morning, everyone. On this Saturday, July 6th, we all have gathered for Maharashtra IIP midterm CM in Nashicon 2024 8th edition at Hotel Expresses.
Suprabhat.
Suswagatam.
Namaskar. On this Saturday, July the 6th, we all have gathered for Maharashtra IIP Midterm CME Nashicon 2024 8th edition conference at Hotel Express Inn. I, Dr. Sharayu Rane,
I am Dr. Kalyani Patil. On behalf of Nashik IIP, we welcome you all for this grand event, Nashicon 2024 8th edition. This year, it is our privilege that Maharashtra Midterm CME has joined hands with Nashicon 2024.
it is truly an honor to stand before you today. We gather to exchange knowledge, insights, and advancements in this field of pediatrics. A very warm welcome to my esteemed teachers, guides, seniors, guests, and colleague friends for this academic feast. We are delighted to welcome you all to our Nashik city.
You all have come here at perfect season of monsoon when the mornings are misty and surroundings are lush green along with fragrance of moist soil and clean waterfalls around ghats.
We appreciate your sincerity to learn, which has made you to come for this academic feast instead of enjoying the short treks in heavenly weather. Our esteemed speakers and experts have traveled from far and wide, bringing with them a wealth of expertise and commitment to improving child health. We encourage each of you to actively participate, engage in discussions, and forge connections that will strengthen our collective ability to provide the best possible care to our innocent souls.
Thank you all. Without wasting much of our time, we will now announce the commencement of our first day of Maharashtra Midterm CME of IIP Nashik 2024 Nashicon.
To start our first topic of the session, when you are dizzy, don't be fuzzy. I would like to invite respected Dr. Atul Kulkarni sir, Dr. Bela Verma ma'am, Dr. Renu Boralkar ma'am, and Dr. Sanjay Deshmukh to come on stage and chair the session.
Good morning to all and welcome to the nice and pleasant morning at Nasik. Today morning we have very important topic, that is the syncope. When you are dizzy, don't be fizzy. We are talking about the syncope. What exactly? This is the very important topic, and I can say it is a neglected, though neglected, but very important topic. Once in a while we may get the patient with the syncope, and recently we have a news in the Nasik that 6th standard school has fainted in the school and unfortunately succumbed to the death. So we should be very careful in evaluating the syncope patient. Next slide. Okay, what does the exact meaning of the syncope? It is to interrupt, cutting up, or sudden loss of strength. That is the exact meaning of the syncope word. It can be the first and the last symptom which has been presented to you. So death can occur in just a first episode of syncope. So you should be very careful. So what is the definition of the syncope? It is the sudden transient loss of consciousness with the loss of postural tone due to the impaired cerebral perfusion. So 4 things are very important. It is a sudden transient loss of consciousness along with the postural tone, and it has secondary to the impaired cerebral perfusion. Classification or the causes, if we look into the causes of the syncope, it will be broadly divided into the 3 classes: reflex, orthostatic or the vascular, and the cardiac. So we will talk more about the cardiac syncope. First is the non-cardiac, which includes the reflex or neurally mediated, and orthostatic or vascular, and second is the cardiac. So among cardiac, most common causes will be the arrhythmias and the structural diseases. So reflex syncope, it has varied etiology and many hypotheses has been presented why it occurs. But basically it is a response of the autonomic nervous system to the normal stimuli. It is an abnormal response of the ANS to the normal stimuli, and that is why the abnormal, the decreased cerebral perfusion occurs and the syncope will occur. So vasovagal, we know most of the times it is the most common type of syncope, vasovagal. It can occur due to the emotional stressful conditions. So emotional conditions, sudden outburst of the emotion, patient may have the syncope, which is the very common. Then again the stressful condition, somebody is performing on the stage, on the first side got stressed, he or she may have the syncope, prolonged standing or the sight of the blood. These are the most common presentations of the syncope, vasovagal it can be. Then situational, it can be the post-micturition, post-deglutition, post-cough or post-defecation also, it can be seen. Then carotid hypersensitivity. Orthostatic is similar to the first occurs the orthostatic hypotension and second is the orthostatic syncope. So what exactly happens during the standing, normal standing response? During the standing, there will be the pooling of the blood to the legs and abdominal vessels, which will cause the decrease in the preload to the heart. If the preload is decreased, cardiac output will decrease, hence the blood pressure will be the decrease. So what will happen? Baroreceptors will send the signals from the carotid sinus, baroreceptors will send the signal to the central nervous system through the cranial nerves 9 and 10, which will cause the increased sympathetic output and decrease in the parasympathetic output, which will cause the peripheral vasoconstriction and increase in the myocardial contractility and heart rate. So this is the basic normal mechanism. Anything which goes wrong in this basic mechanism will lead to the decreased cerebral perfusion and cause the syncope. Then we are coming to the cardiogenic syncope. So what is the cardiogenic syncope? Here the mechanism is not like the previously, somewhere in this system, it is the mechanism itself lies within the heart. So what it can be? It can be the either arrhythmias, which is problem with the conduction system, or it is the problem with the outflow tract, or the cardiac output is not maintained due to the structural disease of the heart. So usually what will happen in the cardiac syncope? It is the cardiac output is fixed and cardiac output could not rise with the exercise, and that will lead to the syncope. So usual the presentation of the cardiac syncope, it is exertional, or it can occur with some kind of activity. Usually there will not be any kind of prodrome. In the syncope, there will be the usually prodrome or the pre-syncope like symptoms, lightheadedness, fatigue, or some kind of weakness patient may complain. The elder kids may tell you these are the symptoms, and after this they will go into the sudden loss of consciousness, that is the syncope. Then the most important part is the prognosis is worst in case of the cardiac syncope. We may see, what I see usually is out of 10 patients, 1 will have the cardiac syncope, 9 will be the absolutely vasovagal, which may not need to come to me directly. But this one patient, if not picked up on time and not got the diagnosis, and not only the diagnosis, if not treated, he is going to have the devastating effects later on. He may not come to you next time. So arrhythmias, long QT syndrome, tachyarrhythmias, usually the tachyarrhythmias will present with the palpitation rather than syncope, but yes, syncope can occur. Bradyarrhythmias, that is the heart block, which the syncope can be the first presentation. In the bradycardia and the heart block, you will be surprised to know that 3, 4, 5, 6 years, up to 10 years also, we have the patient's first episode of bradycardia, which has been seen by many a times by us, our colleagues, but still bradycardia was not noted. Why? Because our patients are usually cranky, they do not allow for the examination, but make sure in each and every patient you document the heart rate. Likewise, saturation is what we say to be documented in the neonate. Similarly, heart rate has to be documented whoever that comes to you, and it is not the peripheral pulse rate, it is the heart rate with the auscultation. Do not rely on your pulse oximeter monitor. If you want to rely on the monitor, it has to be the ECG monitor, because the pulse oximeter monitor can go erratic in case of the bradycardia or the tachyarrhythmias. So these are the very important points. What it can be the heart block or the sick sinus syndrome. Structural causes, important is the aortic stenosis. What happens in the structural causes? It is the LVOT obstruction, left ventricular outflow tract obstruction, that is the aortic stenosis. Similarly, the hypertrophic cardiomyopathy, this is again a very rare. AS is the most common cause for the syncope. Coarctation, again coarctation will present with the hypertension, giddiness and all that, but again yes, it can present with the syncope. Then severe pulmonary arterial hypertension, again the severe PH, syncope can be the first sign, and we have the patients 4 or 5 years old kids, though rare, but we got the syncope. Patient has been referred to me from the neurologist that the syncope has occurred and auscultation, nothing was there. Got the echo done and it was the PAH. So how does it present? ODP, we know that what is the onset. Onset is the rapid, duration is very brief, and usually how it progresses, it's spontaneous and with the complete recovery. The whole episode lasts for less than 8 to 10 seconds. Within 8 to 10 seconds, everything is okay. Patient is upright and he is conscious and awake. He can have the normal talk. In contrast to the seizures, where the patient will have the prolonged stage of confusion or the sleepiness. So pre-syncope, as I told earlier, it is more common in case of the non-cardiac syncope compared to the cardiac syncope. Then complete episode will last for less than 10 seconds. So cardiac syncope, usually it is exertional and it comes after some kind of activity or exertion depending on the severity of the disease activity which is performed. Again, this is very important. Activity does not mean he has to run for 1 or 2 kilometers. It depends on the how progressive or the how severe is the disease. I still remember one patient, adolescent boy, has been admitted with the fever to some of our senior pediatricians. On auscultation, he got the murmur. He asked for the echo, and parents were talking. We came here for the fever, and why you are talking about the this thing, cardiac and all that things. Diagnosis was aortic stenosis. I got over the phone. I did not see the patient. It was a fever. My first reaction, even if it is severe, risk of infective endocarditis is there. We should wait for some time to get the infection under control. Then I will proceed for the procedure. But when I saw the patient in the evening, the first symptom was syncope. Even on standing, the patient was getting this syncope. It did not took few seconds for me to decide this patient needs urgent balloon aortic valvuloplasty rather than waiting for the infection and infective. If you wait in that case, patient may not be there, may not be able to survive the patient. So what happens in the aortic stenosis? We know that left atrium, the blood comes to the LA from the pulmonary vein, goes to the left ventricle, and then it goes to the aorta. That is what the cardiac output is. So aortic stenosis, this valve, your aortic valve is stenosed. It will not allow the blood to go out, and that is how the cardiac output is decreased. Similarly, it will lead to the hypertrophy and all other sort of problems. So very important in case of AS, we need to get rid of the obstruction as early as possible. So how will you evaluate the syncope patient? History, very important. We know morning time, assembly time, schools will feel dizzy and all that, syncope will be there. So history of food intake or water intake can be the less, and that can be the cause. If you do the examination, again I say heart rate is important, then the pulse rate, and it has to be manual, not to rely on the pulse oximeter monitor for the heart rate. I am not talking about the saturation, I am talking about the heart rate. Not to rely on the pulse oximeter heart rate if it is a bradycardia or the tachycardia. If possible, better to get the ECG done. If not ECG possible, then at least with the leads, document the ECG monitor. Cardiovascular system examination, presence of murmur. If the murmur is present, you have to think of the aortic stenosis. In case of aortic stenosis, where the murmur can be absent, if it is the severe in failure, in that case you will get the low volume pulse, narrow blood pressure and hypotension. If this combination is there, and even if there is no murmur on auscultation, think of aortic stenosis. Do not think that no murmur is there, I will not send this patient for the echo. If you don't send this patient, you will miss it. ECG is mandatory, it is compulsory. You cannot afford to not having ECG in a patient of syncope. If bradycardia, that is the heart rate is less than 55 minutes, 2 minutes more, allowed, 5 minutes more. If bradycardia is there, heart rate is less than 55 per minute, think of heart block. And again I told you, 3, 4, 5, 6, up to 10 years I have seen the syncope first episode and with these heart block patients. Till that time they were doing excellent, and that is what the indication is. Even in the antenatal patients we see the heart block, postnatal also 1, 2, 3 months. We don't do anything if the heart rate is more than 55. You will be surprised, we have patient on follow-up, heart rate of more than 55, grade 3 AV dissociation, still on follow-up, nothing doing. So they do very well unless and until some episode occurs of the heart rate goes below this point. Tachycardia, more than 180, we know SVT. So ECG, what we need to see, just like we know that for the orthopedic surgeons, the circulates on the WhatsApp, upright, operate, something negative, do not operate, if flat, declare. So similarly, ECG, that is, yes, that is a joke, but that is how we should explain the things in a simpler manner. So what ECG is? Very simple. P wave, first upright presentation, then followed by tall wave, that is the R wave, followed by next, after the P, first deflection, negative deflection, Q, then R, then again negative is S, and then again one more positive is T. P, Q, R, S, T. This complex has to be there, each and every lead, and it has to be uniformly present everywhere. If you see this normal ECG, P, Q, R, S, T, P, Q, R, S, T, P, Q, R, S, T. If this is there, it is a normal ECG. We should not get worried about the ECG, or as a pediatrician, I also know, because when I was a pediatrician, I was scared of the ECG, what it looks like. So only this we have to diagnose, P, Q, R, S, T. And then heart rate, usually it will come on the ECG strip, what it is, and we know more than 180 SVT. In a pediatric, more than 220, neonatal it is SVT. So PQRST, don't forget. Then heart block. So now here if you see P waves, here the P is there is QRST, nothing. Here the P is there, here the QRST is there, then again P, nothing is there, after this P, nothing is there. So this is heart block. Forget about the second degree, third degree. If the patient is having the syncope, send to your pediatric cardiologist colleague ECG, he will give you the diagnosis over the phone on the WhatsApp, and you will save the patient. If the heart rate, again heart block, heart rate less than 55, needs the pacemaker. This is again the SVT, narrow complex and heart rate. Just focus on the heart rate, how much is the heart rate. And again in that case, you can see there is no P wave, only in between the tall R waves, only T wave is there. So this is what the normal sinus rhythm. And long QT syndrome, again it can present with the syncope. So what the long QT syndrome is, here this is the first negative deflection is Q, and at the end of the T wave, this is the QT syndrome. So normally, again our newer ECG machines will give you the figure of the how much is the QTC, or the calculation is there, Bazet's formula, and but that is a complicated thing. But in short, how will you recognize this is the R wave, this is the R wave, in between how much the distance? 4 large squares. If the distance of the QT is less than the 2 or half of this RR interval, then it is a normal, in short. So that is how you can diagnose QTC. Then pulmonary arterial hypertension. This is neglected, rare, but still we see, and we have the patients of PAH who has presented with the first episode of syncope and got the PAH. So what exactly happens? Pulmonary arterial bed is constricted like this, which will increase the afterload to the heart. Right ventricle will get enlarged, hypertrophied, and this will cause the obstruction to your outflow. The pressure is increased at this level, so obviously this RV has to pump more blood. It will get hypertrophied, it will push this septum to the LV, into the LV, cardiac output is depleted, and that is how the syncope will occur. I will not go into the details of this all. So DD, seizure, cataplexy. Seizure, as I told, prodrome will be there. Usually rather than prodrome, it will be the visual or auditory disturbances in case of seizure. That is not there in the syncope. In seizure, again, post-ictal confusion or drowsiness or sleep will be there, not in the syncope. So this is very important. I'll take just 30 seconds for these slides. In 1 minute, I'll about to finish. So usually, when to reassure? Usual syncope history, not exertional, no murmur, normal pulse volume, BP, saturation. ECG is normal. This is very important point. ECG, you have to document each and every patient of the syncope. Clinical examination will not give you the diagnosis of long QT syndrome or heart block unless and until you are very keen about the auscultation heart rate. So first episode, everything is okay. Then probably further evaluation is not needed. On your own, you can send the patient home with, if history repeats, you can ask them to come back again. Who needs the more attention or urgent referral? Exertional syncope. The syncope who has the dyspnea at presentation, abnormal ECG. On examination, you got the harsh marrow of the aortic stenosis. Low volume pulse, low BP, and no murmur. That is again, this is the very deadliest combination. You have the severe AS in failure. But of course, you will have another signs. History of congenital heart disease in this patient, any patient with the syncope, or there can be the post-operative, the surgery or the device closure has been performed and the patient is getting the syncope. That is again the urgent referral is required. So evaluation per se, as discussed, clinical exam, ECG, then the echo. Where to ask for the echo? If murmur is there or no murmur and patient is in the another. So treatable, as I told, easily treatable condition, cardiac all causes. Pacemaker, very easily we can do, more than 8 to 10 kg I can do in Nashik easily. This is the prototype. I don't want to show this. This obviously will not present with the syncope, but if we can do the balloon of the aortic stenosis in a small baby, definitely larger babies, it will be easier for us. Coarctation also, this is again the narrowest coarctation, it is near interruption due to the stenting. Again, this is very rare causes, pulmonary arteriovenous malformation, patient is from remote place of the Maharashtra, Vidarbha region, Yavatmal, 2 siblings have been died, and she presented to us with the just syncope, not to us, to the many, and echo is normal. So do not rely on the, okay, I'll just end up here. So pulmonary arteriovenous malformation, device closure has been done. Then this is the recent patient, again referred to me by cardiologist, who had the PAH, and you will get this diagnosis of Abernathy malformation. So these are the rare causes and which will have the impact, treatable causes of PAH. So to summarize, syncope definition, causes, cardiogenic, syncope evaluation, it has to be the cost effective. It is not like that I should ask each and every patient for the pulmonary angiography with the syncope. So it has to be step-wise and cost. These are the do nots for the syncope patient. What we tell us our epilepsy patient, what not to do. So similarly, swimming has to be under observation if at all he is very keen. Bicycle riding, not in the traffic, washroom, bathroom, you should not lock from the inside. So take home message, only one, not to miss the cardiogenic syncope. And important is cardiogenic syncope, 3 points you should remember, that is the PAH. P, pulmonary arterial hypertension, aortic stenosis and heart block. Only 3 causes you should remember. PAH, pulmonary arterial hypertension, aortic stenosis and heart block. That is what we will not discuss about the any of the other things.
Thank you, sir, for such an enlightening talk. Now I would request Lavankar sir and chairpersons to proceed towards felicitation test. For our next session,
yes. Few questions are there. Yes, yes. No, even I also do not have the answer for this. It has been, it is like, yes, it is like the whoever invents, who thinks it. If I invent something, I wish it has to be named after Lalit. It is not. Yeah, so that way you can take it as the rest.
for our next session,
Great sense of humor.
I would like to invite on stage our chairperson, Dr. Jayan Shah, Dr. Mangai Sinha, Dr. Manjusha Sherkar, Dr. Grivita Raikar. We all know, no matter how brilliant your mind or strategy is, if you are playing solo, you are likely to lose. These statements hold so true for pediatric critical care. So to enlighten more about this topic, we have Dr. Lakshmi Bond ma'am with us, who is a renowned pediatric intensivist from Amravati. She will enlighten us with the topic, build up the team, build up the PICU.
Hello. Hello. Pointer. Hello. Shall I? A very good morning to one and all present over here. Myself, Dr. Lakshmi Bond. I am pediatric intensivist from Amravati. For 15 minutes, I am pediatric intensivist from Tier 2 city, Amravati. So my topic is build up the team, build up the PICU. For this 15 minutes, we will be going across the case scenario as patients are our first and foremost great teacher and we are the learner throughout our life. We will be looking for levels of PICU, what is ideal PICU, what reality intensivists are facing, and what every pediatric small healthcare association should have PICU, why it is so, and what do you mean by really the team is. So going across through the case scenario, this is a common scenario which we face daily in our OPD. 2-year-old male child came with a complaint of cough, cold, fever. Since 4 days, consulted in OPD on examination. He had upper cervical significant lymphadenopathy.
After 2 days, same patient came in OPD, child had persistent fever, increased respiratory effort noticed by the pediatrician, and he has been advised hospitalization, blood investigation, and for the chest X-ray. As it was outsourced, X-ray facility was not available, patient went for X-ray and blood investigation had been done after hospitalizing the child. Now the common question is, if your hospital is having the OPD setup with 10 bedded IPT, how much level 1 PICU bed you should have? Do you know this? This is not written anywhere and this is not according to the corporation or by the government law. But you should have 2 to 3 bedded for every 4 IPD bed, 1 HDU or 1 PICU bed should be there. This is our moral responsibility to have it. So what are the levels of PICU care? You know. Level 0, it starts from level 0 to level 4. Level 4 had not been mentioned over here. Level 0, it is a general ward bed only with better monitoring. Every bed should be having pulse oximeter. 1 ECG monitor must be there with a 1:1 or 1:2 nurse patient ratio. This we can do at our IPD setup. In every IPD set we have. Level 1 is the ECG monitoring with a short-term ventilation facility with 1 mechanical ventilator by side. For what we can go for 24 hours backup we have. For level 2, prolonged ventilatory support and a complex invasive monitoring we can do with all the 24-hour facility backup with pediatric surgery we have. And what level 3 is the specialized intensivist round the clock over there with critical care nurses facilities and 24-hour backup. We will be coming across what the level 2 and level 3 where it differentiates. Now, what is the ideal PICU by consensus guideline? It should be located at the acute care area and the fastest access. That means the lift should be there in front of the ICU door. Single entry and exit point should be there with the emergency exit for the fire. This is the norms which has been set. Central air condition with fire extinguishers, sound absorptive surface. Sound should not be exceeding 40 decibel for the day and 20 decibel for the night. And the floor infective prevention and easy equipment moving area. But is this possible in every scenario? No. But what is possible? We must do that. The floor area should be 100 square feet for a bed and a cubicle should be there if it is exceeding more than 12 bedded PICU for separation and isolation. One patient should be having 2 to 3 O2 points, 2 suction point, 1 compressed gas outlet, 16 power outlets, and central monitoring area with a direct access. These are the norms which had been set. For the Indian scenario, basic should be there for the second level and a tertiary level PICU. And what size of PICU we should have? Ideally, it should be a 6 to 12 bed PICU. It is desirable, but PICU less than 4 bedded. If you say I will run secondary PICU or tertiary level PICU for 4 bed, it is not feasible money wise because it is ineffective. And more than 16 bed, it is difficult to manage if you want to give quality care. Pediatric ward bed of up to 25, you have 25 bedded hospital, you should have 6 to 8 bed of PICU ideally if you are having a team and if you are upgrading for it. Now these are the consensus guideline of the pediatric intensive care by 2020 by all the stalwarts from India, and we should follow the Indian consensus guideline. And what the PICU setup look like, these are. Now building an ICU with an optimal design, why it is necessary? Because it helps to reduce the medical error, improve the patient's outcome, reduces the length of the stay and obviously reduces the cost of the patient. Now what is the reality? Is it possible in every scenario or at the level 2 city or level 3 tier city? Scenario is different. Here everyone is the boss over here. Now what happens? Pediatric intensivists generally join the preform setup. They are not from the building stage of the ICU. They need to join the other bosses who are practicing over there. And obviously, at the peripheral level, that is the single-handed person who was running whole of the tier. But we, as a pediatrician and pediatric intensivist, should follow him, should have his experience advice also. Preference of the pediatric intensivist is to join the tier 1 and 2 city and corporate sector because of all this, because it is a very costly process and everyone needs an income to support his family. And protocol changes according to every consultant, whosoever is admitting the patient in the PICU. These are the things which is happening. Trained staff is the most common issue everyone is facing in his life. Ego issues in the team. So these are the issues we commonly come across. Now the same child who was admitted at the level 1 PICU, after 3 hours of admission, pediatrician has noticed that he was tapping the tachycardia is there, X-ray done, which was suggestive of this. Will not comment on X-ray at this point. Now what we need to do for every busy practicing pediatrician in his OPD, we should anticipate. Do we have that facilities to keep this child at our level? Or should, if not, safe transport is necessary to level 2 and 3 pediatric ICU? In small private setup, level 2 and 3, if the facilities are available, it is there in provided in one unit only. So what is the basic difference in level 3 and 2? Rooms. For level 3, if you are having level 2 PICU and you want to upgrade for level 3, library is necessary. In monitoring, invasive BP monitoring is necessary for almost 50% of the bed. High frequency oscillatory ventilation is necessary. EEG facility is necessary along with all what I told. Crash cart, obviously, appropriate stock crash cart is necessary. Lab facility for 24-hour service along with lactate and coagulation studies. Supportive services, you should have a MOU or tie up with neurosurgeon, pediatric surgeon, ENT surgeon and all the higher end facilities. And one utmost important thing is CQI, that is quality improvement indicator. And you should follow the severity of illness scoring system for PRISM and PIM. So level 3 care, if you are having admissions more than 200 in PICU, you are having 4 to 6 ventilator, pediatric intensivist is heading the unit, pediatrician with a postgraduate training program is going on, minimum one-on-one nursing on ventilated patient, high level of monitoring capability in all patient. If all these facilities are available, then we are at a level 3 and we should upgrade above that also. Now what is the modern medical team is consisting on nowadays? Patient is looking for where is a doctor and where is a nurse. This is the scenario in corporate sector. We are far from this now still. But what organization and staffing now is necessary to build up the PICU? It is a medical director, whosoever it is, not necessarily always a pediatric intensivist is a medical director and intensivist in charge. He should by the side. Staffing requirement, medical staff and nursing staff. This is utmost important, but ancillary support services is also that much important, right from the IABI to the OT technician, from the X-ray technician. Everyone should be having simulation training program routinely. Now work profile for intensivists, it doesn't limit to managing the pediatric intensive care only. It is establishing the policies and protocols for your ICU. Follow your ICU protocols. Admission and discharge criteria should be followed. Quality assurance and continuous quality improvement program should be followed. Maintaining the PICU statistics of mortality and morbidity, hospital infection control, and nursing staff. One pediatric ICU trained nurse for one ventilated patient, 1:1 ratio. Very unstable patient, you may require 2:1 ratio. And if the patient is stable, post-operative, 3:1 ratio you can have at your. Now you have taken care of, right, again going to the scenario, taken care of EBC at your level 1 PICU, child had bradycardia, episode of desaturation. Do you have RRT team, medical emergency team at your hospital? Your small hospital can also have it because it is necessary. Cardiopulmonary arrests that occur outside the critical care unit in pediatric hospital, it has a poor survival rate. So if your hospital is 10 bedded also, prepare a RRT team or a medical emergency team. And survival rate, not this at this level, at tertiary care level also, cardiac arrest following the pediatric in the hospital during nights and weekends are more. This is the publication. Now, what is a med team? Team who brings critical care expertise at a bedside. Always remember, it is necessary. What is the goal? Identify the unstable patient. Not resuscitation is the goal. Preliminary identifying the unstable patient is the goal of MET team. Now, child required intubation and mechanical ventilatory support. He has been referred safe by the God's grace to level 2 and 3 PICU. Now, what is there? Only Rohit Sharma and Virat Kohli cannot bring you reward, for sure. Only intensivist and director cannot do this. Unpredictability of the clinical event of death and emotion, grief and guilt is there. You need to take care of that also for your staff. Ethical dilemmas are there. Fear of litigation, what parents are going to claim. Now, together everyone achieves the more. That is what the team is. Learning involves understanding why things happen and why some decision led to this specific outcome. Now, same child at level 3 PICU, bedside 2D echo was suggestive of pericardial effusion, worsened chest X-ray within the 6 hours of hospitalization. He reached tertiary level. Still, this was the scenario. So bedside echo was there and bedside USG was there. So lung USG, which was showing of massive pleural effusion, it is not a clear fluid if you see, and this was a normal lung for comparison. Now pleural fluid tap has been done. It was hemorrhagic and ICD has been inserted. HRCT was done, suggestive of mediastinal mass. Simple patient had turned up into devastating case. Now what here is required is pericardial effusion with mediastinal mass, parents and relative, nursing staff and intensivist, cardiologist, hematoncologist, oncosurgeon. So we are leveling up from level 0 to level 4. The only persistent team member over here is the parents of a sick child in a PICU. The only persistent team member they are. They have the highest interest in a good outcome and they are the primary source of information that we forget in our all this management. So learning while working, if you are at a tertiary level, you should upgrade yourself and should learn bedside USG also. For nowadays it is necessary. For patient safety, 16% of hospitalized patients, developed countries have adverse event. So always a stimulation workshop for every 15 days. Now, creating a culture of respect, improving the interprofessional communication and building the flat hierarchies is the need of an era to work out smoothly. And you should have one center of excellence to whom you are tied up with. That identified center of excellence will be technical hand-holding to the other ICUs. So team is not only the group of people working together like this. It should be like this, that effective team, it is a group of individuals more committed to the team outcome than the individual performance. This is the need of an era, what we need today. And what take-home message we have is 11 players are needed and it is necessary to have a reward. Only Virat Kohli and Rohit cannot bring you the reward, so that the intensivist and only the director cannot bring you the reward. Consistency, discipline in your life and zeal to learn the new things is the key to success. Do not underestimate the new player. They have the generation gap. They are having the new knowledge. Combine with them, collaborate with them. Parents are your mentors. So listen to them. Do not neglect them. Identify the center of excellence around you. And moral responsibility of every pediatric player to build up the PICU, start from the level 0 and upgrade yourself to level 2. Combine with your team. Thank you.
Thank you, ma'am, for this enlightening session. Now I request the chairperson and Dr. Lakshmi Bond, ma'am, to proceed towards felicitation desk. Now I invite respected Dr. Vinayak Patki, Dr. Ripa Agrawal, Dr. Kaustubh Deshmukh, and Dr. Anup Chaudhary as chairperson for the next topic. COVID has brought pulse oximeter in every home, and now it's time to use this pulse oximeter in our practice to screen all newborns. To elaborate this topic, I call upon a very renowned speaker who does not need a special introduction, Dr. Sanjay Ahir sir, the first neonatologist in North Maharashtra and current Maharashtra NNF president. He has recently broken his own record by successfully discharging a healthy baby of birth weight of 490 grams. I invite Dr. Sanjay Ahir sir for his talk on pulse oximetry screening of critical congenital heart disease.
करो टच नहीं करना ठीक है हेलो ये ऑफ है, ठीक है. So good morning everyone. Can I request the people to come inside? Can we request those who have finished their breakfast, they can join us. So good morning to all who are present in the hall. I'm going to discuss very important topic. Change नहीं हो रहा है यहाँ से. So I'm going to discuss the role of pulse oximetry screening to diagnose critical congenital heart disease. So may I ask you, how many of you practicing this SpO2 screening in all babies before going discharge? 1, 2, 3, 4, 5. Okay, so I think you will get some important message from my talk today, and I hope after finishing this Nashicon, at least you will implement this practice in your day-to-day NICU practice or obstetric calls. So, so I'm going to start my presentation with a case which we received 15 days back from Dhule. So this was a term male baby born by vaginal delivery. His weight was 3 kilo. And as I said, he was born in Dhule. Delivery was uneventful. His neonatal period was uneventful. Baby stayed with mother. He never required any NICU admission. And he went home on day 3. On day 7, he presented with tachypnea. He was looking dusky and not accepting feeds. He presented in very severe shock. His ABG was showing pH of 6.9, his bicarb was only 4, his base excess was 21 minus and lactate 12. So what could be the differential diagnosis in this case? Okay, so that could be one. Anything else? Because that is my topic, so that will be the first diagnosis. What else? So when we practice in NICU, first thing comes in mind is, could be sepsis with shock. Then it could be inborn error of metabolism, because classical presentation after 3 days, and as Tarun said, it could be duct dependent congenital heart disease presenting in cardiogenic shock. So Lalit was involved in this, and 2D echo color Doppler was done, and it was critical pulmonary stenosis with intact ventricular septum. There was a tiny PDA which was about to close. There was right to left shunting through the PDA. And baby was in biventricular dysfunction. That's why his pH was 6.9, his lactate was 12. So prostaglandin was immediately started, but baby went into apnea, so we have to intubate the baby. And baby was transferred to Mumbai for further care, and he got operated, and now he's doing well. So what went wrong in this patient? So there was no screening done for critical congenital heart disease before this baby goes home. So our routine practice, at least we check the femoral pulses, but now we can do SpO2 saturation monitoring or screening in these babies, so that we can screen them whether this baby needs any further evaluation or not. So it could have prevented sudden deterioration after closure of his PDA. So approximately 20 out of 10,000 babies are born with critical congenital heart disease. And when these babies with undiagnosed congenital heart disease go home without any intervention or screening, they might have very serious problems such as cardiac failure, shock, or death within few days or weeks when they are at home. If a critical congenital heart disease is diagnosed before the baby leaves hospital, can be treated to prevent later health problems or even death. So approximately 20 out of every 10,000 babies are born with congenital heart disease. If a critical heart disease is diagnosed before baby goes home, it can be prevented further problems, and mandated critical congenital heart disease screening using pulse oximetry reduces early infant deaths from critical CHD by 33%. So that's very, very huge number. So how common is critical congenital heart disease or cyanotic congenital heart disease? So 1% of all newborn babies have congenital heart defects. About 20 per 10,000 are born with critical heart disease. And delayed diagnosis can have poor preoperative condition and worse cardiopulmonary and neurological outcomes after even if they get treatment. So it is very important to hand over a stable baby to a pediatric cardiologist and cardiac surgeon. So which babies need to be screened? So each and every baby who is not antenatally diagnosed with congenital heart disease should be screened for congenital heart disease. So all newborns at risk for undetected CCHD should be screened. When to do the screening? Screening should begin after 24 hours of life or shortly after discharge if 24 hours, baby goes home before 24 hours of age. Sorry, shortly before going home. So where to check the saturation? So always use right hand and either of the foot. So which cardiac conditions are detected? So commonest ones are coarctation, double outlet right ventricle, Epstein's anomaly, hypoplastic left heart syndrome, interrupted aortic arch, pulmonary atresia, single ventricle, tetralogy, and total anomalous pulmonary venous return. Some non-cardiac conditions can also be diagnosed like hemoglobinopathy, hypothermia, infection, including sepsis, and other hypoxemic conditions not otherwise specified. So we have this algorithm published by American Academy of Pediatrics, which was revised many times, and now we have this final algorithm published in Pediatrics 2020. So first measurement, SpO2 on the right hand and 1 foot around 24 hours of age. So if saturation is more than 95% in right hand and one of the foot, and a difference between upper and lower limb is less than 3%, that means the screening is passed. So do not repeat pulse oximetry. Provide normal newborn care to this baby. If the saturation is less than 89% in right hand or foot, then the screening is failed. So do not repeat pulse oximetry screening. Refer this baby for complete cardiac assessment to a cardiologist. If your saturation is between 90 to 94 in right hand or a foot, or the preductal postductal difference is more than 4%, then you have to do the retest. So you have to wait for another 1 hour, let the baby stabilize for 1 hour, and then repeat the pulse oximetry after 1 hour. After 1 hour, when you do the pulse oximetry screening, if saturation is less than 94% in right hand or foot, or the difference is more than 4%, that means the screening is now failed. So do not repeat pulse oximetry screening again, refer for cardiac assessment. If your saturation is more than 95% in right hand or foot and difference of less than 3% on the second occasion, then do not repeat the pulse oximetry screening again, provide normal newborn care. So what is the sensitivity? So sensitivity to diagnose critical pulmonary stenosis, transposition of great arteries, hypoplastic left heart syndrome, pulmonary atresia, single ventricle, total TAPVC, and truncus arteriosus is more than 80%. So more than 80% babies can be diagnosed simply by this pulse oximetry screening. Sensitivity between 60 to 80% in critical aortic stenosis, double outlet right ventricle, and tricuspid atresia, and low sensitivity in coarctation of the aorta, Epstein's anomaly, interrupted aortic arch, and tetralogy of Fallers. So these are the countries where it is national guideline. So if you see mainly North America and some part of the South America, China, and many European countries, they have their national guidelines. So you have to do it compulsory. In India, it is still, we are having multi-center studies and pilot programs, but I think it is the right time for NNF and IAP to make it compulsory to do newborn screening, along with whatever in newborn screening we do for inborn error of metabolism. This screening is very, very important so that we can diagnose these babies early stages and they can do better after surgery or interventions. So again, to summarize this, this is the algorithm we have already discussed. So approximately 20 out of every 10,000 babies are born with congenital cyanotic heart disease, and mandated critical congenital heart disease screening using pulse oximetry reduces early infant deaths from critical CSD by 33%. And delayed diagnosis may result in child having poor preoperative conditions and worse cardiopulmonary and neurological outcomes after treatment. So sensitivity of this screening is more than 80% in detecting conditions like critical pulmonary stenosis, hypoplastic left heart, and TAPVC. These are the common conditions which we see in early neonatal period. And as I said, it should be a universal practice in our country. So wherever we go for our obstetric calls, we should carry a pulse oximeter and do screening of these babies, because it takes hardly 5 to 10 minutes to screen a baby, so that we can, because in last one and a half year, we have diagnosed one baby with critical pulmonary stenosis, one baby with TGA, and those babies got operated and doing very well. So I think that is very, very important message from this Nashicon. Whenever you go back, you should start doing pulse oximetry screening in newborn babies. Thank you.
Thank you, Ahir sir, for such a important talk. I would request sir to please proceed towards felicitation desk. For our next session, I would like to invite Dr. Praveen Gokhale, Dr. Vikas More, Dr. Sanjay Pakmode, Dr. Suresh Bhattad sir as a chairperson. Headache itself is a huge headache, not only for those who are perceiving it, but also for the one who addresses it. To enlighten us and to clear our concepts about headache, we have Dr. Amit Watkar sir with us, who is eminent pediatric neurologist. He has been faculty at various pediatric conferences and has
Hello.
publications and book chapters. Sir, stage is yours.
So good morning. I thank the organizers.
I would like to request Dr. Chopra sir and Dr. Rahul Patil sir to chair this session. Chopra sir and Rahul Patil sir.
So good morning. I would like to thank the organizers for providing me this opportunity. What I would try and do my best is, by the end of the session, everyone should get an idea at least to differentiate between the primary and secondary headache and recognize common primary headaches and try and manage it. So headache is, as we say, it's not just an adolescent or adult disease. Lots of children get it. Even a 4-year-old, 6-year-old children do get it, and it is very common, especially with the changing lifestyle that we are facing today. So almost 70% of school children have an episode of headache. It's peaked around 12, 13 years of age. Subsequently, it gets on increasing, but after the adolescent, it again starts dropping. So prevalence of recurrent headache is almost 20 to 30%. These are the cases which come to us most of the time. So I will try to discuss it case-wise. So a 12-year-old girl with frontal headache down the neck and shoulders for 2 months. Started as soon as she rises from the bed and relieves by lying down. So this is a common thing what we get, that most of the children don't want to go to school. They get up, no, I am feeling headache, they try to sleep. But she is missing school for almost 6 weeks. So whenever a child misses school for a longer period of time, because nowadays children do like go to school, especially they don't try to remain absent for such a long time, because there are not just studies, there are friends, there are plays, and there are various other things that take place in the school. So whether it is primary or secondary, so what I would like to stress that whenever there is a specific factor, whenever there is a postural change, or whenever it is related to a setup, you should always think of secondary sort of headaches. So this child had meningitis 3 months back, CSF examination was done. Subsequently, she was treated, discharged, her examination is normal, everything is normal. But what I would like to bring to your attention that most common headaches which we get in our OPD are benign causes. So post-viral illness, post-sinusitis, migraine, post-traumatic streptococcal throat and tension headache. So these are the most common types of headaches. So in the previous case, the CSF test which was done, once the dura is punctured, it is punctured. So it's not that all the duras get sealed. So you have to be very careful while doing a lumbar puncture, the way you insert the needle, because wrong insertion of a needle can cause the dural puncture, which can result in CSF leak for prolonged period and can result in headaches even later on. Usually this type of headaches resolve within 3 to 4 months. You have to encourage good hydration in such type of cases. Sometimes acetazolamide works because it reduces the CSF secretion, in turn reduces the leak. And if it is persistent for a longer period of time and there is a definite history of a CSF puncture or CSF leak, then you should do an epidural patch, which helps in most of the cases. So next, primary versus secondary. So 20% of headache that we see are usually secondary in nature, but 80% of them are primary headaches. Primary headaches means they have no other cause. It's just primarily the neurological thing that is causing the headache. So secondary types of headache, like whenever there is an altered intracranial pressure, raised or low, whenever it is related to any vascular things, atriovascular malformation or dissection or vasculitis, drugs. So whenever the drugs are taken for almost more than 10 to 15 days in a month, it can cause rebound headaches, and the drugs can itself be a cause of headache. Local abscesses, like dental abscess, sinusitis, or post-head injury. Post-head injury headaches can start almost up till 2 to 3 months after the injury. And central thalamic or trigeminal neuralgias, which can take place in few children, though rare. So how to identify secondary headache? The most important thing is setting, history. In what setting the head he is getting headaches. So those headaches which are in the same setting are usually secondary. On examination, so if you get hypertension, on examination if you get capsular spots, so you should try and do examination to find out. So most of the secondary headaches will have some examination findings. And last is brain imaging, in which cases when you strongly suspect that there is some specific pattern of a headache, brain imaging can help you in this. So indication that headache is secondary to increased pressure. One is timing of the headache. As I mentioned in the previous girl, it was in the morning, postural maneuver and associated symptoms. So whenever it is in the morning from the sleep before rising, so the child is just not able to get up but relieves as he gets up, coughing and straining exacerbates it. So there is a Valsalva maneuver that causes increase in intracranial pressure, and there can be associated confusion. So this is usually related to raised intracranial pressure. Usually in the morning, but after getting up, in the lying down, the patient feels better. Even such type of headaches are frontal. They are usually associated with pain and paresthesia across shoulders, so they can be low pressure headache. Hydration is very necessary. Most of the children, usually those who drink less water or usually are more athletic, do less of exercises. In these cases, sometimes the water intake is quite less, and these children can have a routine sort of thing, headaches getting in the morning. What one should see that they always get up in the night and drink some water. So drinking water helps in relieving this type of headaches frequently. So 16-year-old girl was seen in OPD, frontal headache, there when she wakes up, but better when she gets up. So no nausea, no neurological symptoms, 4 months, not getting any worse. So as I mentioned, there is again a frontal sort of headache. On further examination, you found that there are enlarged blind spots. So the diagnosis in this is quite obvious. When you find that there are enlarged blind spots, you come to know that this is secondary to raised intracranial pressure. So raised intracranial pressure, idiopathic, does not have any underlying cause. Usually in adults and girls, you should always try and elicit a history of any drugs or any steroid withdrawal. Vision loss can be in 10% of cases. In such type of cases, we need to treat them with medications, because the vision loss is one thing that is permanent. So you should try and give medications that will reduce the intracranial pressure. And imaging is must in such type of cases to find what is the underlying cause. Sometimes sinus thrombosis can be a cause for this. Sometimes there can be vasculitis that is the cause for this. So what are the other causes of raised intracranial pressure? Hydrocephalus, tumor obstructing or obstructive to CSF reabsorption like post-hemorrhage or meningitis which was there in past. It can be congenital, mild one which is not detected even till late stages. There can be cerebral edema, secondary to inflammation, infection, metabolic, CO2 retention, or it can be idiopathic. So 14-year-old girl headache since the evening before. So this was first and the worst headache in her life. So she never had previous any history of headache. So just his headache started and she's all crying and all over the house. Sudden onset vomiting started at once. So this is a very obvious case which we may find most of the time. And the first thing comes to mind that whenever it is the worst headache, the child is just not controlled to it. We have to intervene something in it. And on further examination, unilateral facial weakness with frontal spurring, ipsilateral arm weakness with hyporeflexia. In such cases, we should always think that there is some intracranial pathology. You go for imaging and you find a stroke. So the indications for neuroimaging. So there was a recent guidelines which were consensus guidelines released by IAP, which have in detail given the management of headache. So they have mentioned that in case of SNOPy, so they have given a mnemonic. So whenever there are systemic signs and symptoms like vertigo, vomiting, there are neurological symptoms like weakness or diplopia or nystagmus. Whenever it is sudden onset, occipital in location. So occipital migraines are usually not there. Occipital headaches are usually not there because occipital area is quite a vascular area. So whenever you get anything occipital headache, you have to suspect some intracranial pathology. And whenever there is a previous headache history with new, worse or different character, like progressive nature or precipitated by Valsalva maneuver, postural component, in age less than 6 years, because less than 6 years children cannot specify what sort of headache is there, what they are exactly feeling. So there can be varied symptoms in less than 6 years. So it's very difficult to diagnose them. So we may require a neuroimaging. In short, any headache that is severe enough to wake either the doctor or the patient from the sleep should be neuroimaged. So most of the headaches, migraine, primary, usually don't disturb sleep. So if the child goes to sleep, he feels comfortable. Child gets up from the sleep, he feels comfortable. But those headaches which disturb the sleep should have a neuroimaging. So single first severe headache, suspect bleed. Severe headache all day for 12 days, bleed. Headaches over a few months, now it is getting worse, tumor. Recurrent headaches over a month, migraine. Headaches almost all the days, tension type headaches in which you need to do more of a behavior therapy rather than medications. So support your clinical impression, rule out other differential secondary causes of headache and familial expectations. So conscious level, blood pressure, vision acuity, extraocular movements, long track signs, cerebellar signs, and fundus. Never miss the fundus. So 8-year-old boy with 10-month history of bitemporal headache, throbbing, worse with movement and exercise. Mother says look pale and unwell, usually start in the morning, last all the day. No family history, examination is normal, so usually seems like a primary sort of headache. So this is migraine without aura. In children, usually aura is not there. As you grow to an adolescent, aura becomes more vivid and more pronounced. So migraine is a neurovascular process. So initially what it was thought just to be a vascular thing, now it is said that there is a neural thing, increased cortical hypersensitivity, which further spreads, and then comes the vascular vasoconstriction and dilatation, which complicates the process. So before the vasoconstriction and dilatation comes in, you have to take a medication which helps in early relief of the migraine. So aura typically what they say in case of migraine is lines or abstract. In case of epilepsies, it is formed figures. So in case of occipital epilepsy, you get formed figures. But in migraine, you can get spots or you can get just lines, colorful or black and white. So sinus, usually in the center towards the sinus, tension, bifrontal, migraine. Usually there is a unilateral or a focal sign. It can be either left or right, never only left or never only right. And cluster is usually related to eye. Cluster headaches are less common in children. So at least 5 attacks should fulfill this. Headache lasts for 2 to 72 hours. If the child sleeps after the headache, that sleep should be considered as a part of headache. So it's from normal to normal, the duration. So headache should be either bilateral or unilateral, pulsating, you feel like something is hammering in your brain, moderate to severe pain intensity aggravated by causing means routine activity the child does not feel to do. There can be either nausea or vomiting, more of nausea rather than vomiting, and there can be either photophobia or phonophobia. So the child doesn't like to sit in class, or the child feels that the sound is too much, he doesn't like to see, he likes to go in a dark room. So often a positive family history, aura in 15 to 40% of patients, and it is a characteristic pattern. So it can be further classified as migraine without aura, with aura, basilar, ophthalmoplegic, even alternating hemiplegia is a type of migraine. In this case, rather than fighting hemiplegia, you should try and migraine medications which helps. So in children there are variants, abdominal migraine, where there may not be headache, it will be just vomiting and nausea. They get up in the night, vomit, sleep, tomorrow morning, all normal. They can get these episodes several times a month or once in 2 to 3 months. There can be cyclical vomiting, benign paroxysmal vertigo, or benign paroxysmal torticollis. In this case, migraine medications work better than the medications which are related to vertigo or torticollis. So migraine diagnosis is clinical one, family history helps. Migraine usually lasts for a longer period. Normal examination, and then we should try and convince them that, well, this is not something bad if it is quite recurrent. So explain it is not a tumor, explain it is worst usually in the second decade of the life, but afterwards it will start decreasing. Most patients get fever headaches as they grow older. So induce sleep, avoid precipitating factors, avoid opioids, abortive medications to abort severe migraines, preventive medications to avoid migraine in total, and lifestyle changes. So primary first drug which can act is brufen or acetaminophen. Naproxen acts for a longer period. It doesn't usually have a rebound sort of sensation, so naproxen is also preferred in some cases. But in smaller children, PCM brufen works well. So prevention, you should always think of smart sleep. Sleep is very necessary. What I always say my patients, in the night there is a servicing of the brain that is going on. So if you give good time for servicing of the brain will not make any sound and it will run smoothly. So you should sleep before 10, get up after 6. So that's the standard what I say. Meal should be regular. Every 4 hours you should eat something. Maybe it is half apple or half rice or half chapati. Whatever is possible, you should try and eat something 4 to 6 hourly. Activity is necessary. Half an hour jogging, half an hour meditation. Relaxation techniques, trigger avoidance. So avoid anything that is in packet or bottle. So no magic bullet, valproic acid has been tried, topiramate has been tried, propranolol has been tried. Cyproheptadine usually in those cases where it's not per se much of headache and more of abdominal complaints. Amitriptyline works almost best in tension type headaches also, in migraines also. Flunarin, nighttime dose, start with 5, if not relieved, increase it to 10. Second line triptans, usually above 6 years, only rizatriptan has been sanctioned. It is available as a sublingual mint flavored slip which can be kept under the tongue. But I have found quite efficacious with brufen, and paracetamol works almost the same. So I would skip this case for the want of time. So key points, most headaches have benign cause, but you have to do your examination properly. Remember uncommon and serious causes where there can be any tumor or where there can be any which will disturb your sleep. Address the temporal pattern, always get temperature and BP reading. In children, it can be just hypertension that can cause headache in few cases, and there may be no other symptom other than increased blood pressure in these cases. So do a complete neurological examination including fundus. Only patients with abnormal neurological examination and findings and disturbing your sleep should get an CT or a MRI done. Thank you.
Thank you, sir, for decreasing our headache of treating headache in children. I request respected chairperson to accompany Dr. Amit Vatkar, sir, to felicitation desk. Nashicon has arranged fitness challenge for all the pediatricians. Winners for jumping jack challenge competition in 1 minute in males above 45 years are: first prize goes to Dr. Milind Baradia, sir. Second winner is Dr. Nitin Surana sir. Third winner is Dr. Mahesh Siddeshwar sir. I would like to announce a special award for this challenge, and the award goes to Dr. Manaklal Chopra sir. Now we will move towards to our next topic. I invite respected Dr. Biba Komawar, Dr. Pritesh Devre and Dr. Deepa Joshi to chair this session. Cough with seasonal exacerbation. Is it a routine and frequent URTI or something significant? Let's come together to understand better about asthma from Dr. Parmar Chandane sir, who is Head of Department of Pediatric Respiratory and Sleep Medicine at Wadia Hospital, Mumbai. He is a master trainer of Pulmostar module and a mentor to pulmonology fellows. I request to Dr. Parmar Chandane sir to start the topic.
फोल्डरमधनं ओपन केलं ना तर व्हिडिओ प्ले नाही व्हायची फोल्डरमधनं ना नाही नाही ते फोल्डर नाशिकॉन 24 ओपन कर त्याच्यामधलं PPT ओपन कर ते हां 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 हॅलो Good morning, everyone. Welcome to the one of the most awaited conference of this year, Nashicon 24. I've been always looking at this conference for a long time, and my friends Praveen, Amol Pawar, Milin sir, and our other chairpersons are still awaited. Okay, shall we start? Okay, fine. Thank you for the opportunity, the organizing team. So today I'm going to talk about asthma in pediatrics. Is it underdiagnosed? So when this topic was given to me, I was thinking probably I may be overdiagnosing than underdiagnosing it, because once you know into go in one specialty, you tend to become a one-track mind and you tend to overdiagnose things. But when I was reading or preparing this talk, so there are so many things that are there, and in the practice when the general pediatricians are seeing patients, so how we can miss out these cases, so how it can get underdiagnosed, that is what I'm going to explain in this talk in next half an hour. So हे यूज करायला लागेल. Okay. So for next half an hour, I'm going to talk. The outline of the talk is it really underdiagnosed? So we are going to see some statistics, not many slides, couple of slides. Then we are going to see what are the factors or reasons for underdiagnosis. The third thing that we are going to check is how should we diagnose it correctly. And fourth thing, the last thing that we are going to see, what are the precaution challenges and what should be the roadmap in near future. In between also there are a couple of cases which I have added, so that it should be more of an practical based approach rather than just a theoretical thing. Okay, so the first thing is it really underdiagnosed? Is it really underdiagnosed? Anywhere where there is a problem, once you know that the problem exists, you try to solve the problem. So first thing is, always you should know the problem exists. There is a problem, and once you know that the problem exists, then you can take steps towards addressing that particular problem. Now look at how do we know the problem exists. We'll always look at the statistics that is data available that is worldwide, and we compare that statistics or data in our Indian subcontinent or in India. So looking at the worldwide data, this is the 2019 WHO non-communicable disease document, and in that document they mentioned asthma is underdiagnosed in all income group countries. This is probably one of the disease, because most of the times WHO says that low income or medium income groups, and they'll always India will be there in part of that this thing. So this asthma is one condition, it is underdiagnosed in all income group countries, especially in pediatrics. And this is where they have commented upon mid and low income group countries, where the awareness of the condition, that is the awareness of asthma, as well as the inhalers used for treatment are not available easily in mid and low income group countries. Now, looking at Indian statistics, there is a study which is published in Lancet by our own Dr. Sandeep Salvi. I'm sure many of you must be knowing Sir. Sir is associated with Chest Research Foundation based in Pune. And they have mentioned that 46% of asthma deaths worldwide, of the total deaths, 46% happen in India. So that is a huge number. So almost like 50%, half of the asthma deaths happening worldwide, 50% of 46% of them are happening in India itself. And what is the main reason? This is Dr. Sandeep Salvi who has contributed to that article. Probably he is the lead author in that article. So what he says, the main reason for the deaths is, the most important is the underdiagnosis. Because these children get diagnosed very late. And probably by that time, the significant airway modeling or remodeling, what we can say, already has happened. So what are the reasons why the asthma is underdiagnosed? So there are multiple reasons. First, we will try to blame it on the disease. Okay, so the disease itself is a problem. Okay, so heterogeneous disorder can have variety of presentations. So some children can come with only cough, some children will come with breathlessness, some children with chest tightness, and some of them may have some other associated symptoms also. But because it's a heterogeneous disorder and have different presentations at different ages, different perception at different ages, as well as these symptoms vary in intensity, as well as the symptoms vary in presentation over time. That is why it makes it difficult for common people or even doctors to understand the disease per se and to diagnose it. Next is awareness amongst doctors, that is healthcare workers, as well as parents. Many times we talk about asthma in a lot of conferences, but how many times you have done a conference for uh, parents? Okay, we create awareness among healthcare workers. Probably there are a lot of material available for healthcare workers and they have resources available for us. But how many times we have done community camps to make awareness, about asthma? We are not done many times. Next thing is denial by parents. Most of the times the fear that the parents have in their mind, as well as the doctors when they make the diagnosis, asthma, we call it as dama in Marathi. So when we make that diagnosis, most of the times, either it becomes difficult for the doctor to put that diagnosis upfrontly, or many times the parents don't accept the diagnosis. So there is always a denial in their minds. And last but not the least is the scarcity of testing methods. So when we want to diagnose any particular disease, we may have a lot of CTs and MRI in all the centers, but I don't think, hardly handful of people in Nashik must be doing PFTs and all these things. So if you count, there must be at least 10-15 MRI centers in Nashik, but I'm sure hardly 10-15 pediatricians must be doing PFTs in Nashik. So that is and it's not very costly. You can buy 10,000 PFT machines with single MRI machine or more than that also. Okay, so now coming to the disease complex, as I already mentioned, this is a heterogeneous disorder. What is it by heterogeneous? Because when we don't know what is happening, we call it as heterogeneous. So it means that it is basically, there are a lot of symptom complex which are generated by different inflammations because of different cytokines that is bodies producing. So it's basically a chronic inflammatory disease of the airways, characterized by cough, shortness of breath, chest tightness, and sometimes wheeze. Wheeze, when I say sometimes, if you auscultate, it is most of times there. But when I say wheeze, because it is a symptom, when I'm telling you, it is a symptom when presents, it has to be severe enough, the wheeze has to be severe enough to be audible externally. Okay. Some patients can say, CT jaisa आवाज आता है, but that is generally perceived by children who are beyond 8-10 years. These symptoms vary over the time and in intensity. What does that mean? Means the same child can present with cough multiple times, breathlessness, chest tightness and wheezing. So intensity also varies over a period of time. So same child this time may come with only cough, next time may come with severe breathlessness, may require hospitalization. And it is characterized by, this is a feature which needs to be demonstrated by doing testing. It is characterized by a variable expiratory airflow limitation. So what does that mean? It means that there is a significant bronchoconstriction which we need to demonstrate by performing some form of lung function test. So this is a symptom complex, and this is a in total information about asthma, and because this is such a heterogeneous picture, many times it becomes difficult for common pediatricians regularly to diagnose this. Now another thing is, there's something called as iceberg phenomenon. Okay, most of the times, most of the diseases have iceberg phenomenon. It ranges from hypertension to asthma to multiple diseases. So for respiratory, asthma is also having an iceberg phenomenon. What does mean by iceberg phenomenon? Means we see a very handful cases, and most of the cases get missed or maybe diagnosed differently or maybe treated differently, maybe given multiple over the counter medications. Why does it happen? So when the asthma starts, basically if you see the asthma starts, it starts very early, and it is characterized by sensitization of the airways to some form of dust mites or pollens, which creates some inflammation. Once the inflammation is started, the child will have symptoms, but the symptoms are sometimes random. Okay, sometimes they will have exercise or activity induced symptoms, something like cough, secondary to laughing. When the child is laughing, mother complains, जब भी हंसते रहता है तो खांसी आता है या भागता है तो खांसी आता है, which gradually progress to become a nocturnal cough, later on becomes persistent cough, and then maybe later on over a period of time can develop breathlessness. So because what happens now, the initial two-thirds of the picture, if you see, gets missed off, gets labeled as, many times we ourselves use terms like hyperreactive airway disease, Waldry, viral wheeze, and that's why many times underdiagnosis happens. So infrequent symptoms, next is seasonal symptoms, nocturnal symptoms, and when persistent symptoms present or breathlessness present, we diagnose them as asthma. So it takes very long time for asthma to get diagnosed. So before this, below the red line, most of the times the asthma doesn't get diagnosed. So creating awareness about the disease, we need to do that in parents as well as in health workers. Uh, why the underdiagnosis happens in common public? If you see, perception about the disease by the parents as well as perception about the symptoms by the kids is different. And there is something called as, we in COVID we used to define something called as happy hypoxia. In asthma also there is called as happy dyspnea. These children may be dyspneic, breathless, but they are happy, and because they are happy, they are running around. So parents feel that there is nothing. Okay. Fear of diagnosis and denial. Many times the parents know that the child probably is asthmatic, but they are in a denial mode. It takes a lot of communication, counseling, and many times incorrect or incomplete information that is offered to the parents, because uh, there are so many things available over the social media, as well as so many relatives offer so many things. Always they are being incompletely or incorrectly informed about the disease. Healthcare workers, the reason that they are not aware about the disease is basically inadequate knowledge. Second thing may be fear of losing patients. We don't label these patients upfrontly as asthma, and we many times, give a diagnosis around the asthma, but don't, many times we give them a diagnosis of allergic bronchitis, Waldry, HRAD, or something like that. We never put directly our finger on diagnosis of asthma, because we fear that probably the moment we put a diagnosis of asthma, patient will run off to some other pediatrician. And many times we ourselves are underconfident in labeling that particular child as an asthmatic child. So coming to the diagnosis, how we should diagnose this case correctly of asthma. So asthma diagnosis is basically divided into two parts. One is a child who is less than 5 years, and a child who is more than 5 years, then everything is same above 5 years. So 6 to 11, adolescent and adult, all age groups become the same above 5 years of age group. Less than 5 years, the diagnosis is slightly different because we don't have an objective way of proving. That is why the diagnosis below 5 years is based on the symptom complex. While above 5 years, the diagnosis is predominantly symptom complex plus demonstration of airflow limitation. So this is the first thing, that it is divided into three parts. A child who is less than 5 years, we need to see how frequently the symptoms are. So symptoms are whatever cough, wheeze, heavy breathing, less than 10 days during the episodes of upper respiratory tract infection. 2 to 3 episodes per year, no symptoms in between. So less likely to have asthma, or we can see it as few have asthma. Next is the child is having these symptoms for more than 10 days. That is the cough, heavy breathing and wheezing for more than 10 days during the upper respiratory tract infection. More than 3 episodes in year, severe episodes, night worsening is there, and the child may be having occasional cough or wheezing in between the episodes as well. Some may have asthma. So it ranges from few may have asthma to some may have asthma. And last is all of that is there. Along with that, there is an allergic sensitization or atopic dermatitis or a family history of asthma. If that is there, then most likely this child will turn out to be an asthmatic at a later age. So few have asthma, some have asthma, or most have asthma. Depends on how frequent or how severe the symptoms are. Along with that, the last is additional of allergic sensitization in the family members or in the child. Now coming to the diagnosis in a child beyond the 6 years of age group, so we need to have two things. One is a typical history of asthma, and we need to demonstrate that the child is having an expiratory airflow obstruction or limitation. So looking at the history, we need to see wheeze, shortness of breath, chest tightness and cough if any of these there. Most importantly, we need to see that most of the times this child needs to have multiple symptoms rather than just one symptom. If a child is coming to you constantly with only cough, so it may be a cough variant of asthma, but cough variant of asthma is a little less in proportion as compared to other diagnoses. So keep it in mind, multiple symptoms which vary over a period of time and in intensity. The symptoms are worse at night or on awakening. The symptoms are triggered by exercise, laughter or allergens or cold, and the symptoms worsen during acute viral illness. We need to demonstrate by doing some form of testing, and commonly we do, which is easily available, cheaper, is spirometry. What we need to document is expiratory airflow limitation. What does that mean? When we do a spirometry, we check for a ratio of FeV1, that is the amount of air exhaled in the first second of the breath after taking a maximum inspiration. And FVC is the vital capacity, that is the total amount of air that is exhaled after taking a maximum inspiration. So what happens in these patients with asthma is, suppose if I am inhaling, breathing out, breathing in, and I am filling my chest, and when I am exhaling, so when I exhale, the amount of air that comes in the first second is called as FeV1, while the total amount of air that comes out after exhaling is called as FVC. So what happens in patients with asthma is FeV1 it goes down, so the ratio goes down. So what is meant by that? In patients with asthma, the amount of air that should be exhaled in the first second goes down significantly. Okay, and that is called as airflow limitation. There are other ways also of confirming variable expiratory airflow limitation. One is bronchodilator reversibility. You give a bronchodilator and you check for a change in the FeV1 by more than 12%. You check for PEF variability of more than 30%, 13%, and positive exercise challenge of more than 12% in FeV1 and 15% in PEF. Different testing methods are available, which I was discussing previously. Peak expiratory flow meter, that we know, spirometry, and now we are using, there is something called as lung oscillometry. So we are using lung oscillometry also nowadays. So this is a typical PEFR meter, that is also called as peak expiratory flow rate meter. Commonly used in clinical practice, I think not spirometry at least, but all of us can take a vow today and we can have PEFR meter in our practice, because this is a very useful tool and you can actually find out whether this child has airflow limitation. Once you do some testing in a child, with the before you put the diagnosis of asthma, the parents also many times get convinced about the diagnosis of asthma. So this is a PFR meter. The next one is PFT, that is spirometry. We commonly do in my clinical practice, as in private practice, as well as in the institute. Also, we do spirometry because that is what I'm doing day in and out. This is a impulse oscillometry machine. So a type of lung oscillometry technique. This is called as a forced oscillation technique, FOT machine, that is there in my clinic, FOT machine. And then there is one more is called as IOS, that is there in one of the hospitals where I go for consulting. So these four are different machines. They basically check the airflow limitation. One is PFR meter, other one is that spirometry. Third one is FOT, that is force oscillation technique, and the fourth one is IOS, that is impulse or impedance oscillometry. These are different machines that are there which can be used for confirming the diagnosis of asthma. Coming to one case, so I'm going to discuss about a case of underdiagnosis versus and a case of overdiagnosis as well. So in a child, like how we can miss out a case of asthma, and a child where we can actually label a child of asthma and probably is not asthma. Okay, so case number one. So this is a 7-year-old boy has come to us with complaints of cough for last 8 months, and the cough is dry mainly at night as well as during sleep and on getting up. And this grandfather is asthmatic and he is on inhaled corticosteroids. So parents feel that he is doing it on purpose, as the previous doctors have told him the same, and probably it is secondary to the attention seeking. And parents, somebody has labeled this child as a habit cough or stress cough, something like that, psychogenic cough. And because every day in the morning he coughs, the parents feel that the child doesn't want to go to school. That's why he's coughing in the morning. It is not always so. It may be, but not always so. Early morning cough is a very characteristic symptom associated with asthma. So when I examined this child, the child was found to have an inferior terminator. So many times now, when a child with asthma, we need to look for telltale signs of allergies as well. Something like a nasal crease, something like allergic shiners, allergic salute, hypertrophy of the inferior terminator, something like the telltale signs which can tell you there can be an associated allergic phenomenon going on also. On no adventitious sounds were there, significant amount of prolonged expiration was there, other rest of the systems were normal. So we tried to do a spirometry in this child. We tried multiple times on 2 different occasions, but we could not get a good quality PFT or spirometry. So what next? Should we label this child as a case of asthma and give him a trial of 3 months, or we should do some other testing? Because the parents themselves are not convinced. When they themselves are not convinced, it is less likely that they are adherent to the treatment. Okay. If you are giving some treatment to a patient and he is not convinced about the diagnosis, probably they may not take the treatment, they are not adherent to the treatment. So you need to put confidence into their mind about the diagnosis. Once you put that, probably they'll accept the treatment and remain adherent to the treatment. So we did a lung oscillometry in this child. So this is a pre-bronchodilator, and as you can see, for a predicted of 3.7, the child's performance, that is called as R5, that basically tells you about the resistance the airways are offering, and R5 tells you the resistance that is present in the total airways. R12 tells you about the resistance in the large airway, while the R5 minus R20 tells you the resistance in the smaller airways. So there was a significant what do you call resistance in the smaller airways, and when we gave a bronchodilator and post bronchodilator, if you can see the below graph, I'm not going to the values and everything, but you can see the continuous red line. The green belt basically tells you the normal range for the patient. The continuous red line tells you the pre-bronchodilator, and a dotted red line tells you the post-bronchodilator. There is a significant improvement post-bronchodilator in this child. It may not have reached to the green belt, but definitely there is a significant improvement. An improvement of more than 30% from pre to post by a FOT confirms your diagnosis of asthma. So in this child, if you see, there's an improvement of 240% after the bronchodilator. So there is a significant improvement after the bronchodilator. So this child was labeled as an asthma, confirmed with a diagnosis by the force oscillation technique, and the child was started on the treatment, the inhaled corticosteroids, and child is doing better. Now, as I was telling you about the underdiagnosis, we should be cautious about overdiagnosis as well, because many times we tend to, in a child who is less than 5 years, the guidelines themselves mention about giving a trial of inhaled corticosteroids for 3 months. And whenever you start inhaled corticosteroids for any disease for that matter, transient improvement always occur, which may be for few days, few weeks, and again the symptoms worsen. So parents always tell you, slightly better. So we may, again say that, theek, if your diagnosis probably is correct. But if the symptoms are not getting relieved, and if you feel that there are some other telltale signs of some other disease, we should always work up in detail. So uh, overdiagnosis is also common, and many times we see in practice that overdiagnosis is happening. So this is one case. This is a 10-year-old boy who has come with complaints of cough for last 4 months, which has become worse since last 2 to 4 weeks. Initially the cough was dry and gradually it has become wet. Parents feel that the chest is filled with secretions, but the child is not able to bring it out. There was occasional sputum, especially in the morning. No fever, breathlessness, no weight loss also. And mother is a known case of sinusitis, and she was doing some jalaniti that she was doing. So, based on these symptoms, this is the child. I hope the video plays. आवाज आवाज नहीं This is going on for last 4 months. You heard the quality of cough. So many times, no, in the OPD when the patient is sitting outside and they are coughing, in your mind you make a diagnosis whether this is asthmatic cough, whether this is something else, whether this is habitual cough. Habitual cough is because when you enter the cabin, coming from out and going into the cabin, the child, when you see as a doctor, the child makes more effort in coughing to show you that I am suffering. In a typical diagnosis, so many times that habitual cough is uh, get diagnosed. So this is a child who is having a typical cough, which sound like wet cough. So impression about the cough, this type of cough. So it is a wet type of cough. Otherwise, the child is clinically doing fine, hemodynamically stable. The entry was good, no evidence of wheezing, and the child is thriving. Also, you can see the child is well grown. There is no weight loss, or the child is not having any failure to thrive or something. And rest of the system examination was normal. This child is coughing for 4 months. Otherwise, everything is going smoothly. There is nothing. So what do you want to do in this child? Whether you want to give a trial of treatment, or whether you want to investigate this child further, or what should we do? Yeah, I think last 4 5 slides. Okay. So this child actually had got worked up before coming to us. So he was referred to us for doing a bronchoscopy. So this child has undergone a X-ray, CT chest, and other test also, and sputum also has the child has undergone, which was no growth. This was the chest X-ray of the child, which if we can see, we probably will label it as a normal chest X-ray without any typical findings. The child has received multiple doses of cough syrup, bronchodilator, oral steroids also the child has received, nebulizations has received, and the child was started on MDI budesonide, and for last 1 month there is some relief, but the symptoms are persistent. This was the CT which was done outside before coming to us, and which was reported as normal. And so we thought probably this is a case of something, and then we thought we'll do a bronchoscopy and confirm. So this child has undergone a PFT also, which was normal. This is the bronchoscopy. This is the Karana. I'm going to the left side now. You can see the left side. Keep a watch. It's a very small video. Significant amount of sputum is coming, and the child is coughing during the procedure. Rest of the airways was significantly normal. So ball was collected, ball was sent for biofire. Biofire showed H influenza type B. Okay, so what is a diagnosis, which is a common day-to-day practice we see nowadays? Okay, so bronchoalveolar lavage, it was showing a neutrophilic predominant count. Culture grew Haemophilus influenza, that is the bacteria. Other cultures like Gene Expert and MGIT were these things stain were negative. Child was started on a course of amoxicillin for 4 weeks. So the diagnosis is protracted bacterial bronchitis, which is a close mimicker of asthma. And this child was started on 4 weeks of coamoxicillin. The symptoms improved drastically. So we should be careful about what is not asthma. So what are the pointers towards that? Asthma diagnosis becomes less likely if you have this isolated cough with no other respiratory symptoms on repeated visits. I am saying a repeated visits, I am stressing it because cough variant asthma is also there, and many times when the child has come to you, you may be just having cough, no other respiratory symptoms. But on repeated visits, if the child is having only cough, then possibly you need to think whether I am really dealing with asthma or it is something else. Chronic sputum production. Asthma doesn't have sputum production. Very less amount of sputum production happens. There are different phenotypes where you can have in asthma sputum production, but in pediatric age group these phenotypes are not seen. So sputum production is not seen with pediatric age group. Other system involvement, something like shortness of breath, dizziness, lightheadedness or peripheral tingling is not a feature of asthma. Isolated chest pain is also not. Exercise induced symptoms are there in asthma, but exercise induced dyspnea with noisy inspiratory sound, that is a stridor, if that is there, then it points towards vocal cord dysfunction more than a asthma. And if you see a child where you see clubbing or cyanosis, then it is less likely to be an asthma, because by the time you develop cyanosis in a child with asthma, probably it is a severe disease, probably child is already in PICU. So clubbing and cyanosis are not features of asthma. Last slide. So coming to the future roadmaps, lung oscillometry, I'm not sure if anybody is doing in Nashik, but this is one of the things that is coming up, and it is easier to perform in a child who is 4 years and above, and gives us a diagnosis relatively easy. Many times we have seen our technicians breaking their head while doing spirometries because it is very difficult to get a good graph with a spirometry. If you go by the criteria of spirometry, of a good spirometry readings, probably 90% of the children will fail the criteria of spirometry. Disadvantages is costly machine, and there are at present no Indian standards available. There are one standards available, Indian standards. Still it is not to be called as standards, and we need to do more and more public awareness programs. We need to create an awareness program which will provide, will give a prime importance to accept the diagnosis. Thank you so much.
Thank you, Sandhane sir, for sharing your wisdom. Now I would request you and chairperson to proceed towards felicitation desk. There is a car standing in the parking, MH12 RK8400. Car doors are open. I would like to also make an announcement for Adolescent 2024. It is good opportunity to register for this conference organized by IAP Nashik on September 27, 28 and 29 at same venue. Nashicon delegates will get 20% discount today and tomorrow only for Adolescent registration. Registration counter is available outside. So please hurry up. I would like to invite chairperson for our next session, Dr. Tanaji Kanade sir, Dr. Bhagyashri Bora, Dr. Abhijit Sangle. Please proceed towards desk. Now we will delve into critical topic that resonates deeply with every pediatrician, and the topic is how sick is too sick. This topic really challenges us to explore our skills and judgment. Leading us into this exploration, we have with us Dr. Tarun Kanade, who has done pioneering work in pediatric critical care in North Maharashtra.
Thank you. A very warm good morning to one and all. It is a great pleasure and honor to be standing amongst one's own family, especially my father, my first teacher, in front of whom to speak. So it is an honor and it's a heartfelt thanks to the organizing committee for giving me this opportunity to present my thoughts on a topic which is quite close to my heart and to everybody's heart as well. So how sick is too sick? When I first heard of this topic, it was a conundrum. Like how sick is too sick? For me, a sick child may be different than some other pediatrician who's looking at the same child. So it is like facing Bumrah's Yorkers, or is it facing Rohit Hitman in his full flow? So it's a difficult question to answer. However, I'll try my best to answer and satisfy your queries. So basically, how to approach a sick child, that is what is more important to us. First and foremost, as in when we are sitting in the OPD or when we are walking in our ER, the first thing that is strikes us is the initial impression. So how is the child looking? Even when Dr. Parmar just mentioned, when you're walking inside your OPD and you're hearing a child, if you hear a grunt or if you hear a shrill cry, I think so that is the first thing which strikes you. So keep your eyes. One of my seniors from whom I've learned too much is in the audience. He used to say, the ICU is like military. You have to be on the war front. Similarly, when you're in the OPD or in your wards, when you're walking in your hospitals, when you're on your pediatric duties, I think so keep all your senses open. Dr. Satish used to say, तेरा कान कभी बंद नहीं होना चाहिए, तेरा आँख हमेशा खुला रहना चाहिए. And I think so he's there here to guide us all subsequently. So he is to, whenever you're looking at one patient, your ears must be hearing something else. Maybe a cry, maybe the monitors who are blinking. So keep your eyes and all your special senses on. So that will help you first to get your initial impression. What is initial impression? It's basically appearance, breathing, and color. How the child looks at you. Is the child alert? Is the child drowsy? Is the child comatose? So those that look, how is the child breathing? Is he breathing fast? Is he breathing slow? Is there any breathing? So third thing is the color. That will give you the maximum information. Like yesterday itself, I had a patient who was a 5-year-old who had come to me for a second opinion. They usually come to me for second opinions. So this child had a cyanosed look to his child. This child was in pulmonary hypertension, was having a large VSD. Multiple times he was advised operation, but couldn't do because of many reasons. This child was probably going on to Inauguration. So that look, the color, that gives you a lot of information. Look at the tone, interactiveness, consolability. Many children land up, when they enter the doctor's cabin, they start crying. Look at them whether they are consolable. Consolability is a very important aspect. Look at the worker breathing, any abnormal sounds, any wheezing, which Dr. Parmar just mentioned. Is the child pale, cyanosed? Then you come down, this will take few seconds. Next is few minutes. In first 2 to 3 minutes, you just look at his airway. Whether his airway is open, is it having secretions, do you need to suction, or is it clear? If the airway is collapsing, not maintaining, he will require an advanced airway. He will require some form of advanced airway, either a tube or a LMA, something will be required. Look at the breathing. First 4 points are just clinical. You don't require any hi-fi equipment for this. Look at the respiratory rate. Now we all know a normal respiratory rate for each age. So if the child is looking tachypneic, look at the worker breathing. Is he using intercostal muscles? Is he using accessory muscles? Is there any suprasternal retraction? Look at the tidal volume. Is the chest rise good? Or many children with asthma, they will be having a lot of breathing, but there is no chest rise because the chest is already hyperinflated. Okay, look at air. Just put up the setho, look at air entry. Very important. Look for adventitious sounds. Look for wheezing. Look for stridor. And last, if you must have these two, I will request every one of you from here henceforth, keep these two equipments in your OPDs, a pulse oximeter and a glucometer. How will the glucometer help you? I'll tell you subsequently, but the pulse oximeter will help you 100%. Okay, so you must check, as Dr. Iyer sir said, you must check every neonate's pulse oximeter or SpO2. You should check a child who is sick looking to you. You must not every child who is coming for vaccination, though I would like to mention that any child who is coming for BCG vaccination, just get his SpO2 checked. Many times you do pick up a lot of cyanosis at the time of BCG vaccination also. Third thing we come down to is in that pentagon is the C. A, B, C, C is circulation. Look at the pulse. Dr. Umali used to say, "Pehle aake patient ke pair chuo." Not only for his blessings, but to look for his dorsalis pedis. Look at his pulse, see the volume, See how it is, see the CRT, look at the color. Is it pale? Is the CRT quick, brisk? Look at the blood pressure, if it is possible. A very important aspect. I remember one of the conferences, I think so it was a nephro conference, everybody had received, instead of a folder and a pen and a pad, they had given BP cuff. A very innovative thing. BP cuff is an essential thing nowadays in our OPDs. At least keep one small BP cuff in your OPD so that you can get some idea of the blood pressure. Always remember, not only because I'm a nephrologist student, but because urine output is an important parameter to understand. It's an indirect indicator for cardiac function, for adequate circulation. Especially in this season of dengue, we should always look out for urine output. Any patient, bolta फक्त विचारून घ्यायचं, सु करतो ना बाबा? You ask the patient, he will tell you, sir, काल रात्री केली होती, अजूनपर्यंत केली नाही. So that will give us an important indicator that something is going wrong. So you have to pick up these small signs. There are very subtle signs, may not be very critical, may not 90%, you may not get anything. Always the answer will be a positive answer, but in 10%, they will help you diagnose something very critical. It also helps us to monitor the response to treatment, especially in patients with dengue, shock. Urine output is an important parameter we need to use. You can use an indwelling catheter if it is available. Another important function is disability. Is the child neurologically intact? It's the third vital organ of the body. Very sensitive to oxygenation, very sensitive to hypoxia. We just have to check two things, cortical function and brainstem function. आपल्याला खूप हाय-फाय hammer घेऊन लगे ठोकाठोकी नाही करायची. So we have to look out for any cerebral dysfunction. Important over here is again estimation of glucose level. Okay, look at the sensorium of the child, look at his reflexes, look at the pupils, look at his sugars. So we can use the AVPU response, which we commonly advise in the IAP, ALS, BLS. Is the child alert? Is the child responsive to verbal stimulus? Is the child responsive to painful stimulus? Or is the child unresponsive? Only 4 things you have to check over here. Accordingly, they have the corresponding GCS score so that we can go for it. Then comes, after your primary assessment, you go for your secondary assessment. You look at for focused history, a focused physical examination. The child is coming for respiratory complaints, ask respiratory problems, look at respiratory system. Along with that, you can do a secondary examination of the other systems also. So focused history may include signs and symptoms, any allergies, medications if the patient is taking, any past medical history, last meal taken, or what is the event which brought the child to ER or your OPD. You can go do a quick head-to-toe examination. A detailed examination can be followed subsequently. Look for subtle signs like neck stiffness, throat, any lymphadenopathy, edema. Then you can go for diagnostic tests, which you are all experts in. So the crux over here is a structured examination. Don't miss out any of the ABCD. तुम्ही B miss केलं, so you miss out something important. So keep a structure. This word is very important. Structured evaluation of the patient is very important, and make it a habit. Don't use in only one patient. हाँ अभी 9 patient में अपना आया patient लगे लिखना शुरू. ऐसा नहीं. You do it this examination in every patient. It will become a habit, and it will take less and less time as you do it regularly. One thing is very important in this age of modern era nowadays. Unaware is okay. If you're not aware, it's okay. Under-resourced is also okay. But unprepared is not okay. You have to be prepared for anything, not anything, most of the things in your OPD. So keep a few things in your OPD which are now the need of the hour. Earlier, okay, it was okay, 100 or 150 OPD, fine, you may miss a few things. But now, since people are also expecting a few things from the healthcare services, we need to keep a few things in our OPD, such as a bag mask, a suction machine, pulse oximetry, a glucometer, thermometer. These are a few things which are very important, which may prove to you a life-saving in few patients. Certain emergency drugs like adrenaline, steroids, nebulizers, atropine, paracetamol suppositories, midazolam nasal spray, very important. Many times we are in our OPD, patient comes conversing to us, doctor बघा ना काय झालं, doctor बघा ना काय झालं, आपण पण बघत राहतो आणि patient बघत राहतात. बघण्यापेक्षा, if the patient is actively conversing, if you give a simple nasal spray, it will abort the seizure. It will give you time and it will make you like a god in front of them. So you have done something actively, okay? Rather than just putting oxygen, of course, that needs to be done. If you abort the seizure, it will really go in a long way in helping the patient come over. Second thing is, it's an outcome-oriented society. So if you have to improve your patient's outcome, you have to act. You can't just stare now, okay? So now let's come to certain pediatric problems which you commonly face in our OPDs or in a general practice. This was a 1-year well-grown male baby who was sitting in the OPD reception area for a fever and cold for 1 day, and suddenly you are sitting inside and there's some commotion outside. So you get disturbed, there is some shouting and crying, you rush outside to see the baby convulsing. So it's a very common scenario. So what do you do next? Now, first and foremost, of course, this is probably a febrile seizure, looks like a simple febrile seizure. So what we can do is take the baby on the table, attach a pulse oximeter, start oxygen if you have the provision with you, check his temperature, put a suppository, and give a midazolam nasal spray. These few things we can do. Along with that, if you check the glucose, with the glucometer, this is like Sone pe Suhaga. So you'll get to know what is the cause with the temperature. You can treat the cause, the suppository, stop the complication using a nasal spray. Either to me kiti active, how much you don't need an intensivist over here. You just need basic pediatric critical care over here. Nothing hi-fi. You can do it in your OPD with few equipment with you. Nasal sprays are easily available. You can keep a nasal spray in your OPD. You may not require it for many months together, but definitely it will help you in one patient. Definitely it will help you a lot. And look, always remember that not only you, not only God, the other patients are looking at you. How you are managing this critical patient, and that creates a very good impression when you do something very actively and very empathetic if you approach to the patient. Second common problem we see is a fall from bed. Just 2 days back, I had a young doctor with a first child coming to me with a child who has fallen from bed, like hardly from 2 feet the child has fallen, but the mother is crying more than the baby. So in such situations, head injuries or fall from beds. Now this child was 18-month-old. He came to us for crying for 10 minutes and had vomited once. Had a LOC. LOC is loss of consciousness for around 5 seconds. So do you think this is critical? Let's see, what are the guidelines tell us? Now there are certain guidelines given by PICAN. PICAN is Pediatric Emergency Care Acute Research Network. So this child is younger than 2 years. So when is a CT head indicated? Or when do we need to observe the child and when do we need to send home the child? So a child who is having altered mental status definitely requires a CT head. Child who has a GCS which is less than normal definitely requires a CT head. A palpable skull fracture, 100% CT head. So these 3 patients, to an option is nahi hai ghari jaisa. You have to get a CT, you have to get him admitted. Now what about observation and if required, CT? LOC of more than 5 seconds. There's a loss of consciousness lasting for more than 5 seconds. There's a non-frontal hematoma. Frontal hematoma is okay, but non-frontal hematoma, not acting normally, not consolable, shrill cry, or there is a severe mechanism. Like I had a child who had, the mother and the father were traveling with the child on a bike towards Manmad, and the child slipped from the mother's wrist and he got entangled in a dupatta. Okay. Now this child, when he came to me, he was conscious, but he was not moving only. No upper limb movement, no lower limb movement. He was conscious, looking around, feeding also, no vomiting, no LOC, but he was not moving the upper limb and lower limb. So the mechanism of injury was quite severe. It was a partial strangulation. Okay, because of dupatta got entangled in the neck and that child had a sort of hanging sort of thing. So these children are the ones who you really require to have your sixth sense active and get him admitted, look for an event. In this child also, we were not certain what is happening, but subsequently when we got an MRI neck done, that time we got to know that there is some injury to the spinal cord and we had to give steroids and the child improved subsequently, required a long time, never paid the bill. Children who are 2 years and older, again, the little bit different this thing, but look out for LOCs, look out for palpable fractures, less GCS. So in these children, they do require observation and CT brain. So use the AVPU scale, look for GCS, look for pupillary response, and always get a blood glucose done. So we need to keep in mind a cervical spine. Very often we forget in our state of panic and so much this thing, we forget cervical spine protection. Keep a small board in your OPD or your IV line board also can be helping smaller children. Okay, protection of spine is essential. After the ABCD mahiti ahe. A is what? Look at the airway. Look at the breathing, oxygen saturation, and intubation if required. C is circulation. Look for do you need to give fluids, cervical injury. C is again calm yourself. Many times, apan's panic zalo asto. So you have to first calm yourself, look at the patient, look at surrounding. All three things you have to keep in mind. Check for sugars, give dextrose if required, elevate the head end. The only thing which is proven to save, which has survival benefit is head end elevation. So many people who have worked with me must be knowing, sir, name head end elevated ka litat. That head end is the only thing which is proven to save or to remove or reduce the mortality in children with head injuries. Check for pupils, ease and electrolytes. Look for sodium levels. Can give 3% NS or mannitol, whatever is required. Look for give adequate fluids. Avoid dextrose initially. Counsel the family, very important. They are in itself a panic situation, more panic rather than and this thing. So you have to counsel them. Avoid fever as much as possible. Reassess GCS. Hyperventilate if required. Look for signs of herniation and look for, if you are in a tertiary or quaternary setup, look for ICP monitoring. Come to the next case. This child was a 2-year-old who was found with a container of a dishwasher detergent in his hands, and there is some around his mouth. So the patient is asymptomatic. फक्त dishwasher liquid हातात आहे आणि तोंडातून थोडासा वास येतोय. There is physical examination is normal, including oropharynx. You saw no burns, nothing. Should we send him home? So what are you going to do? Reassure the parents. घरी जा, काहीतरी औषध rantac देऊन, Gelusil. See, caustics are very dangerous, as electric batteries. I hope you all know that electric batteries are one of the, especially the button batteries, very dangerous. They will act within few minutes, cause severe burns, acid burns. These are alkali burns. Avoid lavage. You don't know whether he has swallowed or not. So, jari tonda disat nahi hai, there's a high chance it must have gone inside. And do not give anything orally unless you're really sure the child is absolutely normal. Now, acids cause a coagulation necrosis, whereas alkalis cause liquefaction necrosis. There's slight difference in the two, in the mechanism of injury. Alkalis more, they cause airway problems. So lower down the larynx, pharynx, and esophagus, they cause a lot of inflammation and injury. So can your examination predict injury? No. So don't trust your examination, especially in terms of button batteries, acids, and alkalis. Caustic therapy is basically keep him NBM. You can get a check scopy if you're really suspecting. Get an upper airway examined by an ENT person or by a pulmonologist. Get a scopy done by a GIS person. Steroids are controversial. It depends upon degree of injury. We can give antibiotics if pneumonitis is suspected. Now some rapid fire cases. We all know, all out, good night. Many children come with tonal lovely battery or swallowed. So what do you think? What is what poison it is? It's alcohol is there and there is pyrethroids. First of all, foremost, no lavage, similar to kerosene. Observe, look for seizures, look for hepatic and cardiac dysfunction. Kerosene, again, it's a hydrocarbon, so avoid lavage. No lavage, no charcoal. Get a chest X-ray done after like 6 hours. Don't get a chest X-ray done immediately because immediate X-ray may be normal. Rat poison, dangerous. Hepatic trauma, zinc oxide is the main poison over there. You give activated charcoal in this patient and vitamin K should be administered. Camphor, many times during Ganpati festival or Diwali we get this camphor poisoning. They cause a lot of seizures. So camphor is, you can give activated charcoal and you can control seizures by using midazolam or phenobarbital. Next, this 9-month-old child came to the ED with irritation, respiratory distress, but chest is clear. The child is irritable and history of cysts 1 day only. So you got an X-ray done. Nowadays parents are smart, they come with an X-ray. So this X-ray was showing this. Is this X-ray abnormal? 9-month-old child. What do you see over here? What is this? A sail sign. Okay, so this is normal. That is thymic shadow. So don't get confused by that. Okay. Look at the blood gas. My God, havoc. This patient was over smart. He came with the blood gas also. 6.9 pH. Okay. Co-oximetry is normal. This is from a hi-fi center. They must have come. Nashik doesn't have a co-oximeter. Very important. Again, important over here. Look at the glucose. What is it? 467. Sugar is very high. Completely flummoxed. We never expected this thing. Since the child didn't have any findings, the child had undergone an ABG and that showed a sugar of 467. Okay. So this child was an infantile diabetic coming with DKA. Very rare presentation. I just showed over here just to show the importance of a glucose, a simple glucometer monitoring in the OPD. Patient coming with respiratory distress. Respiratory distress glucose ka check करायचं. अशा patient मध्ये कामी येतं. Okay. Next child, this is Parmat's patient, came 13-year-old child with severe cough difficulty in breathing. Now, Parmanth will go for PFR and flow oximetry and all those things, FEV1 and all. But for as a simple pediatrician, I will first check I'll auscultate the child, check her pulse oximeter. And since the child is having tachypneic, looking obviously distressed, saturation is only 88% on room air, I will classify this as an acute exacerbation of asthma and immediately start the first drug. Which is the first drug in this child? You will give her oxygen. Oxygen is a medicine, it's a drug, it has its own side effect and its effects. So oxygen, use it as a drug, don't overdose it. Give a bronchodilator. If you are hearing audible wheeze, that means the air is going in. If you are a silent chest, don't waste your time in giving nebulizations, inhaled drugs, because there is no movement of air. In a silent chest, you have to go for systemic bronchodilators. You have to get the patient admitted, give IV infusions. Second thing is, give a steroid as early as possible. This is one patient in which you have to use rampant steroid. Preferably give systemic steroids, oral or IV, whichever is preferable. Continuous monitoring is important. Nowadays, even Maxelf has come into the first few hours of diagnosis of acute exacerbation. So give Maxelf. Many people are afraid of giving Maxelf. Give Maxelf in a child with asthma, not in other children, but in asthma, you give as early as possible. Very simple dose, 0.1 ml per kg of 50% Maxelf. Some small ampule, hardly 7-8 rupees take ampule. Dilute in 25 ml NS, give it over 30 minutes. Don't give it an infusion over 6 hours. It may not act. Because of your fear, you will give Maxelf slowly. Give Maxelf fast, nothing will happen. But the spasm will get relieved. Okay, it will break down the spasm ka cycle. Once it breaks down, the child will come out. Okay, not to do what? Not to do in asthma. Very important. First lesson I learned when I was doing my MD, what not to do. Okay, routine X-ray is not indicated. If a child is a known case, don't go and spend time. Let him go to the X-ray center, get an X-ray, come back. Don't waste time in that. The child may go in further hypoxia. Don't use inhaled steroids. Many often I see inhaled Budecort, chalu etala saka sandhyaka, saka dupar. Budecort doesn't help unless it is you're using in the right dose for prophylaxis. In acute state, inhaled steroids have no role. You have to give someone, I remember we had calculated dose, we had to give 42 ampules of Budecort to achieve some bronchodilation. Now remember 42 ampules kutan apan ek deto hai, 0.5 mg. So there is no role of inhaled Budecort in acute exacerbation. Dokyatna kadun naka. If you want to give proper bronchodilator, give ipratropium, but avoid Budecort. Oral beta-2 agonist, syrup Livolin plus Surconilla, syrup Ascoril. The child will not be able to, though that will not be act only. So you need to give inhaled bronchodilators and systemic. Don't go for oral bronchodilators. Don't go for Montelukast. Nebulization without oxygen is a difficult aspect in our limited resources settings, but try to give nebulization with oxygen because it requires very high flow of oxygen. Avoid antibiotics rampantly. If you're suspecting infection, fine. If you're not, there's no fever, avoid antibiotics as much as possible. Routine chest physiotherapy, not really indicated. Next patient, very commonly seen, we had just this patient around 2 months back. This 1.5-year-old child came with history of, he just drank a bottle of crocin. आता कुठलं crocin drops होते, syrup होतं, 250, 120, or combination with mefenamic, combination with ibuprofen, we are not sure. And mother has come with that child with a bottle of crocin. A patient is anxious, there is mild tenderness in the abdomen, the heart rate and other vitals are stable. And there are various preparations. You are not sure what crocin he has taken. Okay, there is a drop which has 1 ml as 100 mg. There's a syrup which has 5 ml as 120. There's a syrup which has 5 ml as 250. And now that there's a syrup 5 ml is 500 also. Okay. So, most important over here is you have to let them bring the bottle to me. You don't spend time. Yesterday only I was breaking my head. Tumchake drop se ka syrup hai, drop se ka syrup. She was not knowing. So I said, you bring that bottle to me. Unless I see it, you will not be able to know what he has taken. Okay. So what questions should I ask in a child with crocin or suspected paracetamol poisoning? What should I do? Toxic dose is 150 mg per kg. So calculate dose. He has taken 10 ml of 1 ml crocin drops, then it is 1000 mg. So you should just know what preparation he has taken. Activated charcoal is readily available. It comes from Yashika Pharma. You can keep it in your pharmacology store. Don't keep it with you in your OPD, but in the store you can keep. And you can give 50 grams stat. Or you can induce a lavage, bring out the crocin syrup. Okay. NAC, don't go after NAC. It has proved a very good role, but not in the immediate this thing. In the next first 6-8 hours, yes, it is definitely shown to have good effect. Keep a nomogram in your mobile or in your folder, in your laptop, wherever. You can use this nomograms. Use the units. Look at the units. Many times when I have used a nomogram, I was totally confused because the units are so different. Okay. First 24 hours, there is some nausea, vomiting is there. There might be some rises in SGOT, SGPT. Subsequently, there might be a lot of clinical findings may come up. And after 5 days, it may progress to multi-organ failure. So just keep a close watch. Another thing which can come up in very commonly is, last 5 minutes, a 4-year-old boy who came with some rashes, wheezing and flushed appearance following a bee bite. So anaphylactic reaction. So there can be immediate hypersensitivity leading to anaphylaxis. Look at respiratory compromise. Look at blood pressure, pulses, perfusion. Look at GI symptoms. Adrenaline can be given subcutaneously in such patients. It has lateral thigh has maximum absorption. You can repeat 15-20 minutes till the symptoms subside. You can use IV Avil or diphenhydramine. IV hydrocortisone can be given, and bronchodilator nebulizations can be given. Not only bee sting, आता bee sting तर मला बघूनच खूप दिवस झाले, but you can get some other stings. There's something called as the beetle sting. Okay, wash with soap. It is a very strong local reaction. Just so wash with alkali, soap and water. Avoid contact with eyes. Definite management is just analgesic. A local allergic reaction, there may be a blister formation locally, so it may resolve spontaneously. A CO rat. Here important is you have to give rabies vaccine in these children. You have to remember this is one condition in which the dog bite is not there, but still you give rabies vaccine. Do not suture, give TT if the child is indicated, and give antibiotics because CO rats are known to have anaerobic infections very commonly. And child to child, शाळेत खेळ होते एकमेकाला चावलं. Okay, so what do you do? Reassure, clean, wash with povidone, iodine and all. Can refer to plastic surgery if the bite is severe. Give a tetanus if the child is not immunized. You can immunize with a booster dose or TT. You can give antibiotics, and counseling is important over here. So coming to the last slide. Pediatric office emergencies can be sudden and unexpected. They will not tell you that I am coming as an emergency. Recognition of emergency. As Dr. Parmat's first slide was, पहिले तर problem कळला पाहिजे. जर कळला तर आपण act करू शकू. So you should recognize an emergency. Don't wait for someone else to diagnose that emergency. Don't wait for parents to tell me, sir, आम्ही तुम्हाला सांगितलं होतं patient emergency म्हणून. Okay? This is the worst dialogue you can hear. Use a structured evaluation approach. Very important. Look for airway, look for breathing, look for circulation, disability, check his pulse oximeter, check his sugars, look for his urine output, look at the parents, and look towards yourself also. Be prepared. Nehmi taiyar raho. This is a slogan of Gorkha Regiment. But okay, you should have a good equipment, good drugs available with you, timely, appropriate, and a safe transport. आपल्याकडे ट्रान्सपोर्ट म्हणजे काय? ते समोर हॉस्पिटल आहे, जा पळत. तिथे इन्फॉर्मेशन नसतं, तर पेशंट आता रिसेप्शनला आपल्याला फोन, सर एक पेशंट आले, काय करू? आपण म्हणून त्याला पाठव तिसऱ्या माळ्यावरती. पेशंट वर जास्त तर ते आधीच गॅस्पिंग होतं, अरेस्टमध्ये जातं. सो बेसिकली इफ द पेशंट इज रिअली क्रिटिकल, accompany the patient. Okay, one thing which I have really learned from my seniors over here in Nashik, they never left the patient's bedside. So be with the patient, whatever it is. Patient च्या नावावर डॉक्टर सोबत होता बाबा. So they will get reassurance. You will know what is happening first of all, because you yourself require some time to understand. Third thing is you can move things. When your staff sees you accompanying the patient, they will act more promptly. Okay? Or if you are referring to some other hospital, talk to the doctor, talk to the PICU, talk to the hospital over there. Maybe the intensivist may not be able to pick up his phone like me, but there may be some people who are there who will pick up phones, who will answer your queries. Okay? So timely, appropriate referral and a safe transport is the important thing over here. With this, I thank you. Thank you for the opportunity. It was an honor and a pleasure to be over here. Thank you again.
Thank you, sir, for such an engaging and informative session. I would like to please proceed towards felicitation desk, chairperson and Dr. Kanade, sir. Nashicon had organized a fitness challenge for doctors to motivate them. Now I would like to announce names of fitness challenge jumping jacks below 45 years. Dr. Tushar Gudbole, sir. Dr. Abhijit Sangre, sir. Dr. Sagar Bhalerao. Please proceed towards felicitation desk. Okay, ma'am has question.
Hello.
Yes, madam.
I want to share some my ideas. I'm myself Dr. Bhagyashree Bora, professor from Program Medical College, Loni. I know Tarun Kanade since long time. He is an excellent speaker. He had given very precise and points which are needed in day-to-day practice. only things I want to add, most thing which I like is a structural evaluation, ABCD of evaluation is very nice. As I'm working in a rural area, some points I have want to add, such as you have not added organophosphorus poisoning, then scorpion bite, snake bite, which we come across so many times. We had one case, 3-month-old baby with a cobra bite. So that point I want to tell you. Then as I work in a rural area, I want to share my idea, that means share my, not idea, my experience regarding how sick is a too sick. It is from doctor side we talk. I want to talk it from parent side. When I was working in a rural area, patient is okay, but they are coming just for to take a saline. Doctor Sukha's ek saline there. So, and that also yellow color, red color with some multivitamin. So we have to treat that psychology also. At the same time, some patients who are sugarcane cutter, that means us todi wale, patient is so severe, severely dehydration, shock, but they are telling that bharicha saline de tondani deto. So we have to, that means illiteracy is a major part, and we have to consider from parent side also. Very nice lecture. Just I want to share. Thank you.
There was a snake bite patient, but since we are in from a urban area,
Yeah.
I have hidden the slides. There was a case of, I've sent you the presentation, madam. You can see.
Okay, okay. No, no. Just I have pointed out.
Yeah, snake bite is a rare presentation in our urban setup. And there is a special topic on animations tomorrow. Entire
Okay.
lecture is there, so you can, all your queries can be answered, and by the best person probably available in this part of the
No,
world.
no. Just I said
Second
my
thing,
idea. Nothing
yeah.
is, but it was an excellent presentation.
Yeah.
No
The
doubt.
second thing, the parent
Thank you
part
very
is
much.
very important. Parental concern is very important. Over here, I would like to specify that you have to spend some time with the parents.
Yeah.
The parents are definitely panicked, but in our busy OPD, we always neglect this aspect. So what I would suggest over here is, whatever correct therapy is there, that only you advise.
Exactly,
Don't advise
exactly.
anything abnormal. Many patients come to me also, sir, injection lagao. ये injection लेता है. But I have never given injection. Don't promote practices which are not ethical, not recommended.
The most important point I like,
time.
the most important part I like is a be calm.
Yeah.
That is the most important thing. So thank you, organizing committee of Nashicon, for inviting me.
I
Thank
think
you.
we are extremely sorry we are running short of time. We have to wind up. Yeah.
I would like to hand over the mic to Dr. Pawan Devre sir for inauguration ceremony.
There is registration counter for Adolescon 2024, which is a national conference. It is going to be held on September 27, 28, 29 at Expression Hotel. Nashicon delegates will get 20% discount today and tomorrow, only for Adolescon registration. Registration counter is available outside.
Good morning, ladies and gentlemen, esteemed guests and delegates. I, Dr. Pawan Devre, Organizing Secretary of 8th edition Nashicon 2024 and Maha-AP Midterm CME, I welcome you all to the inauguration ceremony here in the holy city of Nashik, renowned as the wine capital of India. As we gather in this picturesque setting, surrounded by lush greenery and refreshing rains, we embark on a journey of discovery, collaboration in pediatric healthcare. Nashicon is an occasion when we gather together to celebrate innovation, collaboration, and pursuit of excellence in healthcare. Over next 2 days, we will explore groundbreaking advancements, exchange invaluable insights and forge connections that will shape the future of medicine. Together, let us embark on this journey. Ladies and gentlemen, to ensure a swift and seamless continuation of our program, may I request our esteemed guest to join us for lamp lighting ceremony. Please welcome Dr. Ram Gopal Chejara sir, President of Dr. Amol Pawar, Secretary, Dr. Amol Pawar, sir, Secretary, and EP member of Central Committee and Joint National Coordinator of IIT Presidential Action Plan. Dr. Mohan Wadu, sir, Treasurer, Maharashtra IIT. Dr. Sachin Saudari, President, IIT Nashik. Dr. Dilip Baradi, Founder President of Nashicon. Dr. Ravindra Sonawale, sir, Organizing Chairman of Nashicon 2024 IIT UPC. Dr. Sachin Patel, Secretary, Nashik IIT. Thank you, dignitaries. Your presence and participation in this symbolic gesture symbolize the illumination of knowledge and the spirit of collaboration that defines this conference. I kindly ask all dignitaries to come forward and take their place on stage. And I also request all EB members of Central IIP, Maharashtra IIP, and other office bearers to occupy the front seat. Ladies and gentlemen, it is with great honor that I introduce to you our distinguished. I also invite Dr. Sagar Bhalerao sir, President-elect of Nashik IIP branch, to come forward on the stage. Ladies and gentlemen, it is with great honor that I introduce to you our distinguished chief guest for this inauguration ceremony. Please join me in welcoming President of Maharashtra IIP, Dr. Ram Gopal Chejara sir. Sir is a senior consultant pediatrician from Thane. He is an astute academician, a true soldier of IIP, known for his energetic personality, time punctuality, and very accurate business acumen. I request Dr. Milind Bharadia sir, founder president Nashicon, Dr. Ravindra Sonavane sir, chairman, organizing chairman of this conference, and Dr. Sachin Chaudhary sir, president Nashik IIP, to felicitate our chief guest Dr. Ram Gopal Chejara sir.
गोपाल शेजारांना जे आपले चीफ गेस्ट आहेत त्यांना हे झेडचं प्लांट दिले. ते वेल्थ प्लांट आहे आणि लगेच त्यांना आता मी सोन्याचं नारळ देतोय. म्हणजे इतकं फास्ट.
Now I request Dr. Sachin Patel, Secretary of Nashik IIP, to felicitate Dr. Amal Pawar sir, Secretary of Maharashtra IIP. Treasurer inaugural issue themed around neonatology was released online in an innovative flipbook format in April 2024. For those who haven't seen, you can access it by scanning the QR code on our official standee at the registration desk. We are honored to officially unveil this first issue, which is featuring the insights from our esteemed seniors, Dr. J.S. Patel and Dr. Shama Kulkarni. And there have been enthusiastic contributions from all the Nashik pediatricians. We are privileged to have Dr. Pradeep Suryavanshi, a renowned neonatologist, to grace us as a guest writer. As we eagerly anticipate the release of our second issue focusing on pediatric and neonatal cardiology, we look forward to a long and vibrant journey with Nashik Pulse. I request Dr. Tarun Kanade sir to come on the stage, and I request all the dignitaries to unveil this copy of Nashik Pulse. Okay. Now, ladies and gentlemen, it is with great honor that I introduce our shining beacon of not only Nashik but throughout Maharashtra and entire India. He has made us immensely proud through his remarkable achievements representing our country with distinction on multiple international platforms. Yes, you all have guessed it correctly. I would like to welcome on stage Iron Man Dr. Arun Gachale sir. His dedication to excellence is exemplified by his completion of prestigious Ironman race multiple times, showcasing unparalleled perseverance and sportsmanship. Moreover, Dr. Gachale has recently scaled new heights by conquering the grueling and physically demanding Comrade Ultra Marathon in South Africa. His accomplishments not only inspire us but also serve us as a testament to his unwavering determination and commitment to pushing boundaries. Please join me in applauding Dr. Arun Gachale for his extraordinary achievements and for his exemplary role model in both medical as well as sporting communities. Now, friends, I would like to felicitate our very hardworking and ever jubilant officials of IIP. I would like, as I take their name, I would like our MOCs, Dr. Sharayu and Dr. Kalyani to felicitate them. Dr. Vikas More, Dr. Praveen Gokhale, Vice President, Maharashtra IIP. Dr. Pramod Kulkarni, EB member of Central IIP, Dr. Sanjeev Joshi, EB member Central IIP, Dr. Renu Boralkar, Dr. Ramakant Patil sir, immediate past president Maharashtra IIP, Dr. Vikas More, okay. Dr. Satish Sahane, Dr. Sushma Save, not reached. Dr. Manjusha Sherkar, Dr. Kundan Chopra, Chopde, sorry, Dr. Kundan Chopde, Manjusha Sherkar. Dr. Kaustubh Deshmukh, and I'll just take the names of those who have not reached in time. Dr. Jitendra Gawane, Dr. Sushma Save, Dr. Ripa Agrawal, Dr. Grivita Raikar, Dr. Mangai Sinha, Dr. Anup Chaudhary, Dr. Sanjay Deshmukh, Dr. Sanjay Pakmode, Dr. Jayant Shah, and Dr. Suresh Bhattad. Now, I would like to call Dr. Ravindra Sonawne sir, organizing chairman of Nashicon 2024 and Maha IP Midterm CME, to say a few words.
पवननी म्हटलं फ्यू वर्ड्स, पण मी बरेच काही वर्ड्स बोलणार आहे. आदरणीय व्यासपीठ, चीफ गेस्ट डॉक्टर रामगोपाल शेजारा, अध्यक्ष महाराष्ट्र स्टेट IIP, डॉक्टर अमोल पवार आमचे परम मित्र, सचिव महाराष्ट्र स्टेट IIP, डॉक्टर मोहन वारके खजिनदार महाराष्ट्र स्टेट IIP, डॉक्टर सचिन चौधरी अध्यक्ष IIP नाशिक, डॉक्टर मिलिंद भराडिया संस्थापक नाशिकॉन 2015 आणि उपस्थित मान्यवर, उत्तर महाराष्ट्र, मराठवाडा, विदर्भ या परिसरातील तमाम बालरोग तज्ज्ञ मंडळी, वेळ व परिस्थिती अभावी मुंबई, दिल्ली, बँगलोर, चेन्नई इत्यादी ठिकाणी होत असलेल्या परिषदांना उपस्थित राहू शकत नव्हते. ह्या बाबी लक्षात घेऊन 2015 साली नाशिक IIPचे तत्कालीन अध्यक्ष डॉक्टर मिलिंद भराडिया यांनी नाशिकॉन या परिषदेची मुहूर्तमेढ रोवली, म्हणजे माझ्या भाषेत झेंडा काढला. ह्या कॉन्फरन्सची उत्तरोत्तर प्रगती ही वाढतच गेली आहे. चंद्रकोर पासून पूर्ण चंद्र होण्याच्या योगात आहे. महाराष्ट्रातील सर्व बालरोग तज्ज्ञ उत्सुकतेने ह्या परिषदेची वाट बघतात, जसे चातक पक्षी पावसाची आणि काही जण रात्री होणाऱ्या बँक्वेटची. ह्या परिषदेचा मुख्य उद्देश ज्ञान साधण्याशिवाय मनोरंजन तसेच नवोदित बालरोग तज्ज्ञांना कलागुणांना व सुप्तावस्थांना वाव मिळावा व त्यांना एक नवीन व्यासपीठ मिळावे हा त्याचा उद्देश आहे. तसेच या परिषदेमुळे सर्व डॉक्टर एकत्र येणारे, काही जत्र्यात हरवलेले काही मित्र पण पुन्हा भेटणार आहेत. ही परिषदेची 8वी आवृत्ती आहे. ह्यावेळी एकूण 650 डॉक्टरांनी रजिस्ट्रेशन केले आहे. त्यामध्ये फिजिकल 450 व 200 ऑनलाईन उपस्थित राहून त्यांचा लाभ घेणार आहेत. आपण हे एक पाऊल डिजिटल इंडियाकडे एक आपलं हे पाऊल आहे. आणि हे जे ऑनलाईन आहे जी मिश्र ही गेल्या या नाशिकॉनमध्ये सर्वप्रथम आपण म्हणजे मिक्स जसं DJ मध्ये आपण मिक्स करतो तसं आपण हे ऑनलाईन आणि फिजिकल ठेवलं आहे. दुसरे वैशिष्ट्य म्हणजे पहिल्यांदाच नाशिकॉनमध्ये 3 वेगवेगळ्या कार्यशाळांचे आयोजन केले गेले. एक प्रोटोकॉल इन न्यूनेटॉलॉजी, पीडियाट्रिक व्हेंटिलेशन आणि मिक्स बॅग वर्कशॉप. हे सगळे तिन्ही वर्कशॉप आपले डॉक्टर वसंतराव पवार मेडिकल कॉलेज येथे घेण्यात आले. याच्यात प्रथमच जवळजवळ 100 MBBS शिकत असलेल्या विद्यार्थ्यांनीही सहभाग नोंदवला. एकूण पार्टिसिपंट्स हे साधारण 200 पार्टिसिपंट्स होते. आणि भारतात प्रथमच MBBS मुलांना वर्कशॉपमध्ये सामील घेण्याचा हा पहिलाच योग असावा. हे वर्कशॉप टोटली फ्री होते. ब्रेकफास्ट, डिनर, ब्रेकफास्ट, लंच आणि तसेच बुकलेट्स, हँडआउट्स हे फ्री वाटले गेले. 15 फॅकल्टीजने तेथे लेक्चर व हँड ऑन ट्रेनिंग दिले. म्हणजे प्रॅक्टिकली जी कार्यशाळा आहे म्हणजे प्रॅक्टिकल गोष्टी तिथे शिकवल्या गेल्या. आणि चांगले फीडबॅक्स हे MBBSच्या विद्यार्थी आणि PG रेसिडेंटकडून पण मिळाल्या. ही परिषद प्रथमच महाराष्ट्र स्टेट IAP व नाशिक IAP यांच्या संयुक्त विद्यमानाने होत असल्याने या परिषदेला राज्यस्तरीय दर्जा प्रथमच प्राप्त झालेला आहे. तर त्याचे श्रेय डॉक्टर आपले महा-IAPचे अध्यक्ष डॉक्टर रामगोपाल चेजारा व आमचे पवार डॉक्टर अमोल पवार परममित्र सेक्रेटरी महा-IAP हे यांना जाते. नॅशनल मेडिकल कमिशनच्या नुसार स्टेट कॉन्फरन्समध्ये एक पेपर किंवा एक पोस्टर हे पदव्युत्तर विद्यार्थ्यांनी हे करणं हे सक्तीचे आहे, कंपल्सरी आहे. तर हे यांच्यामुळे राज्य दर्जाचा हे दर्जा मिळाल्यामुळे ते मुलांना जे पेपर पोस्टर प्रेझेंट करणारे त्यांना हे स्टेट लेवलचे सर्टिफिकेट मिळणार आहे. आणि जवळजवळ 60 पदव्युत्तर विद्यार्थ्यांनी याच्यामध्ये सहभाग घेतला. त्याच्यामध्ये याच्यासाठी डॉक्टर नितीन मेहकरकर पेपर पोस्टर चेअरमन आणि डॉक्टर दीपा जोशी को चेअरमन यांचा मेन रोल होता. अखिल भारतीय बालरोग संघटनेचे राष्ट्रीय अध्यक्ष डॉक्टर बसवराज सर व प्रेसिडेंट इलेक्ट डॉक्टर वसंत खलतकर सर यांनी अध्ययन क्षेत्रात म्हणजे अकॅडमिक क्षेत्रात माझ्यावर काही जबाबदाऱ्या म्हणजे सोपवल्या. एक म्हणजे मला वॅक्सिनॉलॉजी मॉड्यूलमध्ये वेस्ट झोन कोऑर्डिनेटर केले महाराष्ट्र, गुजरात आणि गोवा. आणि तसेच ह्या दोघांनी 2025 मध्ये जी नॅशनल पेडिकॉन येथे हैदराबादमध्ये होणारी जी परिषद आहे, कॉन्फरन्स आहे, त्याच्यामध्ये जे 32 वर्कशॉप्स होतात आहे त्याची देखभाल व सुपरविजन किंवा कोऑर्डिनेटर म्हणून ही जबाबदारी, मोठी जबाबदारी त्यांनी माझ्यावर सोपवली आहे. त्यांचे मी खूप खूप ऋणी आहेत. हे दोघं अकॅडमिक्सवर खूप भर देत आहेत. तर माझी सर्व पदव्युत्तर विद्यार्थ्यांना ही विनंती आहे की त्यांनी लवकरात लवकर लाईफ टाईम मेंबर अजीव IAP मेंबर हे व्हावे, जेणेकरून त्यांना कमी खर्चामध्ये ह्या बऱ्याचशा परिषद अटेंड करता येतील. कोणतेही शुभ काम करताना जसे देवाचे नाव घ्यावे. मी तर काही देव नाही बघितला, कदाचित तुम्ही लोकांनी बघितला असेल, पण माझ्या नाशिकचे जे देव आहे, सिनियर लोक जे पेट्रन्स ॲडवायझर्स जसे डॉक्टर जस पटेल सर, डॉक्टर कश्यपे सर, डॉक्टर टिळक सर, डॉक्टर टेंबे सर, डॉक्टर लड्डा सर, डॉक्टर मानकलाल चोप्रा, त्यांना मी माणिक म्हणतो कारण ते मानकासारखे माणिक जे असतं ना, माणिक त्याची किंमत. जसं आज त्यांनी स्पोर्ट्स कॉम्पिटिशनमध्ये पण म्हणजे 80 वर्षाचे आहेत, पण ते 80 वर्षाचे जवान वाटत होते असे चोप्रा सर. त्यानंतर श्यामा कुलकर्णी मॅडम, संगीता लोढा मॅडम, त्यानंतर आमचे गुरु डॉक्टर रमाकांत पाटील सर, डॉक्टर राजेंद्र कुलकर्णी, डॉक्टर सुरवसे सर आणि सर्व सिनियर्स. आणि हे ज्युनियर्स पण माझे काही गोष्टींमध्ये सिनियर म्हणजे सल्ल्यामध्ये किंवा याच्यामध्ये असू शकतात. तर त्या पद्धतीने मी देवाचं नाव घेऊन हे बाकीच्यांची सगळ्यांची ओळख करून देतो. आता सर्वात पहिले अध्यक्ष डॉक्टर राम गोपाल शेजारा यांचे मी आभार मानतो की त्यांनी चीफ गेस्ट म्हणून जबाबदारी चीफ गेस्ट म्हणून आमचं आमंत्रण स्वीकारलं. तर त्यांचं नाव मला नेहमी मी शेजारा म्हणायचो, पण मग पेपरमध्ये न्यूज देताना चेजारा. माझं आज मराठीमध्ये बोलण्याचा हाच उद्देश आहे की CH हा छ पण होतं, च पण होतं. तर ते असे रामगोपाल चेजारा, त्यांचे ते राम पण आहे आणि गोपाल पण आहे, म्हणजे घर में राम गली में श्याम. त्यांचं खरंच म्हणजे सर्व क्षेत्रांमध्ये अशा पद्धतीने ते काम करत आहेत. 3 दिवसापूर्वी म्हणजे त्यांची आणि माझी फोनवर बोलणी झाली, तर त्यांनी वंदे मातरमबद्दल मला वंदे मातरम जी रेल्वे मुंबईहून नाशिकला सुटणार कोणती वंदे मातरम सेम वंदे भारत ही जी ट्रेन आहे, तर त्याच्याबद्दल मला त्यांनी खूप माहिती सांगितली. आणि म्हणजे असं मला असं थोडं वाटलं त्यांच्या नावाने राम आणि गोपाल आणि वंदे भारत की ते BJPचे प्रवक्ते किंवा काय मोदी साहेबांचे भक्त आहे का असं वाटलं. तर असे आमचे डॉक्टर रामगोपाल शेजारा आमचे चीफ गेस्ट. त्यानंतर आमचे सेक्रेटरी डॉक्टर अमोल पवार आणि पवार हे सारखंच आहे त्यांचं, ते म्हणजे काय म्हणतात इक्वॅलंट नाव झालेले आहे. ते म्हणजे अणुशक्ती आणि इतर बऱ्याच शक्तींचा भांडार आहेत. ते माझे म्हणजे मी त्यांचा कधी काळी गुरु होतो, म्हणजे काही गोष्टीत आहे अजून पण. आणि मी शिष्य पण आहे. म्हणजे जी तलवार असते ज्याला दुहेरी धार असते, तसे आमचे डॉक्टर अमोल पवार, म्हणजे ते कोणाला टोपी घालू देत नाही, त्यामुळे तर हे असे परम माझे मित्र डॉक्टर अमोल पवार. आता हे जी कॉन्फरन्स जी नाशिकॉन ही जी घडून येते, त्याचे म्हणजे मेन बॉस आमचे डॉक्टर सचिन चौधरी IAP प्रेसिडेंट, जे म्हणजे शांत संयमी व कुशाग्र बुद्धिमत्ता असा त्रिवेणी संगम लाभलेले व त्रिमूर्ती चौक जवळच त्यांची प्रॅक्टिस आहे. तर असे आमचे मित्र मला लाभले. सचिन पिळगावकर, सचिन तेंडुलकर यांचे बरेचसे गुण त्यांच्यामध्ये आलेले आहेत. आणि ते संध्याकाळी गाण्याची पण जादू हे करणार आहे, जादू तेरी नजर म्हणून. त्यानंतर कुशल संघटक, उत्तम नियोजन, मितभाषी अशा अनेक गुणांचा मिलाप असलेले आमचे लाडके मित्र डॉक्टर मिलिंद भराडिया. गोविंदा समजू घ्या, गोविंदा आहे जे कोण पिक्चर मधला गोविंदा किंवा कृष्णाचं पण दुसरं नाव गोविंदा आहे. तर ते असे आमचे कलाकार. आणि नासिकॉन आणि लव यू जिंदगी हे आता फक्त स्टेटमध्ये नाही राहिला, हा त्यांचा ब्रँड हा भारतात आणि इंटरनॅशनल कदाचित म्हणजे अंतराळ याच्यात पण कदाचित जात आहे. ती येईलच, वेळ लवकरच येईल. तर यांनी नासिकॉनचे बीज 2015 साली रोवले आणि आता त्याचे मोठ्या वृक्षात रूपांतर होताना दिसत आहे. हे सचिन सर, मिलिंद सर आणि मी म्हणजे आम्ही असे 3 इडियट्स. म्हणजे मी तापट, बिलकुल संयमी नसलेला, आणि हे दोघं म्हणजे शांत, संयमी, गोड बोलणारे. म्हणजे जरी मी म्हणजे बोलताना तापट असलो पण मनाने गोड आहे, ते वेगळं गोष्ट. तर हे असे तिघं असे वेगवेगळे विजातीय ध्रुव एकत्र आले. आपल्याला मित्रांनो माहिती आहे की सजातीय ध्रुवामध्ये नेहमी रिपल्शन असतं आणि विजातीय ध्रुवामध्ये आकर्षण असतं. ते असे 3 असे विभिन्न 3 इडियट्स हे एकत्र आले आणि त्यामुळे आज ही कॉन्फरन्स सक्सेसफुल होत आहे किंवा होणार आहे. तरुण तडफदार व जंजीरचे यंग अँग्री मॅन. ॲक्च्युली जंजीरमध्ये एकच अमिताभ बच्चन होता. माझी इच्छा असती तर मी डबल रोल घेतला असता अमिताभ बच्चनचा. तर ते याच्यासाठी म्हणतोय, डॉक्टर सचिन पाटील व डॉक्टर पवन देवरे हे दोघं सचिव, त्यांच्यावर टाकलेली सर्व जबाबदारी काही कुरकुर न करता धडाडीने पार पाडत होते. जसं आपण जस्ट 20 जो वर्ल्ड कप जो बघितला आपण, त्याच्यामध्ये ऋषभ पंत किंवा तो सूर्यकुमार यादव, म्हणजे तो सूर्यकुमार यादव चौके छक्के पण मारत होता आणि तो बाउंड्रीच्या बाहेर जाऊन तो कॅच पण करत होता. असे हे दोघं यांनी सर्व कामं म्हणजे 360 डिग्रीमध्ये हे कामं असे वेड्यासारखे करत होते. वेडे नाही झाले ते, अजून म्हणजे अजून त्यांना बरंच काम करायचं आहे. तर असे दोघं जोडी. त्यानंतर डॉक्टर प्राची बिरारी ही माझी UGची आणि PGची स्टुडंट, मी गर्वाने सांगू शकतो. अतिशय ॲक्टिव्ह, अतिशय शार्प डोक्याची. 2011 साली MCIचे ते जे इन्स्पेक्टर AK दत्ता सर आले ते, त्यांना फक्त सगळ्या केसेस प्रेझेंट करण्यामध्ये इतकं फिरवलं त्यांनी की त्यांनी बाकीचं काहीच बघितलं नाही ना आम्हाला त्यावेळी MCIची मान्यता दिली. अशी ती आमची प्राची बिरारी. हिने आर्थिक नियोजन व तसेच कला व सांस्कृतिक मंडळाची म्हणजे कल्चरल कमिटीची ही जी धुरा ती व्यवस्थित पार पाडली. आणि ते आपल्याला बँकेटमध्ये रॅम्प वॉक किंवा डान्स किंवा गाणे किंवा DJ हे या स्वरूपात ते दिसून येणारच आहे. आता डॉक्टर सोनाली पारदी सहसचिव यांनी सर्व ठिकाणी हातभार लावला. यांनी सर्व मीटिंग्स आवर्जून त्या उपस्थित राहिल्या आणि बऱ्याच इनोव्हेटिव्ह आयडिया सांगितल्या. हे जे पल्स वगैरे हे तिचं फार योगदान आहे. बऱ्याच इनोव्हेटिव्ह आयडिया सांगितल्या ज्या की तीच स्वतः करू शकते. आमचं तर आता तेवढं डोकं चालत नाही, ती वेगळी गोष्ट. आता परिषदेचा मुख्य गाभा हा, कोणत्याही परिषदेचा मुख्य गाभा हा सायंटिफिक प्रोग्राम असतात. तर असे हे आमचे अकॅडमिकचे करण अर्जुन किंवा धरमवीर डॉक्टर अमोल मुरकुटे आणि डॉक्टर प्रवीण काळे यांच्यासाठी जोरदार टाळ्या होऊन जाऊ दे. यांनी हे त्यांच्या कुशाग्र बुद्धिमत्तेने ही जबाबदारी ते व्यवस्थित पार पाडताय. या 2 दिवसाच्या परिषदेमध्ये जवळजवळ 50 व्याख्याते राज्य व राष्ट्रीय स्तरावरून येथे व्याख्यान देऊन ते सहभाग नोंदवणार आहेत. तर आता सर्वात आमची सहकारी असोसिएट प्रोफेसर, कारण आमच्या सहकाऱ्यांची आठवण करावंच लागेल कारण मला तिथे मेडिकल कॉलेजमध्ये काम पण करायचं आहे आणि त्यांनी तसं काम करून पण दाखवलेलं आहे. अशा त्या डॉक्टर दीपा जोशी या परिषदेच्या 3 कार्यशाळेंची नियोजनाची जबाबदारी वर्कशॉप कमिटी चेअरमन म्हणून व तसेच पेपर पोस्टर जे 60 पेपर्स आता पोस्टर्स प्रेझेंट होतात त्याचे को चेअरमन म्हणून दुहेरी जबाबदारी ही उत्तमरित्या पार पाडली आहे. आणि डॉक्टर नितीन मेहकरकर हे जे आमचे HOD SMBT हे आमचे असे परम मित्र आहे. काय जास्त घनिष्ठ मित्र असल्यावर जसं ते अमिताभ बच्चन आणि शत्रुघ्न सिन्हांसारखे भांडणं होतात किंवा जे तसे पण होतात आणि एकत्र पण येतो, तर तसे आमचे हे डॉक्टर नितीन मेहकरकर यांनी पेपर पोस्टर चेअरमन म्हणून ही जबाबदारी मोठी शिताफीने पार पाडली आहे. आणि हे जे सर्व स्टुडंट्सला जे सर्टिफिकेट जे NMC साठी खूप गरजेचं असतं, तर ते सर्टिफिकेट्स व्यवस्थित चुका न करता ते बनवण्याचं काम हे डॉक्टर नितीन यांनी केलेलं आहे. आता डॉक्टर राहुल कोपीकर जे स्वर्गीय डॉक्टर गौतम कोपीकर यांचे सुपुत्र, आपण डॉक्टर गौतम कोपीकर सरांचे ओरेशन उद्या घेतो आहे. नितीन शहा सर येणार आहेत. तर राहुल कोपीकर म्हणजे बाप नंबरी बेटा 10 नंबरी. कारण आणि मी हे असं नाही बोलत आहे कारण मी दररोज त्याला बघतो आहे. तर त्याचं अकॅडमिक नॉलेज त्यांच्या वडिलांना पण बघितलेलं आहे, तर त्याचं अकॅडमिक नॉलेज खरंच सुंदर आहे. तर जे म्हटलंय की बाप नंबरी बेटा 10 नंबरी, राहुल कोपीकर हा भरपूर अकॅडमिक याच्यात भरपूर पुढे जाणार आहे आणि त्यासाठी माझे आशीर्वाद त्याला आहेत. सगळे सोंग आणता येतात पण पैशाचे सोंग आणता येत नाही. नवरा सगळं कोलूला जुंपलेल्या बैलासारखा कष्ट करून पैसे आणून देतो आणि तो शेवटी बायकोला देतो. बाकीचे देतात की नाही ते माहीत नाही. पण तसं आर्थिक नियोजन समितीचे जे प्रमुख डॉक्टर वैशाली भराडिया यांनी ही जबाबदारी मी आपले जे फाउंडर आहेत डॉक्टर मिलिंद भराडिया त्यांचे पतिदेव यांच्या विनंतीने ती स्वीकारली आणि त्यांनी ही जबाबदारी खूप सुंदर पार पडली. आज आपल्याला त्यांच्या याच्यामुळे 30 स्टॉल्स हे आपल्याला मिळालेले आहे. त्यामुळे हा जो कार्यक्रम आहे, जो असा नाश्ता आपण एकदम असा आलिशान नाश्ता करतोय किंवा जे काय करतो आहे हे ते भराडिया सरांच्या सौबाईमुळे आहे. स्वागत समितीचे अध्यक्ष डॉक्टर साधना पाटील मॅडम. सॉरी मॅडम, मी रात्री त्यांना मी ॲक्च्युली व्हॉट्सअप केलं की मॅडम मला पहिले सकाळी पहिले 2 तास फार लागेल, शीतल पगार किंवा चैताली किंवा कृष्णा पवार, ते म्हटलं पहिले 2 तास मला लागतील. ऑस्ट्रेलिया किंवा इंग्लंड इथे पहिल्या 10 ते 15 ओव्हरमध्ये तिथे टिकणं हे फार अवघड असतं. तर हे मोठी जबाबदारी या 4 जणांवर दिली होती आणि त्यांनी ती पार पाडली. त्याबद्दल त्यांचे मी खूप आभार मानतो. आणि रजिस्ट्रेशन कसे जास्तीत जास्त होतील ही जबाबदारी यांनी ती पार पाडलेली आहे. या परिषदेची सामाजिक स्तरावरील म्हणजे सोशल मीडिया आपण तो शब्द वापरतो, उत्तमरित्या जाहिरात करण्याची आणि सगळ्यांची मध्ये मध्ये करमणूक करण्याची, म्हणजे त्यांना महाराष्ट्रात म्हणजे पैसे जमवायला वेळ नसतो, पण तरी त्यांनी म्हणजे असे आमचे खजिनदार डॉक्टर मोहन वारके यांनी ती धुरा खूप व्यवस्थित सांभाळली. आता अजय अतुलकडे येतो. म्हणजे अतुल अजय ते वाजवतात, म्हणजे संगीत वाजवतात, पण हे डॉक्टर गौरव नेरकर आणि डॉक्टर अतुल बोंडे हे दोघं म्हणजे निवास व्यवस्था अकोमोडेशन व दळणवळण व्यवस्था, म्हणजे दळण किंवा वळणाने घेऊन तसं नाही, वाहतूक व्यवस्था ट्रान्सपोर्ट याची ती जबाबदारी खूप म्हणजे किचकट जबाबदारी असते, ती त्यांनी सांभाळली. या परिषदेचे उत्तम सूत्रसंचालन करण्याचे काम डॉक्टर स्वाती भुतडा, डॉक्टर सुवर्णा देवरे व त्यांचे इतर सहकारी वर्गांनी सांभाळले आहे आणि ते योग्य पद्धतीने करतील. डॉक्टर शीतल पगार, डॉक्टर अरुण गचाले व डॉक्टर दिनेश ठाकूर यांनी स्पोर्ट्स क्रीडा कॉम्पिटिशन स्पर्धा घेऊन सर्व बालरोग तज्ज्ञांमध्ये नवचैतन्य निर्माण केले व पहिल्या 3 जणांना 3 स्पर्धामध्ये आणि वयोगटानुसार ते त्यांना पारितोषिक देण्यात आले. मी ऑलरेडी 80 सालाचे जवान त्यांचा उल्लेख केला आहे डॉक्टर माणकलाल चोप्रा सरांचा. तर कन्व्हेनर आणि तर ऑलरेडी बरेचसे बक्षिसं तिकडे दिले गेलेले आहे. कन्व्हेनर म्हणून डॉक्टर ममता अग्रवाल, शीतल पगार, डॉक्टर सागर सोनवणे, डॉक्टर प्रितेश देवरे यांचेही मोलाचे सहकार्य लाभलेले आहे. सर्वात महत्त्वाचं, आता पोटात गेल्याशिवाय काही सुचत नाही. डोक्यात जर ऑक्सिजन म्हणजे ग्लुकोज कमी झाला तर डोकं चालत नाही. तर डॉक्टर प्रकल्प पाटील, डॉक्टर सागर भालेराव आणि डॉक्टर योगेश पाटील यांनी मेजवानीचा फडशा नाही पाडला. मेजवानी म्हणजे बँक्वेट तसेच खानपान यांचे नियोजन ते व्यवस्थित करत आहे. याचा अनुभव हा तुम्हाला येतच आहे आणि संध्याकाळी पण येणार आहे. आणि याच्यात अजून एक विशेष, डॉक्टर राजेंद्र कुलकर्णी सर यांनी जे डॉक्टर गौतम कोपीकर सर ओरेशनसाठी जे डॉक्टर नितीन शाह सर येणारे यांचे सायटेशन केलेलं आहे. ते आता सध्या नाही आहे, ते परदेश दौऱ्यावर आहेत, तर त्यांचेही मी आभार मानतो. आणि सर्वात महत्त्वाचं, पडद्याच्या मागे काम करणारे खरे कलाकार, खिंड लढवणारे बाजी प्रभू, ओळखा पाहू कोण 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 असू शकतं. एक जण जो म्हणजे सगळे म्हणजे सगळे त्या एका पर्सनच्या हाताखालून जातात किंवा ते म्हणजे जे काय असेल, तर असे हे आमचे दत्ताभाऊ. कधीही कुठल्याही कामाचा कंटाळा न करता सतत कार्यमग्न असणारे असे आमचे दत्ताभाऊ. आणि सर्वात शेवटी कुठलीही परिषद यशस्वी होण्यासाठी सांघिक जबाबदारी ही महत्त्वाची असते. जर कोणाचेही नाव यात चुकून नाव राहून गेले तर क्षमा असावी. कारण हे चेअरमन किंवा मुलीचा वडील असताना म्हणजे चूक नसताना किंवा चूक असताना पाया पडावा लागतो. आणि थोडीफार कंबरदुखी आहे मला, ती रात्री बहुतेक म्हणजे गाणे, डान्स, डीजे किंवा जे काही असेल त्याच्यानी ती दूर होईल. तर सर्वांचा मी म्हणजे माझं हे बोर भाषण 10 मिनिटं ऐकलं त्याबद्दल धन्यवाद आणि मी थँक्यू.
Thank you, Ravindra Sonavne sir, for this wonderful speech. Now I request Dr. Milind Bharadia sir, our founder president of Nashicon, to give his president speech.
Hello. खरं तर विराट कोहलीने इतकी जोरदार बॅटिंग केली आहे. खरं मी बोलू का नको आता हाच एक माझ्या डोक्यात विषय येतोय. नाही नाही, विराट कोहलीने खूपच छान पद्धतीने सगळं बोललंय. असो, 1972 साली 8 सदस्यांच्या मदतीनं ज्यांनी नाशिक IIPची स्थापना केली असे डॉक्टर काश्यप्पे, डॉक्टर टिळक, डॉक्टर JS पटेल सर, डॉक्टर कानडे सर, कासलीवाल सर, ह्या सगळ्यांना मी पहिले वंदन करतो. जर तुम्ही ह्या नाशिक IIPची स्थापनाच केली नसती सर तर आम्ही इथपर्यंत पोहोचलोच नसतो. मित्रो, 13 जून 2015 ही तारीख नाशिक IIPच्या इतिहासात सुवर्ण अक्षरात लिहिली जाईल. त्या दिवशी नाशिकॉनची सुरुवात झाली. असो, आजच्या कार्यक्रमाचे अध्यक्ष डॉक्टर रामगोपाल छजेरा, IIP प्रेसिडेंट. आयुष्यामध्ये कितीही संकट आली तरी त्याच्यावर मात कसं करायचं ह्या व्यक्तीकडनं बघावं. डॉक्टर अमोल पवार, IIP सेक्रेटरी, ज्याने त्याची राजकीय सुरुवात ह्या नाशिकॉनच्या सेक्रेटरी पदापासून केलेली आहे. तो EB मेंबरही आहे आणि तो नॅशनल कन्व्हेनरही आहे. शांत डॉक्टर सचिन चौधरी, थोडंसं भाषण आटोपतं घेतोय, बरंच बोलायचं होतं पण आता वेळेचं बंधन आहे याची मला कल्पना आहे. डॉक्टर सचिन चौधरी, नाशिक IIP प्रेसिडेंट. शांत आणि संयमी नेतृत्व. मोदीजींना ह्या कॉन्फरन्सची नोंद घ्यावा लागली ही फक्त आणि फक्त आपला लाडका IIPचा सेक्रेटरी डॉक्टर मोहन वारके, डॉक्टर रवी सोनवणे यांच्याबद्दल बोलायचं म्हणजे खरंच सूर्याला आरसा दाखवण्यासारखं आहे. ही इज अ ग्रेट पर्सनॅलिटी अँड HOD ऑफ द NDMAP मेडिकल कॉलेज पीडियाट्रिक्स डिपार्टमेंट. सचिन पाटील, नाशिक IIP सेक्रेटरी, अतिशय उमदा कार्यकर्ता. डॉक्टर प्राची बिरारी, ट्रेजरर. शी इज associated with the Nashicon since 2015. She is a part of all the organizing committee since 2015. She is a hardcore supporter of the Nashicon. Dr. Pawan Devre, very committed personality, but at the same time very down to earth. Dr. Sagar Balerao, President-elect, and Dr. Sonali Pardi, जिचा आता Pulse is her brainchild. मित्रो, ह्या नाशिक IIPने मला जो मान दिला, जो मला सन्मान दिला, मला एक ओळख दिली, फाउंडर प्रेसिडेंट ऑफ द नाशिकॉन. खरंच ह्या नाशिक IIPiansचा मी आयुष्यभर ऋणी राहील आणि मला ऋणातच राहायला आवडेल. मागच्या 10 वर्षापासून नाशिकॉन ही कॉन्फरन्स आम्ही घेतो आहोत. तर वैयक्तिक जर मला विचाराल तर मी ह्या 10 वर्षामध्ये काय कमवलं तर हे कमवलं. ह्या LED वॉलवर जेवढे तुम्ही आज सगळे माझे मित्र बघतायत, this is my earning, that is what I earn. I really thanks Nashicon for giving me such a wonderful friends. Why Nashicon? Nashicon. Why Nashicon is such a great and very successful startup. एकाच वाक्यात सांगतो. लहानपणी पसायदान होताना एक संत ज्ञानेश्वरांचं पसायदान होत असताना तिथे एक वाक्य नेहमी मला शिकवलं जायचं, जो वांछिल तो ते लाभो प्राणी जात. अशी ही आमची नाशिकॉन. इथे कोणालाही सांगावं लागत नाही, सगळी लोक एकत्र येतात आणि खूप जोरात काम करतात. देर इज समथिंग फॉर एव्हरीवन अँड नॉट एव्हरीथिंग फॉर समवन. प्रत्येकाला काहीतरी आहे इथे. मित्रो, नाशिकॉनचा जेव्हा आम्ही जर्नी विचार करतो, 2015 साली आम्ही जेव्हा सुरुवात केली तर गौतम कोपीकर ओरेशन हे थोडंसं मागे पडलेलं होतं, ते आम्ही पुढे नेण्याचं काम केलं. कोणी दिलं ओरेशन? यू जस्ट नेम द एनी नॅशनल फॅकल्टीज, दे हॅव केम हिअर अँड गिवन दे हॅव गिवन द ओरेशन. उमा अली मॅडम असतील, उपेंद्र किंजोडेकर सर असतील, प्रमोद जोग असतील, अशी सगळी मंडळी ह्या सगळ्या ओरेशनसाठी आली. थँक्स टू ऑल सायंटिफिक कमिटी चेअरमन. 500 पेक्षा कधीच कमी रजिस्ट्रेशन ह्या नाशिकॉनमध्ये आजपर्यंत झालेले नाही आहेत. फार्मा कंपनीज, जस्ट फोन कॉल अवेज. मित्रो, हे सगळं आणि सगळं ह्या नाशिक IAPच्या सांघिक नेतृत्वाने आणि सांघिक बळाने आम्ही हे करू शकलो. आज इथे बरेचसे स्टेट लीडर आलेले आहेत, सगळे नॅशनल लीडर्स आलेले आहेत. त्यांना मी सांगू इच्छितो की तुम्ही नाशिकांसारख्या ज्या कॉन्फरन्सेस होत आहेत त्यांना तर तुम्ही बळ देताच, आता अजून बळ देण्याचा प्रयत्न करा. आपल्या सगळ्यांना माहिती असेल राहुल द्रविड वेन ही वॉज अ BCCI सिलेक्शन कमिटी चेअरमन त्यांनी काय केलं. त्यांनी सगळ्यात महत्वाचं, ही हॅज अटेंडेड ईच अँड एवढी रणजी ट्रॉफीला गेले, दुलीप ट्रॉफीला गेले, तिथे जाऊन एक एक खेळाडू त्यांनी तयार केला. शुभम गिल असेल, विराट कोहली असेल, हू फाइंड देम, दॅट इज अ राहुल द्रविडची फाइंड होती. ह्या सगळ्या आज जे इथे आदरणीय नेतृत्व आलेलं आहे, मला त्यांना हेच सांगायचं आहे की अशा ज्या नाशिकॉन सारख्या ज्या कॉन्फरन्स आहे याच्यामध्ये तुम्हाला तळागाळात काम करणारा कार्यकर्ता भेटेल. आणि हा कार्यकर्ता जेव्हा सेंट्रल IAP मध्ये जाईल, जसं राहुल द्रविडने एक प्रशिक्षक म्हणून चांगलं काम केलं आणि आपण वर्ल्ड कप जिंकलो, तसं ही सेंट्रल IAP खूप स्ट्रॉंग करू शकतो. आपण आपल्या हक्कासाठी लढू शकतो जर ह्या प्रत्येक नेतृत्वाला जर आपण पुढे आणलं तर ह्याला आपण बळ दिलं गेलं पाहिजे. मित्रो, खूप काही बोलायचं आहे पण आता वेळेचं बंधन आहे. जाता जाता एकच सांगू इच्छितो, ही नाशिकॉन करताना ज्या कोणी मला सहकार्य केलं, सगळ्यात महत्वाचं माझे 2015चे सगळे सहकारी डॉक्टर नितीन बेकरकर, डॉक्टर राहुल पाटील, डॉक्टर प्रवीण गडसिंग, डॉक्टर प्रवीण भांबरी, डॉक्टर वैशाली भराडिया, दत्ताभाऊ केदार, ह्या सगळ्यांनी मला खूप बळ दिलं. माझी जी संकल्पना होती त्यांनी उचलून धरली, त्यामुळे मी हे करू शकलो. ही नाशिकॉनची पालखी पुढे नेण्यासाठी ज्यांनी मला मदत केली असे एक ना अनेक नावं आहेत. त्याच्यामध्ये मी प्रामुख्याने सांगू शकतो, एखाद्याचं नाव चुकलं तर क्षमस्व. ह्याच्यामध्ये डॉक्टर नितीन सुराणा आहे, डॉक्टर अनिरुद्ध भांडारकर आहे, नंतर डॉक्टर संजय आहेर आहेत, डॉक्टर रमाकांत पाटील, डॉक्टर केदार मालवतकर, अनिल कासलीवाल सर, शर्मिला कुलकर्णी, संगीता लोढा, अमोल मुरकुटे, प्रवीण काळे, अशी बरीचशी मंडळी आहे का ज्यांनी ही नाशिकॉनची पालखी पुढे नेण्याचं काम केलं. पण सगळ्यात महत्वाचं काम जर कोणी केलं असेल तर शी इज माय बेटर हाफ, डॉक्टर वैशाली. मित्रो, मागच्या 20 ते 22 वर्षापासून नाशिक IAP साठी काम करताना आणि नाशिकॉनसाठी काम करताना मला माहिती आहे किती वेळ द्यावा लागतं. आणि हे ऑर्गनायझेशन मध्ये जी लोक इथं बसलेले आहेत त्यांना माहिती आहे की यू हॅव टू गिव्ह लॉट्स ऑफ युअर पर्सनल अँड प्रोफेशनल लाईफ, यू हॅव टू सॅक्रिफाईस दॅट. पण हे सगळं करत असताना तिने माझी प्रोफेशनल अँड द पर्सनल फॅमिली लाईफ कधीच हॅम्पर होऊ दिली नाही. एवढंच नाही, दोन्ही मुलांना तिने एम्सला धाडलं, हे सगळं तिचं कर्तृत्व आहे. वैशाली ने जर सपोर्ट केला नसता तर मी हे करू शकलो नसतो. आय एम अ जस्ट फेस प्रेझेंटेशन ऑफ दिस. पुनश्च एकदा आपल्या सगळ्यांचे खूप मनापासून आभार मानतो आणि मला इथं बोलण्याची संधी दिल्याबद्दल नाशिक IAPचे, नाशिकॉन टीमचे पुनश्च एकदा आभार मानतो. भेटूया मित्रो पुढच्या वेळेसच्या नाशिकॉन 2025 मध्ये, कारण ही नाशिकॉन चालूच राहणार आहे. Till the last breath of my life, I will try to see that the Nashicon, with the help of you all, we will take to the new heights. कारण नाशिक IAP न एक ध्येय ठेवलेलं आहे 2035. हे आम्ही पेडिकॉन म्हणून 2035ला आम्ही पेडिकॉनला बीडच करणार आहोत. त्याकरता आम्हाला आत्तापासूनच आमचे नेतृत्व तयार करायचे आहेत आणि त्यासाठी नाशिकॉन सारख्या कॉन्फरन्सची आपल्याला खूप मदत होणार आहे. धन्यवाद. थँक्यू. लव यू ऑल. लव यू जिंदगी.
Ravindra Sonone sir has to make few announcements.
ॲक्च्युली 4 वाजता रात्री झोपल्यामुळे कदाचित काही गोष्टी आम्ही विसरून जातो, घरचे मेंबर्स विसरून जातो. असे आमचे घरचे मेंबर डॉक्टर अनिल कासलीवाल सर, जे चेअरमन आहेत गुरुदक्षिणा येथे होणाऱ्या डॉक्टर आठवले फाउंडेशनची जी कॉन्फरन्स होत आहे इन्फेक्शियस डिझीजवर, जी सर्वप्रथम महाराष्ट्राच्या म्हणजे मुंबईच्या बाहेर होत आहे, त्यांचे ते चेअरमन आहे आणि मी त्यांचा को चेअरमन आहे आणि मी ते विसरून गेलो, त्याबद्दल क्षमस्व. आणि तसेच माझी वाईफ जी फिजिशियन आहे ती SMBTला असोसिएट प्रोफेसर आहे आणि माझ्या दोन्ही मुली, जी मोठी मुलगी माझी 12वीत आहे ते मला बराच म्हणजे मी माझ्या मोठ्या मुलीला वेळ देऊ शकलो नाही, कदाचित 8 तारखेपासून मी देऊ शकेल, तर त्यांचेही नाव मी विसरून गेलो. बस एवढंच बोलायचं.
Thank you, sir, and thank you, Milind Bharadia, sir, for being such an inspiration for us. I now request Dr. Sachin Chaudhary, sir, Nashik IIP President, to give his presidential speech.
Hello. Good afternoon, everyone. Good afternoon to respected dignitaries on dais, Dr. Ram Gopal Chezara, Dr. Amol Pawar, Dr. Mohan Varke, and all my team in Nashicon for Nashicon 2024. I welcome you all Nashicon delegates here for the wonderful conference that is being held today and tomorrow. Yesterday also there were very innovative and educational workshops conducted at Dr. VNP Medical College and Research Center. Workshops were a great hit actually. Almost 150 delegates they attended workshops. Today also we have achieved our basic target of registering for 500 plus delegates. That also we achieved. Just we are running late, so I will cut short my speech. I am requesting you all to register for upcoming Adolescon, which is a national adolescent conference being held in September 27 to 28th September in Nashik at the same venue. The QR code or the registration counter, they are open outside. You can just avail that facility and get registered for this conference. Actually, there was a big speech, but since we are running late, I will cut short. First, I will express my sincere thanks to my seniors, Dr. Kashyap sir, Dr. Patel sir, Dr. Kanade sir, Tilak sir, Kasliwal sir, Chopra sir, or R.D. Patel sir, and all other names. With this, I hand over my mic to Dr. Pawan Devre and ask him to conduct further proceedings.
Thank you, sir, for this short and sweet speech. And I request our MOC committee members to felicitate few members of IAP who were not there during the first felicitation. I request to come forward Dr. Sushma Save madam. And I request Dr. Swati Bhutada madam to felicitate Dr. Sushma Save madam. I request Dr. Renu Boralkar madam to come ahead. Dr. Manjusha Sherkar, Dr. Sanjay Deshmukh, and Dr. Sanjay Pakmode. Now, ladies and gentlemen, a very special a person, Dr. G.V. Basavaraja sir, National President Central IIP, is going to share his video greetings through a video message.
Namaskar. Greetings from Indian Academy of Pediatrics on behalf of 45. Rewind करून परत लावा. Namaskar. Greetings from Indian Academy of Pediatrics on behalf of 45,000 members. Let me congratulate our IIT Nashik branch for organizing Nashicon and bring them the Nashicon president Dr. Sachin Chaudhary, the secretary Dr. Sachin
well supported by our National President-elect Dr. Vasant Kalatkar and our immediate past President Dr. Upendra Kinjidekar. They are all doing a great academic work across the Maharashtra. Best wishes for the IDCA. Our the oration lecture, which is going to be delivered by none other than our President, Dr. Nitin Shah, who has been a dying in the field of pediatrics and infectious disease and hematology. So, and of course many other faculties who has been deliberating, their presence here will make a big difference. I was supposed to be here, I am missing the thing. Best wishes for this program on behalf of Central IAP, our National General Secretary Dr. Yogesh Pari, the first National Treasurer Dr. Atanu Badra, with all the IAP Executive Board members. Best wishes to this conference. Thank you very much. Namaskar. Greetings from Indian Academy of Pediatrics on behalf of 45,000 members.
I thank Dr. G.V. Basavaraja sir for his greetings for our conference, which he couldn't come physically, but he made sure that his wishes are with us. And another special message from Dr. Vasant Kalatkar sir, who is President-elect of National IAP, and he is going to share his video greetings through a video message.
IAP तर्फे मी सर्वांचं स्वागत करतोय ॲज अ प्रेसिडेंट इलेक्ट 2024 आणि मला या पदाबद्दल तुम्ही भूषवलं, तुम्ही मला निवडून आणलं त्याबद्दल खरंच मी तुमचा सगळ्यांचा स्पेशली महाराष्ट्रीयांचा आभारी आहे. आता नाशिकॉन या कॉन्फरन्सकडे वळू आपण. खरंच एक म्हणजे आश्चर्याची आणि कौतुकाची गोष्ट आहे की ही 8व्या वर्षात नाशिकॉन पदार्पण करते आणि यात बेसिकली मला माहिती आहे नाशिकचे जेवढे लोक आहेत ते अत्यंत भरारीचे आणि उत्साहपूर्वक लोक आहेत. म्हणजे जेंट्स असो लेडीज असो मेंबर्स आपले सगळे टोटल जे 200च्या वरती मेंबर आहेत सगळे अगदी उत्साहवर्धक आहे. मला थँक्यू म्हणायचं आहे किंवा अभिनंदन करायचं आहे डॉक्टर सचिन चौधरी जे की याचे प्रेसिडेंट आहे आणि डॉक्टर सचिन पाटील जे की सेक्रेटरी आहे त्यांनी हे केलं आहे. तसंच मुख्य कणा जो असतो ऑर्गेनिक चेअरपर्सन ते डॉक्टर रवींद्र आबा सोनोने, तर यांचा खूप मोठा सहभाग आहे, त्यांनी मला वारंवार सांगितलेलंच आहे. तसंच सर्वात महत्त्वाचं म्हणजे सोबतच डॉक्टर मिलिंद बर्डी यांनी केलेलं काम तुम्हाला माहितीच आहे की महापेडिकॉनमध्ये किती त्यांनी काम केलं होतं. याची सर्वात मोठी जमेची जी बाजू आहे ती बाजू अशी आहे की ही मिड टर्म CMA ऑफ महाराष्ट्र जी सोबत नाशिकॉन यावेळी होते. खरं तर हा योगायोग खूप चांगला आहे आणि तुम्हाला माहिती आहे महाराष्ट्राचं मेन म्हणजे मेंबरशिप याची जी संख्या आहे ती मोर दॅन 5,000 आहे आणि एवढ्या मोठ्या ब्रँचच्या सोबत ही नाशिकॉन होणं म्हणजे खरंच एक चांगली गोष्ट आहे. अर्थात याचं सगळं श्रेय आपले प्रेसिडेंट महाराष्ट्र IAPचे प्रेसिडेंट डॉक्टर शेजारा, सेक्रेटरी डॉक्टर अमोल पवार आणि डेफिनेटली ट्रेझरर हवा असतो आपल्याला मोहन वारके, या सगळ्यांना जातं. मी सगळ्या नाशिकवासियांचं पुनश्च एकदा अभिनंदन करतो आणि नाशिकांना ऑल द बेस्ट देतो. थँक्यू. नमस्कार. सर्वप्रथम
I thank Dr. Vasant Kalatkar sir for his best wishes. Now friends, I would like to tell you a very special thing that Maharashtra IAP cricket team has won a third time cricket trophy at the National Pedicon, and this is a tremendous feat which has been achieved. And to lift the trophy along with the Dr. Ramgopal Chejar sir, I would like to invite the captain of our Maharashtra IAP team, Dr. Bhupesh Bond, Vice Captain Dr. Mohan Warke, Dr. Amol Pawar and Dr. Vinod Garje to come on the stage. Dr. Bhupesh Bond, Captain of Maharashtra IAP cricket team, Vice Captain Dr. Mohan Warke, Amol Pawar sir and Dr. Vinod Garje. Ram Gopal Chejara to release the copy. E-copy.
Thank you very much. I declare that officially we are releasing the Darpan. It will be in the digital format just to save the environment. So officially the Darpan is released and we will send the copy to each and every member. Please go through it. It is a very hard work done by our editors, Dr. Mangai Sinha, Dr. Ripa Agarwal, Chief Editor Amol Pawar and Dr. Vishal Raut.
Thank you, sir. I now request Dr. Amol Pawar, sir, Secretary Maharashtra IAP, to share a few words.
Thank you, Pawan. सर्वप्रथम महाराष्ट्र IAP तर्फे सर्वांना वेलकम. वेळ बराच झालेला आहे तरीसुद्धा काही व्यक्तींची नावं घेणं क्रमप्राप्त आहे. सर्वप्रथम डॉक्टर राम गोपाल चेजारा, महाराष्ट्र IAP प्रेसिडेंट, he has consented to allow the executive board member to hold this conference, this midterm CME along with Nashicon, and gracefully that was accepted by Dr. Sachin Chaudhary sir, Dr. Milind Baradia sir, Dr. Ravi Abha Sonone sir, and entire team. So Maharashtra IAP executive board meeting will be happening after lunch, and this Nashicon conference, I was also part of it. In 2018, the conference was held, and entire North Maharashtra and some of the people from Thane, they came here and they enjoyed. And already Dr. Ravi Abha Sonone sir has already told the history of Nasik IAP, starting from the branch formation by Dr. Kashyap sir, Patel sir, Tilak sir, and Kasliwal sir, and everybody. So I won't take all the names, but this is a collective effort of all Nashik IAP members and the nearby branches members. Malegaon IAP is there, which is a sub branch of Nasik district, another sub branch. I wish all the best to entire team for the remaining 1.5 days of the conference, and say goodbye. Thank you.
Thank you, Amal Pawar sir, for this short and sweet speech. I would like to request our chief guest, Maharashtra IAP President, Dr. Ram Gopal Chejara sir, to give his presidential speech at this dais.
Good afternoon, friends. I should say sorry if whatever I am going to speak in next 1 minute, if it hurts someone. The inauguration, the time given was for the 20 minutes, and I think people come here to learn the science. Almost more than 1 hour, or maybe 1.5 hour has passed. So on this platform, I want to request in future also all the organizing committee just to be very specific. I think I'm hurt because I always value the time. So I'm sorry, I will not be speaking anything because everything has been spoken by them. So there is nothing left for me to speak. Once again, sorry and thanks.
Thank you, Chejara sir, for reminding us about the importance of time and punctuality. So, to conclude this session, this inauguration, I request Dr. Sachin Patil sir to give vote of thanks.
Good afternoon all. On the behalf of Nasik IAP, it is my honor and a privilege to extend a heartfelt vote of thanks on the occasion of Nashicon. First and foremost, I would like to extend the deepest gratitude to our esteemed chief guest, Dr. Ram Gopal Chejara sir, President Maharashtra IAP. A special thanks to Dr. Amol Pawar sir, Secretary Maharashtra IAP, Executive Body Member, for your continuous support and guidance. We are also grateful to Dr. Mohan Warke, the Treasurer Maharashtra IAP, and Dr. Milind Bharadia sir, the founder president of Nashicon, for their invaluable contribution to this conference. I extend my sincere thanks to Dr. Sachin Chaudhary sir, President Nashik IAP, for your leadership. Our heartfelt appreciation to Dr. Ravindra Sonawane sir, organizing chairperson, Nashicon, and Dr. Pawan Devre, secretary, organizing secretary, for their meticulous planning and execution. I also thanks Dr. Prachi Birari madam, treasurer of IAP Nasik, and Dr. Sonali Pardi, joint secretary IAP Nasik, for their hard work and commitment. Finally, I would like to thank you all the faculty and all the delegates for their presence and contribution. Let's look forward to a great conference ahead. Thank you.
Now we come up with our first panel discussion of the conference on common challenges in pediatric office practice. This panel is being moderated by Dr. Sudhir Sane sir, who is renowned and very senior pediatrician, director and HOD of Jupiter Hospital, Thane. He is well known for his rational practice in pediatrics. Now I invite our panelists, Dr. Satish Shahane, Dr. Pramod Kulkarni, Dr. Kundan Chopde, Dr. Sushma Save to come on stage. I request Dr. Sudhir Sane sir to start the panel discussion.
Good afternoon, and thank you all, and special thanks to organizing committee Nashicon, because they have been extremely adjusting. We got delayed in traffic. We were driving for 5 hours or something, and they changed the schedule, and I'm very thankful for that. So I think we are going to discuss various common challenges in office practice. And one of the challenges is how to move the slide further. So we have lots of common challenges like administrative, medical, legal, practical, compliance related, social. Today I realized that it's always also a challenge to reach in time in your clinic because we came so late. But what we are going to focus today is mainly clinical challenges in office practice. And if you kind of see that office practice is most of us feel often mundane, dull routine, definitely less glorified than intensive care or emergency management. However, one needs different kind of skill sets to find a needle of a serious or potentially serious patient in a haystack of in our OPD rush. And we also learn to treat our patient and not the disease, so we know our patients. And so done with some focus, the sea of cough, cold, fever patients become more challenging. And so to solve this challenge, we have today's panelists, and you know all of them, and they have more than 100 years of experience. So let's move on straight to the challenge one, which is bread and butter of a pediatrician, and that's infection. And we'll try to discuss what kind of difficulties, challenges we get in infections. Let's see how from hundreds of fever, cough, cold, we can detect unusual presentations and diagnosis. So let's focus on onset, duration of progress, and fever, almost simultaneous cough and cold against cough and cold for 2 to 3 days if a child has got and now has started developing fever. I mean, I would ask the panelists to say that would the approach differ? Kundan, would you like to speak?
Yes, sir. So if there is fever and almost simultaneously cold and cough, that is usually a infection, that is a viral infection. As against when cough, cold is there and then fever comes, that is usually a secondary bacterial infection is there.
Yes. So I think either it's secondary, anyone, I think all of us can be interactive.
Yes,
so,
sir. So, yeah, secondary bacterial infection in the form of a sinusitis, otitis media, or it's bronchiolitis or bronchopneumonia or pneumonia per se, that can happen.
Right.
But sir, in influenza also, if you see, it can happen that the cough and cold is there and then the fever can come. So that can be there. So one has to keep that also back of your mind, that it's a viral, but even that influenza is going to tell us.
Absolutely, absolutely.
Yeah, mainly, sir, I'd like to stress on the three things. One is onset of fever, that is very important, because most of the what we see in our practice, we require, actually we have very less time to ask the history. So in these cases, the onset of fever matters a lot. If the fever is high on day one, it's likely to be viral, or there is a localized infection, or there is some kind of a what you call erratic fever like malaria. So we try to see for next 2-3 days how the fever behaves. If decreasing, we just wait and watch. If it's increasing, then act.
Correct. Yeah, Pramod. Yeah.
Here we have two different perspectives. One is fever and one is systemic manifestations, both the scenarios. So you think like that, fever is suggestive of systemic inflammation and the local system inflammation. So the cadence of the symptom tells you where it has started and where it has gone. To start with GI manifestation or respiratory manifestation, the onset of disease at local point, and then it becomes generalized with systemic manifestation. On the other side, you have a systemic process inflammation which localizes to one system. This is the other way looking at
it. Motion. That's the usual viral gastroenteritis scenario. Child has come where the usually fever subsides and GI symptoms remain, but this child has come where GI symptoms have disappeared, but the fever persisted. So how would you kind of analyze this type of situation? The first situation is typical viral gastroenteritis that we see. Yeah.
So as we see here, the GI manifestations have resolved, but the fever is persistent. What does it mean? The systemic inflammation is still persisting. So we have to look for what is the cause of this systemic infection, whether it's a sepsis actually going on, or it's a natural course of the infection. When the GI manifestations are minor, it could be a simply viral also. So it totally depends on the condition of the child. It can be either way.
So would it be fair to say that it's unusual and enteric and extraintestinal infection like UTI and otitis media would come like this? So don't get bogged down by only loose motions, vomiting, and think of local gastrointestinal. So
mainly parental diarrhea, what we call it.
Parental diarrhea, the way we say.
Yes.
Yeah. Okay. So let's begin. Kind of currently we are in an outbreak of an influenza, and we'll try to discuss some of the points there. So this 15-month male child on 14th of July, we just had influenza season onset in Thane, came with fever for 3 days, cough, cold, and is not taking medicine. Just to have a small diversion, I think, I'm sure in our office practice, this kind of things must be very common. That doctor, my child is not taking medicines at all. And how do you deal with such thing? I think all of you can say one, two words of wisdom that my child is not taking medicine, how we should.
Yeah, basically this child require medicine, that is a big challenge, because when the child has got only minor symptoms, when the child is in interfebrile period is normal, when there is a strong family history of viral in the family, we can wait and watch better than taking like sponging or any other ways of medicines than oral. We can try like even rectal suppository, sometimes we try when children are not taking orally, for basically to reduce the maybe I got discomfort of fever rather than the symptoms.
Nice. So I think one thing is give as less medicines as possible. Sushma, you wanted to?
So the literature says the rectal suppository doesn't work that well as the oral medication. So, and the child is already in a panic and is already irritable. So to put again on a rectal suppository, I really do not know. I don't have.
So what kind of options do you
Sir,
suggest?
if it's like 5 ml of a medicine has to be given, so you just divide into 2.5 ml small with a dropper or something, or a small quantity that way, or
Kind of you use special, kind of tell them to use droppers or specials. So, Pramod, would you like to say something? And Kundan, I mean, if not taking medicines, do you say, take on, say, full stomach, empty stomach, the way you want to? What do you normally, what's your trick?
With the initial clinical information given in the first 3 lines, what is important is irritability, which you have already highlighted. Not taking medicine is not a big problem because need of medicine will be determined by the fever, degree of fever. So characterization of the first 3 things is very important. Whether the child is taking feeds or not is more important than the medicine. That is what I think.
I agree. I think Kundan, you wanted to say?
Yes,
Yeah, okay. So, I mean, he is irritable now and flu season. So what would be your approach, I think?
It's a wide open choice. It can be simple otitis media. It can be influenza as you have suggested. It can be UTI. It can be any damn thing.
So tell us 3-4 important focus history and clinic. You know, we are seeing so many patients waiting outside, so we cannot have a very detailed focused history points.
As family history is there, I will go for viral infection.
Nice. So family history you will ask for.
This is suggestive of a typical viral syndrome.
Yes.
Fever 3 days, cold and cough to start with, as well as community history. You have told us epidemiology. This seems to be viral infection, and the child is irritable. Now I am looking at the common scenario. Is it otitis media? This is a young child, 15 months. Can it be UTI associated, or a rare possibility? Looking at the immunization and rest of the thing, the rare possibility of meningitis needs to be entertained. Everything has to be thought of.
Absolutely. So, I mean, Satish, would you really investigate what treatment options if you think that this is ILI, influenza
now
like
this
illness?
like with the availability of biofire or the tests which are like now point of cure in many hospitals now, they are one way are useful, but second way their interpretation is very important. So most of them with the family history, you are very want to confirm with the diagnosis. If the child's parent want, then we can give option, because as a clinician, sometimes in an era where we are practicing, we should have the diagnosis. So we are taking samples for RT-PCR, especially on the focused one for maybe either flu or adenovirus. We are not doing like panel of viral or bacterial like, because they are not useful.
Fair enough. So for Satish, the paneler is easily available and he is using it after consulting parents. Kundan, would you like to say something about that?
Yes, sir. In office practice, my main thing is that the first common things we should think first, that is like viral, but at the same time, we should not miss the serious things, like if meningitis is there. So we should look for the progression, counsel the patient accordingly, and also first I will do routine investigation like urine, because UTI can be mixed in this case. If investigation whether I want to do, then I will do first urine and then seizure.
So let's be very sure about that. Fever with cough and cold, still you will get a urine routine done. I mean, would
for
all
fever.
Yeah, because he has an history of a febrile illness in the family 2 days ago, and it's been irritable, sir. And in focus examination, just wanted to say that we should not forget to see the ear with the otoscope.
So he said
that is
otitis.
very important to say.
What
And
about
sir,
sending-
I'm from an
Yeah.
institution.
Yeah, that's what
I'm
I
from
was-
a PMC institution. So we routinely don't send any biofire because the patient we cater to, they are very poor. So if the child has been severely manifested, high risk patient or something, then we send an H1N1. CBC, yes, if it's required, but I don't think so. This case, I would like to go ahead with a CBC.
So
Yeah, thank
I
you.
mean, that's kind of art of medicine that we should start working with whatever resources we have, the kind of patients we have. One quick word, I mean, everyone says that antipyretic other than paracetamol should not be given. And even in American Academy of Pediatrics, they have said Motrin, that means ibuprofen. So how do you look at the need of antipyretic other than paracetamol? I'm not asking whether it is logical to use, whether it is rational to use. Is any antipyretic other than paracetamol needed in our practice?
Usually
Never.
not required. Usually not required.
Never. That's
Never.
all.
Satish, I mean,
I use ibuprofen for pain, especially in small child.
so sometimes for pain and inflammation, Savita.
Same, sir.
So,
Ibuprofen.
so I understand. So this is, I just wonder, what about antibiotics, antivirals, deferred, what is deferred antibiotic prescription means? I would say that if your child's fever doesn't settle within 2 days, then you can start this medicine. Do you follow this kind of?
Never,
No,
never.
Kundan, never, no? Pramod?
Uh, just a correction, it's a deferred antibiotic prescription, not deferred. It's a deferred.
Absolutely.
It's a deferred one.
I agree.
And it's a standard practice and one of the means of practicing rational antibiotic practice. It can be well practiced in few of the OP scenarios like acute tonsillopharyngitis, acute otitis media.
Absolutely.
These are the two common where you can observe for natural resolution and waiting for it, and you can prescribe, and if there is no resolution with red flags told, you can always give a deferred antibiotic prescription of plain amoxicillin, which is fantastic.
I think that's a message that in some patients whom we are sure that they might follow properly, they might be bothered about red flag signs that we explain to them, deferred and not deferred again, deferred antibiotic prescription can be used in certain clinical situations.
Sir, but better to ask patient to come to follow after 2-3 days.
Fair enough. I think, Kundan, I do agree, but we all practice in different scenarios. Some of my patients might be coming from 30 kilometers, and with this traffic, it might be, so, I mean, that's the thing. So, when it comes to influenza, I think we'll just discuss one point here, critical time to treat, because many of the authorities say that under first 24 hours, but it's often not possible to treat. Satish, you wanted to
Yeah,
just
any
comment.
high risk, the child has high risk condition, then definitely would like cardiac, renal, or maybe infantile age group, less than 6 months bronchiolitis, we are not very sure, then use influenza, antiviral drugs.
Okay, so high risk patients and in stage 3 or more severe illness you might use, and do you plan to use it in first 24 hours, or what is your
First
use?
48 hours in cases of high risk, and under 6 months when the child is at pure viral symptoms.
Okay, okay. I think we'll move on to next case. This 6-month-old child came with loose motions and vomiting for 3 days. There are 2 points here. The child is very dull, lethargic. However, there is not much dehydration. His CRP was done. Our big child came to us on day 3. On day 1, someone did CRP, and it's not unusual. You must have found out that on day 1 it was 0 and day 3 36. And so what are the possibilities? This child is dull and lethargic. What point of care testing we will be doing? And I think we'll be talking about point of care testing little more. Yeah.
So this child is a small child, 6-month-old child. Like at this age, as a clinician, we should rule out any acute conditions, especially requiring any admissions or ICU admissions. Second, the child is like stated here is not dehydration, but is dull. So either he may be given some ground solution, because sometimes hypernatremic dehydration can present like this. So maybe in that cases we need to investigate. Our third point is to see for the any complications of the loose motion vomiting, which can happen in cases like infection or intussusception, or sometimes even the metabolic syndromes.
Fair. So dehydration, dyselectrolytemia. So would you really look for dextrostrip and urine showed ketonuria in this child? I mean, many of us, we would find that urine ketones positive in many of our febrile patients. And how do you really look at it?
It just says that the child is fasting, nothing more than that. The oral intake is suboptimal, that is the only interpretation. It doesn't say anything about any disease or anything else. The child is not taking orally, that's all.
So-
That is about the ketoaciduria.
Fine, but would you agree that if this child is fasting and he is becoming drowsy and hypoglycemic,
Definitely.
then this is accelerated hypoglycemia, that means ketotic hypoglycemia. And I think some messages take home if you want to just give quickly, Kundan or Pramod, anyone.
Ketotic hypoglycemia is a common condition, common post-neonatal cause of hypoglycemia we come across. You have to keep in mind, the setting being a IUGR or LBW birth, maybe there might be hypoglycemia documented in the neonatal period or what. Little stress of fasting, low oral intake, and these kids, irrespective of the inciting issue, maybe a simple viral infection or GI infection, they land into actual hypoglycemia, which is symptomatic hypoglycemia. Here you don't have to do much of workup, just prevent it with frequent feeding and manage as a standard case of hypoglycemia.
Fair
That's all.
enough. Yeah, Kundan, anything
Yes,
else?
prevention is good.
So, I think, let's see, go back. Okay. How would you, just one or two lines, how would you interpret CRP in this child?
The CRP increasing titer is suggestive of inflammation or infection is there. So we have to monitor the child.
Monitor the, so we wouldn't really, I mean, would this CRP automatically require antibiotic? Would it require? Not really. I think all of us are on the same page. I think I would like to take one or two quick interactive questions from audience if there are, because we are actually running short of time. Otherwise, we'll move on to next case. Are there any questions? Anyone wants to have a comment?
Sudhir sir, only one thing here. The child has recovered from GI, is a dull lethargic, though there is borderline hypoglycemia. I will like to rule out UTI here, which is very important.
UTI.
Because the CRP, though I fully agree with you, the quantitation of CRP doesn't help, but this is 36 milligram per deciliter, which actually comes to 360 milligrams per liter, which is more than 100, and we have to rule out some bacterial
Absolutely,
underlying.
and that's the reason why urine was done and that was normal. I think we'll just, so in ketosis, one thing is that if the child has got ketosis, and especially recurrent ketosis, keep check on his anthropometry, because ketosis with low height might suggest, give a clue to growth hormone deficiency or hypothyroidism and endocrinal causes. So a 6-month-old child, very reliable parents, they came with history of one spike of fever, 104, and they came urgently. Next, within 2 to 3 hours, the fever had gone to 101 by the time they presented. Anterior frontal was normal, active. So, I mean, how would you approach this child? Like we said that we look at the epidemiology, what is happening now in your...
So common scenario in OPD practice, because as what we know that the mother's antibody wins, then childs are bound to get infection. But we need to alert about, because this is the age where we are sometimes deceived. So in this child where the clear-cut pus are seen and the child is having E. coli, I would say kind of a ESBL, but with this ESBL, we should not directly go to the second line or third line medication. Rather than we monitor the fever, we may start with the first line therapy like cefixime or sometime amoxicillin also. And if the child is responding to medicine, we can wait and watch.
So, I mean, 2-3 points here. I just wanted to just ask the panelists that discrepancy between clinical presentation and the reports. This child came with very high fever, and by the time you got the report of UTI in the form of pus cells, the child had become afebrile and then remained to be afebrile. And that's a discrepancy. That means there is ongoing UTI, possibly pyelonephritis, and child is afebrile. How would you look at it? I mean, can it happen or?
Yes, this can very well happen. To tell you, there are a few clear-cut indicators of high risk of scarring and long-term renal disease. What are those? Basically, the child is 6 months old.
Yes.
Number 2, high-grade fever,
Correct.
documented even once. Then you have got culture-proven UTI at this age is to be taken as pyelonephritis. Okay, ESBL, definitely you cannot make clinically anything out of this. The risk of scarring with this scenario varies from 5 to 30%. I'm not going to take a chance at all with the natural resolution of 1 day. That's the catch. Here, I'm not going to take any chance. I'm going to treat appropriately as ESBL UTI.
I think fair. We have, I think, discussed about UTI and let Kundan, Any quick thing about point of care testing? You are practicing in Solapur. So are you using point of care testing in your OPD, or it's not needed? Or what do you
It's
think?
definitely needed.
It's
Really.
needed. So what kind of you do urine dipstick method, or and any other point of care test do you do? Do you do card test for falciparum or things like that? No.
No, no.
Any
No, sir, no,
yeah.
at our institute.
Okay.
Sir,
Not.
Yeah, urine dipstick is a standard method, can be done bedside. 5 rupees is the cost, 12 parameter stick. Actually, it's a OPD practice. Collect the urine, dip it, read it, and you can make out leukocyturia or pyuria, as well as nitrite test, which is very much surrogate marker of bacteriuria. It's a very good initial screening test for OP diagnosis of UTI to start the treatment, because if it is UTI, putting on antibiotic ASAP is very, very important for the long-term effects of UTI.
Fair. We'll move on to the next section, which I thought was symptoms that we rarely studied, but suddenly they hit us when we start doing our private practice. That so about this, there are probably not many guidelines, and it's only our practice points that we slowly learn over the period of time. And that's why I thought from esteemed panelists, we'll just try to get quick answers. So this 11-year-old girl vomiting every day since school reopened. And early morning, rest of the day, she is playful. She attends school very regularly. And when I asked her, are you worried about something and why are you vomiting? She denies. So, I mean, everyone in the audience and the panelists might be thinking that this might be anxiety associated, school phobia. What are your ways to take that history out from the parents? Can you pick one or two tips?
so actually the child doesn't come on his own. So what I usually do in my ROPD practice, so I talk to the parent first, that what are the stresses and all, and how the things have been happening. But if the parents and child is also not coming, requesting parents to wait outside and get the information from a child. So make a friends with her, right, and get the things out of. And then she comes out with that she's scared of a teacher, or the peers are there, bullying is happening, or something happening. Some incidents had happened, because of that she's not want to go to the school.
So especially in an 11-year-old
Yes.
near adolescent patient,
Yes.
give her
Yes.
one-to-one time. I
Yes.
think that's
Yes.
important. Kundan, you wanted to say something? Any other kind
Yes,
of
sleep
yeah.
is very important. Sleep is very important.
Absolutely. So what time does she go to bed? What time she gets up? What are the timings of school? When does the bus come? How does she go? Is there anything to do with morning sickness, early morning sickness? Have you seen patients like this, and how do you deal with them?
Another thing I want to like.
Not morning sickness, sorry. I wanted to say motion sickness. Sorry. Yeah.
I also like to know the menstruation history, because there can be hormonal changes at that
Hormonal changes, you are saying. Yeah, but this has been going on for quite some time now.
Sir, sometimes parents are very strict. Even I think we being a pediatrician, as a mom, you want the child to have a breakfast, and you want that child to finish that glass of a milk. So forcefully it's been given to the baby. And then when she's traveling through a bus and she pukes out everything. So I think they should not be forcing the child to
So
whatever.
what is the kind of, we do understand that breakfast is so important part of meal in a child, and the child has to leave the school for the bus at 6:30 and she gets up at 6 o'clock. So how do you kind of quickly manage that? I mean, it's difficult on such a forum to say, but...
So sleep early, get up early, sir. That is the...
Any anti-anxiety medicines here?
PPI can be tried, even anti-emetic for that matter, but no anti-anxiety. I don't know the experience from other panelists.
Okay, so we have never given anti-anxiety. So this 8-year-old child came with tooth grinding for many months, and I mean, I would just, rather than going through, we would just say 5 or 6 facts about bruxism and say whether, comment on something. So what are the appropriate answers or answers? That it's a common disorder, often noticed in sleep, but can occur in daytime also.
Yeah, we see bruxism after 5 years of age mainly.
We see many times, so it's a common disorder.
Many parents have that, so history is also there, family history.
So family history is so important because many parents
most of the stress, most of the problem what we have incurred is stress, and allergic disorders very common, because the bruxism is way to open our airway also. So sometimes bruxism can present, allergic disorders can present like a bruxism, especially sinuses and adenoids. So we need to check it out. Then other like deficiencies, what we commonly helminthiasis, has to be like taken care, and we monitor the symptoms.
So Kundan, how would you really counsel these patients with bruxism? Do you say that it's normal and it will go away, or what kind of things you do?
Not exactly like that, but we can say that counseling, there are many children having this bruxism issue, so we have to look. Then first causes like helminthic, anti-helminthic we can try, and the counsel them if any history stress is there, we can explore.
Okay, so
So if the bruxism is occurring during the night, so what has happened throughout the day for the child? So that is a stress factor for the child. So you have to make that bedtime very soothing for them. So tell them stories or calm them so that they are out of that. And during the daytime, sir, when they are doing some activity, watching a TV, writing, doing homework, so that they do that teeth grinding. So one has to be very watchful. And the tics disorders are quite common with the bruxism, sir. So that
Yes.
also we have to understand.
And very occasionally for severe bruxism, we had to use
Yes.
wearable oral
Yes.
devices because there is a lot of dentin loss. I think constipation, 3 years for last 6 months, 3 years old. What are the important history points? Quickly, I think we have.
Constipation, mostly what we are interested in is diet, because that is the way we can treat, because we cannot give medication for long, so we have to
So
change the
the
diet.
3 years old, what focusing on diet, bottle feeding or not,
Yes.
milk intake, what else?
Then intake of hydration, water.
Water,
Then,
Fiber-rich diet, any?
fibers, fruits and vegetables. What else?
then motions, like regularity, or the way, I would say kind of a bowel movements or habits, how they go, how there's a right way to pass the stools, pressures. then
Toilet training.
Toilet. So would you expect a 3-year-old child to toilet trained, or
Yeah.
would you start toilet training
After
for him?
24 months, we can toilet train.
You
the
can
child.
suggest, but you may not enforce. The position in which the child is passing motions, would it be important if they
Yes,
say
sir.
that? How?
So just wanted to make
Yeah.
a point on a history also. We can show the Bristol card, the stool card chart to the parents
Absolutely, I
and
think
make
point
it.
well taken, yeah.
Yeah, so that can be shown. And sir, they'll be they cross the legs and they'll be standing like that, and that is posturing is very important.
Pramod, in your busy OPD, what important points you will look on examination in a child who has got chronic constipation?
Two things, practically 99% of the times it's functional constipation. Very rarely you have organic or secondary constipation. A history of passage of stool at birth late, one of the important point. The hypothyroidism may not be evident in its classic form, but need to be kept in mind. And the third thing, physical examination, the PR examination and laxity of the sphincter. That is one important thing. Palpation, everybody will have fecal palpable, everybody, scabella palpable. But most of the times it is. And the vicious cycle has to be remembered and again counseled about. It is the regularity, consistency, and pain management. These are the three things, not to forget the dietary management. And perseverance with the treatment, laxatives to be given over months to years without stopping is the important message.
So very, very important that long-term usage of laxative, although the parents are not willing. I think just quickly one word, one of you take. What is true about constipation? Gaseous distension abdomen is often seen as habitual constipation. So is it true or not true? I mean, my personal thinking is that it's not true. The large gaseous distended abdomen, which is hypertonic,
not true.
is more likely with Hirschsprungs or something, and there is a reason for that. That there is a difficulty in passage of gases, preferentially flatus, difficulty rather than solids. Fecal soiling can distinguish between Hirschsprungs and habitual constipation?
Yeah,
Yes, it can do so.
rectal
So
hematoma.
I think when we look at the anal area, you look at the fecal soiling. Polyethylene glycol is a drug of choice, true. And as he said, long-term medications are required. Suppository enemas are generally avoided. So because the child has got severe phobia about the anal area, and constipation should be inquired about in patients with UTI. I think for the want of urticaria, okay, we'll take this urticaria for 7 days, new onset of urticaria. Quickly, what are you going to look for and how do you treat it? Let's go through that whether it is true for acute urticaria, that we need to differentiate between fixed versus changing urticaria. And former might suggest more sinister etiologies like vascular. Is it true? I mean, and what else would be the pointers to vasculitis, urticarial vasculitis?
The lesion lasting more than 24 hours, associated angioedema, local pain, which is very unusual with plain urticaria.
Fair enough. So pain much more than itching. I think we would
And
be very
systemic
careful.
manifestations are suggestive of vascular.
Correct. Anything else?
Age also.
Sorry?
Age of the child.
Age of the child. I mean, would you like to elaborate on that?
Basically, if the child is 6 months to 1 year with fever, we should think of vasculitis in different origin.
Younger the child, more likely to be vasculitis. Okay. So, I mean, then we'll move on to our third section, that here we will think that we are seeing these complaints very often from parents, like my child is not eating, not speaking, not growing, and many of times there are ancillary associated complaints. That means he has got fever, cough, cold, and then while going they will say. So here as a pediatrician, our role is to find out red flag signs and common etiology. And out of all this, I thought because of the want of time, so challenges are many, but I have taken only the child is not able to speak. So, I mean, how would you kind of deal with it? So 2 years old boy comes with not able to speak. And what would be the common causes you would think of, and what would be the, I think I've listed the common causes, but what would be the red flag signs that you would think of? Satish?
Mainly, we need to take the, first of all, the birth history of the child, previous growth and development, basically how or where, when he achieved his previous milestones. Then most importantly,
I mean, just tell me quickly that why it is important, because if he has not achieved, what will you think of?
If a child is having like repetitive play or something same, so we should think of autism or autistic spectrum disorders.
Fair.
That one.
First thing we should look
hearing,
at.
Hearing has to be assessed with the, either he's gone through the OE or in his test in the past for the hearing, so that we can think of ruling out the most common cause like deafness. And third is, if he has associated complaint, then red flag signs of syndromic variety also we can think.
Okay, Kundan, you
First thing we want to look for whether the child is able to hear. And second thing is that most of the time what happens, the multilingual family is there. So the child interprets everything, but he does not know in which language he has to respond. So he prefers to not to talk.
Yes, but I think we would not be giving too much just a kind of leeway for multilingual family, because we should be more upfront. So let's analyze this case of 1.5-year-old child now, not able to speak, and the child is able to just, doesn't respond to name, comes to you interested in glows. He kind of briefly plays with your fingers, looks around, notices toys, points, eye contact is good. I think these are the things that we will look for in our OPD. When angry, speaks all in different language. I mean, what would you think
Sir,
of?
yeah, so if 1.6-year-old child not able to speak, that is a red flag for us. Then does not respond to a name, that is also a red flag for us. Comes to you interested in the gloves, briefly plays with your fingers. That means he's interested in specific thing. So that is what his specific interest. And then looks around, notices a toy, that means he's interested in the surrounding. Points and eye contact good. But that eye contact, whether it's sustainable eye contact, that is what is important. And when angry speaks all French, it tries to speak, but which we are not been able to understand. So here, apart from your pre-verbal hearing loss or something, your ASD, that is autism spectrum disorder, is high on a card, sir. That is what you have to
I
see.
mean, I would think of pre-verbal hearing loss much more common, because the typical autism spectrum disorder would have, I mean, we will discuss that case next.
Second, we can, like in this, when we are not very sure about, because the child is otherwise having maybe good eye contact or something, we can then screen them for the MCHAT screening.
Okay.
Maybe online also it is available, or you can print also in the OPDs. So just give them 10 minutes of time and then come out. So if his score is matching for, then we can screen for further.
So I think MCHAT scoring, I think all of us must have discussed. So let's again take this second case, 24-month male, not speaking yet again, but watching, we have 5 minutes, watching mobile phones, doesn't respond to name, doesn't interact and look around. I mean, what are the things that this is the kind of...
In this case, we can suspect autism spectrum disorder.
Okay, now there are 3 sub-scenarios here. In first scenario, he only keeps on playing with his own toy truck. He's tremendously interested in wheels, repetitive restrictive interest, and he has abnormal hand movements when excited. what kind of diagnosis would you offer?
Yeah, so this is very typical with an autism spectrum disorder that they like to have a specific interest and they're very interested in the moving objects. That is what is there. And abnormal hand movements, the repetitive hand movements are there. And if the repetitive words, also, echolalia is also very common.
Would you kind of have antennas up if it's a girl child? What would you
For
think?
Rett syndrome.
Rett syndrome. So we should think whether this can be Rett syndrome and not typical autism spectrum disorder. And scenario 3, everything else is there, but rather than having repetitive restrictive interest, this child draws, plays parallelly with the child, but again too much mobile phone. So what would you think?
So maybe kind of a language delay condition.
So social communication delay, and this is, I mean, there is fine differentiating line between social communication delay and autism spectrum disorder, and that's that, repetitive restrictive interests.
Decreased screen time is the key.
Decreased screen time is the key. Okay, so I think for the want of time, now I would just, because we just have 3 minutes left and counseling is very difficult, but this is one of the challenges that we have in our busy practice, that suddenly child comes with, when we think that it's Down syndrome and Duchenne's muscular dystrophy, because we have only 3 minutes, one point from each, that how do you kind of do successful counseling for such patients?
First, most importantly, we should be empathic to the child. So
Empathy,
when we are counseling, you should be with parents, avoid distractions like other patients, mobiles. So you should have empathy to them.
So give special time to them.
Yeah.
You say that, okay, I'd like to discuss, but come tomorrow early in the morning. Yeah.
So then clear cut, what is the diagnosis of the child and what is their going to be the prognosis in this condition that they have to be understanding. So that has to be counseled to them.
Okay. Yeah, Satish?
Nature of disease and the for the next babies, or we should plan for the
Okay, so
antenatal screening.
So let's talk about DMD. How upfront can you be to give about the nature of the disease? How would you take a patient who is, say, 3-year-old whom you have just diagnosed DMD? What kind of counseling about the prognosis?
So in these cases where we are sure about the diagnosis, then we can tell them the what we can do the next plan of actions. Then discuss is whether we can go for now the genetic. Some drugs are also available, so refer to the genesis, because as a common we can do something to the certain point, but next will be genesis. We can take care of that.
So you kind of give slight hope to the parents that
And progressive
research
nature
is
of the
going
disease
on.
progressive nature of the disease should be explained.
Explain. Pramod?
A few important points, basically understanding what level of understanding about the disease they have.
Absolutely.
Number one. Number two, what is their perspective and what are their concerns? We have to bring them out and address them. And the basic thing, we don't have to forget about the facts associated with that condition. We don't have to give them false hopes. We don't have to unnecessarily threaten them or frighten them with the outcomes. And let us focus on how we can improve the quality of life in this child and what best we can do, especially with the multidisciplinary need of it.
I think thanks a lot. Yeah.
Wanted
Sushma?
to just regarding these things, genetics, because it's a X-linked recessive. So the family counseling is very important with the female siblings. If the female siblings are there, then their carriers test has to be tested. That we cannot be forgetting.
Thank you, my panelists have been absolutely to the point and great. I would like to invite 30 seconds and any questions, because difficulties are too many. There can be sleeplessness and there can be so many difficulties and challenges in common practice, and it's very difficult to finish in 40 minutes. But any comments, any questions? Yeah, Ramakant.
In case of influenza, that in first 24 hours, if there is some adult member or eldership is having proven H1N1, H3N2, you need to give in within 20 this thing, oseltamivir. I think that is one thing. Within 24 hours, you have.
I think very great point, and that's what we have been talking, that we should take family history and family, and also I think any high risk sick contact in the family will decide whether we need to focus. I mean, if there are grandparents more than 65, 70, then we would.
Ketotic hypoglycemia has to be taken seriously. Avoid fasting more than 6 to 8 hours. It should not be past It is just ketonuria because of fasting. So ketotic hypoglycemia with symptoms, that symptoms is that child is definitely lethargic, that is there. And in these cases, urine dipstick, urine dipstick, if it is simultaneously both nitriuria and leukorrhea, if these are there, then definitely along with symptoms, all urinary tract infection, even if it is a screening test, if symptoms are there, what was there in the case, then it has to be taken seriously.
Thank you, Ramakant. As always, precise.
So far the DMD is concerned, there are so many options, therapeutic options are evolving. You can consider just simple steroids like deflazacort. So my request to the practicing pediatrician is refer DMDs where the DMD work is going on in our country. There are so many centers.
Very pertinent
Yeah.
point. And
Another thing that 6 months, at 6 months of age, I will not consider the diagnosis of ketotic hypoglycemia.
Okay.
Usually the range is about 2 to 3 years.
6
If
months to
Promoter
8 years.
if will agree with me. Okay.
Six months to 8 years. Yeah.
Yeah.
Tarun, you wanted to say something? I think we can discuss this. Go back to Nelson. Yeah.
There are two, there are one.
Sir, many times patient come with reports where looks a viral picture, but the CRP is 80s, 100s. So how do we counsel them?
Yeah. I mean, patient comes quickly. And I think, yeah. Praveen, you wanted to ask, and Mahesh, I think. Mahesh, you first, and Praveen, and then we'll, I think, stop for the one type time. I think we need to be punctual, although we individually arrived late for the conference.
About the counseling part, I believe both these conditions which you mentioned, we should call a meeting with elderly parents in the house, not only father and mother. Nowadays, we see very young people, their grandparent, because the whole family is going through that.
Absolutely.
And you do that counseling after preferably having a genetic diagnosis. Otherwise, sometimes you're fooled.
I think very point well taken.
We run a genetic OPD in our Nair hospital. So as Mohite sir has said, so we sit with the parents and then they are also saying that please tell our grandparents also. So automatically the whole family
So I think
is there.
it's a joint effort to manage such patients and they should be involved. Yeah, Praveen.
One point in the vomiting which is a city problem, particularly regarding the school buses, is about the motion sickness. What particular type of medicines will the panel like to prescribe in such situations where the child is repeatedly having this symptom?
I would go ahead with the domperidone.
So motion sickness, so I have some tricks I will share, but I think Satish wanted to say something.
We first of all take care of the sleep, then give them PPI, then sometimes start on promethazine 1 hour before. That we try in low dose in our practice.
So what I tell my patients is motion sickness never occurs to a driver. The person who is sitting in front and looking ahead almost never gets motion sickness because you don't have nystagmus movement. So try to achieve that for your child in the school bus. Then motion sickness becomes worse if they have a liquid diet just before starting for that. So you have some solid. So if the child is not taking something, you may have some dry fruits and then start. And of course, sometimes so domperidone or some other medicine. So thank you all for the active participation. I think this panel. Thank you. Thank you.
Thank you, sir.
Thank you, sir, and thank you all the panelists for such a valuable insights. Please proceed towards felicitation desk. Now we would like to hand over mic to our MOCs for afternoon session, Dr. Suvarna Devre ma'am and Dr. Swati Bujreda ma'am. Thank you.
After this wonderful panel discussion, we will be continuing with the further scientific sessions. The winners for jumping jacks in females for less than 45 years are first winner Dr. Trupti Mahatme ma'am, second Dr. Shweta Patil, third Dr. Kalyani Patil. I'll request to proceed towards the felicitation stage. To all the winners to proceed towards the felicitation stage. The chairperson for next session are Dr. Anukul Nikam, Dr. Krunal Shah and Dr. Aniruddha Bhandarkar sir. As we are aware that bone marrow transplantation itself is a challenging modality of treatment, not only for the patients but also for the treating doctor. There are many myths about it like adverse consequences for the donors, post-procedural long hospitalizations, etc., etc. To clear this maze of confusion, we have with us very eminent speaker, Dr. Ruchira Mishra ma'am. Madam is a pediatric hemato-oncologist and also a bone marrow transplant physician. At present, she is a senior consultant at MRR Children's Hospital, Thane. She has an extensive experience of 26 years and has worked in many reputed hospitals. Madam has special interest in relapsed leukemias, hemoglobinopathies, and inborn errors of metabolism. Over to you, ma'am.
Good afternoon, everyone. I have to thank the management for giving us this opportunity to speak on this stage. It also gives me a lot of pleasure to notice that a number of posters outside mention hematology
I
as
request
their
Dr.
subject.
Sorry to interrupt, ma'am.
Yeah, thank you. Once again, thank you for giving us the opportunity to speak here. When we walked into the venue this morning, we noticed that there were a lot of posters outside which feature hematology as their subject. There's Diamond-Blackfan anemia, there's other pediatric hematology subjects that are being displayed here. And it swells my heart to feel that there is an interest in hematology amongst the postgraduate students over here. And kudos to Medical College Nashik for being able to cultivate that interest in them. So I am a bone marrow transplanter. I am fervent about bone marrow transplants, and I wish I could transplant everybody who needed a transplant. And what we need today is people who recognize the need for transplants and be able to refer them for care at the earliest. But there are a lot of myths around bone marrow transplants, and unfortunately, because we rely on pediatricians to be able to send the patients on time, and also the families come back to you for kind of corroboration of what we have said and the need to do a transplant. We need people to be more aware about what actually happens during transplant itself. So we talk about the myths of bone marrow transplant. Can you help me with this? So what exactly is a bone marrow transplant? Nowadays, the term that we use is called a hematopoietic stem cell transplant, or HSCT, or it's also called an SCT, or stem cell transplant. Initially, because the cells were taken from the bone marrow of the donor, that is why the term bone marrow transplants. However, all these three terms are synonymous with each other. There is no difference between the three of them. And currently, in all literature, you will find the term HSCT being used over here. And the reason being, we are using the stem cells which have a hematopoietic stem cell origin. We are not using these cells to cure DMDs or back pains or any other brain tumors, things like that. We are using it only for systems which have a hematopoietic stem cell origin to them. And what exactly is it? So these are the stem cells that reside within the bone marrow itself, and they have the capacity to divide and further progress and become different cells, not just the red blood cells, the white blood cells and the platelets, but also they will form epithelial cells, they will form cardiac cells, and sometimes even form chondrocytes as well. So those are the effects that you can see. So coming to the myths, the first myth that actually exists is whether bone marrow transplants is only for cancers. Now in adult practice, yes, I can understand that most of the transplants that are being done for cancers itself. But in pediatrics, please recognize that a lot of the transplants are being done for non-cancerous conditions. So if we were to have a list of the transplants that are being done and the indications that we can do transplants in, you will find that the list that exists on the left-hand side for cancerous conditions is far smaller than the one that exists on the right-hand side for the non-cancerous conditions. So diseases like your red blood cell hemoglobinopathies, your sickle cell anemias, your pyruvate kinase deficiencies, your white cell disorders like Viscott-Aldrich syndrome, Sheddak-Higashi syndrome, Costman syndrome, Diamond-Blackfan anemia, all these anioplatelet disorders, everything can be treated by a bone marrow transplant itself. Not just that, we also can treat osteogenesis imperfecta, which is actually chondrocytes. There we can treat hemophagocytosis, histiocytosis. We can treat mucopolysaccharidosis and certain other lysosomal storage disorders with a bone marrow transplant, and even some neurological conditions like Krabbe's disease or XLD or MLD can also be treated with a bone marrow transplant, provided the transplant is done early enough. So please remember this list. That's important because once you recognize that the child can benefit, you will be able to push for transplants. The second common myth that we see is that bone marrow transplant is a surgical procedure. Now, a liver and a kidney transplant, definitely surgery is involved both for the patient and for the donor. But in case of a bone marrow transplant, from the donor, there are 3 ways of collecting the cells. If the gynecologists are present over here, cord blood bank is one way of doing it, where we collect it from the placenta itself and there is no surgery here. The cells are collected after the baby is born. The second way is to collect it from the peripheral blood itself, which is a PBSC collection, so again no surgery involved over there. And the third is a bone marrow. Now actually it's as simple as doing a bone marrow aspiration. It doesn't have any surgery in it, but the fact that we're doing 100 bone marrow aspirations and 100 punctures into the bone, making it a painful process if the child was conscious or the patient donor was conscious, that's why we put the patient under an anesthesia for that reason. But again, there is no cutting up of skin or anything, so no surgery involved in these patients, neither for the donor and nor for the recipient. For the recipient, the actual infusion actually goes just like a blood transfusion, and as you can see in the photograph, it happens in the room of the patient itself. So this is our bone marrow transplant that we have just done very recently, where we have done the infusion, and you can see that empty bag that is hanging behind. That is the end of the infusion that happens over there. So it's done in the room itself. Again, no surgery involved. It's a physician's transplant. It's not a surgical transplant. The next myth that comes up is that bone marrow transplants are of one type. So generally, if one tells you that we've had a bone marrow transplant, you kind of assume that everyone has gone through the same journey itself. Well, that's actually not so. There are different types of transplants. Well, autologous and this allogenic transplant. Autologous means that we are collecting the cells from the same patient itself and giving it back to them after we've given the chemotherapy to this patient. And allogenic transplants generally mean where we are using a normal donor where the cells are normal and then giving it to a diseased patient itself. So main 2 varieties, there are autologous and allogenic. Now when you think of allogenic transplants, again there are a lot of myths, and the first one is that it's very difficult to find a donor. The best transplants will actually happen if you have a donor within the family itself. So it's called a matched sibling or a matched related donor, where the donor is within the family itself. The chances are that you'll find a donor is about 25%. And therefore lots of people say, oh, it's very difficult to find a donor. And as the family sizes are becoming smaller, it's becoming even more difficult to find it. However, what we know is that there is something called an unrelated donor as well, who is a fully matched but not related to your family. There are registries within India. There are at least 3 registries within India itself and at least about 14 registries in the world where people have voluntarily registered to act as bone marrow donors. They've given their blood samples that have been already HLA typed and they're ready as donors whenever we need them to be asked to donate cells. Then beyond that, we've discussed cord blood bank as well. So cord blood is also another very good way of getting allogenic stem cells. And then the third way of doing it is to get a haploidentical related donor. India itself is on the spearhead of actually becoming one of the frontiers in haploidentical transplants because we don't have a very good matched unrelated donor registry. So most of our donors are haploidentical donors. And who do you think would be the best haploidentical donors? For pediatrics, the parents become the haploidentical donors. So every child who has a living parent potentially has a donor. So there is no dearth of donors provided you realize that yes, the child needs a transplant. So that myth that there is a dearth of donors is completely wrong right now. In fact, if a transplant is indicated, we will always have a donor provided there is a parent alive. If I'm a girl, my donor needs to be of a female sex and also of the same blood group. Now, initially when liver transplants and kidney transplants were being done, they really asked you to be the same blood group. So the parents had to be, or somebody had to be the same blood group. With bone marrow transplants, it is not so. So we don't really need either the same sex or the same blood group of the patient to be there. The blood group of the patient will change to the donor type once the transplant is successful. So you don't need to have the same blood group. So that hurdle is absolutely crossed. We really don't bother about it at all in today's day and age. What we actually need is an HLA type, and that is the first building block of a transplant. So if you recognize that the child needs transplant, please get an HLA typing done of the child, the siblings and the parents. This HLA is a protein that is actually present on the cells which defines the DNA structure, and we need to match that. So the better the match, the lesser the complications of transplant. So this is the only thing that we actually ask for when we're thinking about bone marrow transplants. And the typing is done on 5 points mainly. Now we ask for 6 points. That is A, B, C, HLA, DR, DQ, and DP. Now with both parents giving you one haplotype, we're actually looking at this at 10 to 12 points. And therefore, when we talk about a match, we talk it on by 10 or by 12. So you're a 6 on 10 match or a 6 on a 12 match, things like that. So that's the way we will actually be looking at, and that's the only thing we require to be able to decide that this person can be a donor for the patient or not. Bone marrow transplants, when we looked at how they're being done, you can find that there are different ways to be done. So you could either have a MUD, which is the blue line over there, a matched related donor, a mismatched unrelated donor, a haplodonor, cord blood, versus no transplant being offered to these patients at all. And you all can see that the lowest line that you see over red is the ones who don't get a transplant. Everything else is above them, and even haploidentical transplants now have a very good survival rate with our patient cohorts that we see. And this is the data that has come in from India itself. Dr. Revati's team has published the data that their survivals are as good as having a matched unrelated donor transplant also. Then the question comes in that whether these patients will be hospitalized for prolonged periods of time. Now, when we're thinking about transplants, we go through a process of transplant. We call it a pre-transplant evaluation. This is generally done on an OPD basis where the patient undergoes tests and the donor undergoes tests to make sure that they're fit to tolerate the transplant, because after all, we're going to give them very strong chemotherapy. Thereafter, we admit them, we give the conditioning therapy, which lasts for about 4 to 7 days. We do the infusion, which is just like a blood transfusion, and the majority of the period is spent recovering from the transplant or monitoring for complications, and that's the period where the child actually needs to be hospitalized in special rooms over there. This whole period from conditioning to recovery takes about 1 month, so 4 weeks is that is there. After that, most of the follow-ups will generally be on an OPD basis. Yes, we do ask them to stay close to the hospital, because if there are complications, then we want them to get readmitted quickly. So what we say is that you need to be close to the hospital for the first 100 days or 3 months, but most of it again will be on an OPD basis. They will not be within the hospital itself in that period of time. So next thing that people talk about is, after a bone marrow transplant, will the patient be on lifelong medications or not? And again, what I have to say is that when we are doing a bone marrow transplant, we're actually changing the immune system of the patient itself. So what we're changing is the body's ability to control and keep the stem cells or the graft that we have given them. So therefore, there will be no need for long-term medications if the transplant's working fine. Generally, most medications will be taken off by the first year itself. Most of these medications are actually just supportive medications only in the first place. So once we are sure that the graft is picking up and the immune system is coming back, they will all be taken off. And by the end of the first year, we are going to be revaccinating these children and putting them back into society as normal children over there. Only a few patients will need medications for complications post-transplant, and that is generally for chronic GVHD, which may generally be a possibility, but that percentage is generally just about 10 to 15%, not more than that. So the hope is that unlike a liver or a kidney transplant, these children will be free from all medications, will be attending school, college, going up to be regular human beings at the end of 2 years. BMT can be done with active disease when no other therapy is working. Now, especially for cancerous conditions, we definitely say that it is only a consolidation therapy for malignant disorders. So if a child has active AML or has relapsed, has active ALL, where the disease is not getting under control, bone marrow transplants are not going to be the treatment for that. We will have to try experimental therapies. We may have to ask for CAR T cells or some other therapy for these kids, but BMT will not be the solution for them. BMT is only consolidation therapy when you have the disease well under control. Even with non-malignant conditions, what we actually look for is that the patient should be fit. So now if I have a SCID or a Wiskott-Aldrich who's got fungal pneumonia or has active CMV disease, I cannot transplant this patient. I will have to make sure that the patient is infection-free before I take up for transplant. So remember, the good physical condition of the patient is very important for doing transplants. And even if you're thinking of neurological diseases, we will also be looking at the patient should not have bad neurological status for taking up a transplant. So an XLD or an MLD who already has vision loss, who already has disability present, will not really benefit from a transplant. You need to pick them up early when they just started taking them, realize that they are having neurological deficits coming in. So that's the way. So an early referral is very important for us to be done. Once done, there is no more worrying. So again, that's not the case. Although we hope that at the end of first year, they will go back into society and they become normal, we do continue to follow up because there may be some short-term effects which we see within the first 3 months, but there may be some long-term effects as well. And the biggest one for us is infertility and secondary cancers. Now, 1 in 1 lakh patients may actually get secondary cancers, but we still need to continue to monitor them. So at the end of the first year, we tell them come back at 1.5 years, come back at 2 years, then come back at 5 years, 10 years, 15 years, but we don't give up on them. We will continue to monitor them completely. And we make sure that everything is going on fine. If something is not, we need to initiate changes in therapy earlier rather than later for these patients. Last but not the least, the BMT physician is the most important person in the unit in these patients. So, well, that's not actually so. We have a whole team that needs to look after patients, and at MRR we are very poised to do transplants because we have a very good team that is available with us. So I have very good intensivists, I have a very good hepatologist, I have good neurologists with Ankit Pandey as our lead neurologist. We have neurosurgeons, cardiologists, infectious disease specialists, a good lab, blood bank, everything under the sun that needs to be put into place to be able to run a good unit. And that is what I say, that we need to have good facilities in place to be able to run a BMT program which is there. Now, pediatricians often worry that once transplanted, they will lose the patient and the patient will never come back to you. Please be rest assured, they will come back to you. We want to do transplants, but we want them to be our ambassadors as well. So what we do is once we finish the transplants, when they're off that first year, when we're not worried about them, they come back to you. They'll come back to you for vaccinations if they're doing absolutely well. They'll come back to you for their normal pediatric complaints. If I've done a transplant for a 2-year-old and a 4-year-old, he gets cough, cold, he will come back to you for managing his cough, cold, or his otitis media and everything else. So be rest assured that they are going to come back to you. Also, we need to come back to you for stabilization in case of infections. So now, once after 3 months, they've been sent back to their local place. If he does get a fever, loose motions, and suspected sepsis, you are the first point of contact for them. So they will come to you, they will get specialized, only then will they move to a tertiary care center. And in most cases, as the care is improving, tertiary care centers will be in Nasik, will be in Aurangabad, and you can probably look after them as well as we would do in Bombay itself. So the pediatrician has to be involved with the care of these bone marrow transplant patients, irrespective of whether they come to Bombay or to any other place for their transplants. There are too many transplant centers in the world. I know that everyone wants to talk about transplants. I know that there's another talk tomorrow evening also on transplants. But please realize what is happening is the transplant journey is still very slow and very nascent in India at least. We have only managed to do in 2022 about 2,000 transplants throughout the whole country itself, with 114 centers being there in place. What we actually need to do is about 5,000 transplants per year just for thalassemia itself. Leave aside whatever there is for other diseases that are there. So there is a need to be more aware about bone marrow transplants. There's a need for more centers to come into place for bone marrow transplants to be happen and be accessible and affordable for everyone that are there. Even newer advances like CAR T-cell therapies and gene therapy, which everyone likes to talk about when they talk about malignancies or even for thalassemias, they need bone marrow transplants. So CAR T-cell is usually a bridge to transplant, and gene therapy uses an autologous bone marrow transplant when they're thinking about doing gene therapy for these patients. So the transplant need is never going to go away. It is always going to be there, and we need more centers to actually come up as well. I will conclude this by saying bigger the challenge, bigger the opportunity. What I really need from pediatricians is to recognize the cases that need a transplant, refer them early before it's too late, and then be willing to look after them when they come back to you. So thank you so much for that patient hearing. If there are any questions, very happy to answer.
Thanks, madam, for wonderful overview on the transplant. My question is, what is the expenses for this at your center?
So on an average, a bone marrow transplant a matched sibling donor transplant will cost between 15 to 18 lakhs for the 3-month stay. That is.
So they have to stay for 3 months and it will be around 15.
Yeah, their hospitalization will be only for a month, but because they follow up for investigations and drug levels and everything, we package that, we kind of put that into the estimate as well. However, we are trying to decrease the cost as well, and a lot of NGOs will give you help. So if you think that a patient needs transplant, please refer. Cost should not be the deterring factor. I am not from Mumbai or Maharashtra, but this is something that I have learned when I've worked here for the last 5 years, that philanthropy is very good in Maharashtra. I mean, I've done transplants where the patient has given 50,000 rupees only for an 18 lakhs ka transplant. And we've done the transplant with good results.
And
so,
what is the most common transplant you are doing besides non-leukemic patients?
So thalassemia and sickle cell anemia are the commonest that we are doing. Aplastic anemia would be the second commonest indication for transplants. We also do a lot of transplants for neuroblastomas, because Tata in Mumbai refers these cases to us. There's a dearth of time or centers or rooms in Tata. So we're doing transplants for Tata as well.
Thanks. Any other questions?
Thank you, ma'am. Thank you for finishing in time.
Check. Hello.
Cord blood banking is asking.
So, ma'am, I was part of the consensus statement by IAP for cord blood banking. I know that gynecologists and others are really pushed for cord blood banking by private organizers and cord blood banks. But the system is that if the stem cell is defective, then the cord blood is not going to be of any value for the patient itself. So if you're going to develop ALL or if you have thalassemia, then your cord blood is not going to be of any use to you. So when the cord blood bank tells you that these are 70 diseases that you could potentially cure with a bone marrow transplant, they're not talking about autologous transplants. They're only talking about allogenic transplants. So cord blood banking for private use is of no value whatsoever. If it is of value, it's for public banking. Okay, so this cord unit needs to be donated and your patient needs to remain well so that we can use it for somebody who is diseased. Now, what has happened is, because most people are now against cord blood banks, that the cord blood banks have come up with a caveat that we will sponsor your treatment or partly or in some form or the other. So they give an insurance as well. Again, the fine print needs to be read. They will say that they will give insurance provided the disease has not been diagnosed before the cells are stored. So if the elder sibling has got thalassemia and you're storing the younger child's cord blood bank, that's not going to help you at all. However, if the younger child develops some disease for which a cord blood can be used and the elder sibling's cord blood is existing, then they will give you benefit of that. So please tell your families to read the fine print, fight with the cord blood banks and do it. But if they're doing it only for the sake of this particular baby, then it's of no use whatsoever.
Thanks, ma'am. Thanks for your comprehensive information.
Thank you, ma'am. Thank you for the interactive session. I request Dr. Anand Makharia, sir, to accompany ma'am towards the felicitation dais. The chairpersons for the next session are Dr. Tushar Godbole, Dr. Gaurav Nerkar, and Dr. Sadachar Ujramkar, sir. Neonatal seizures represent one of the most frequent neurological events in newborn. and definitely has a long-term sequelae. Management of neonatal seizures involves accurate diagnosis, expedited evaluation, and targeted treatment to abolish the electrographic seizures. To discuss all these in detail, we have a pediatric neurologist amongst us, Dr. Ankit Pandey. He is a consultant pediatric neurologist at MRR Children Hospital, Thane. His special interest is in pediatric epilepsy, neurometabolic disorders, demyelinating, and autoimmune encephalopathies. Over to you, sir.
Uh, Hello everyone. So I would like to thank the organizers for allowing me to speak on a relatively common topic, neonatal seizures, where I will be discussing the current updates and the guidelines which are laid down by the ILE. So, yeah. So the learning objectives for the today's I don't think so this is working. Yeah. So the learning objectives for today's session will be to understand the challenges in diagnosing and treating neonatal seizures, recognizing the need for standardized treatment guidelines, and understanding the principle of the new ILE guidelines on the treatment of neonatal seizures. So the outline of my talk will be, I'll be reflecting on the etiologies, the epileptogenesis in the developing brain, the recent ILE classification and definitions on neonatal seizures, and the recent the diagnosis and the recent management guidelines. So neonatal seizures we know are common, and they are relatively common with 2 to 3 per thousand live births. The clinical diagnosis in neonatal seizures is unreliable, and they are usually associated with a poor outcome. And the therapy in neonatal seizures is challenging. So before going into the neonatal seizures per se, I will be going to the very basics of what is epilepsy, where after an insult, a precipitating injury, which is the initial epileptogenic trigger, there is a period of latent period, there is a latent period for a few months to years, and then slowly over the months to years, there is an emergence of chronic epilepsy. So what do we define epilepsy as? It's a disorder of a brain characterized by enduring predisposition to generate epileptic seizures by the neurologic, cognitive, and psychological and social consequences of this condition. In case of a developing brain, there is enhanced excitatory neurotransmission and paucity of the inhibitory mechanisms by maturational changes with changes in the excitatory glutamate and GABA receptors. There is excessive neuroinflammation and microglial activation, and there are various alterations in the signaling pathway which predisposes the newborn to develop neonatal seizures, they are highly susceptible to develop neonatal seizures. In case of neonatal seizures, the most of the neonatal seizures are acute symptomatic. Basically, there is an insult. Suppose a child has an HIE, and over a period of late time of a few months to few weeks, or the latent period, they develop post-neonatal epilepsies. This constitutes around This constitutes around 85% of the total neonatal seizures, the acute symptomatic seizures, and the neonatal epilepsies constitutes around 15% of the total neonatal seizures. So it is very, very important to differentiate these neonatal seizures, acute symptomatic seizures, from the so-called neonatal epilepsy syndromes, which basically are secondary to the electroclinical epilepsy syndromes, inborn errors of metabolism, or chromosomal or single gene defects. And there is a recent paper on this electroclinical epilepsy syndrome by Dr. Samir Zubairi, which has outlined these epilepsy syndromes as beautifully. In case of, so if we summarize, in seizures in neonates, as I told earlier, 85% of the seizures are acute symptomatic seizures, which can be secondary to HIE, ischemic stroke, infections, or metabolic disturbances. 15% of the seizures are genetic or unknown origin, and some of the neonatal seizures evolve into post-neonatal epilepsies, and Few of them are self-limiting epilepsies and few are developmental epileptic encephalopathies. If you see the common etiologies, the predominant etiology is HIE, and the vascular events which are because of hemorrhage or infarction, and the rarer events are the genetic epilepsy, the infections and the metabolic disorders. So this algorithm is used for the classification of seizures in childhood and adult epilepsy, where the seizures are initially classified into focal, generalized, and then unknown onset, and based on the etiology also they can be classified into structural, genetic, infectious, metabolic, immune, and unknown. But in case of neonatal seizures, this classification is not needed because all seizures in neonate are focal onset, and they have now the recent classification has highlighted the importance of continuous EEG monitoring in case of neonatal seizures, where they are classified into two categories: the electroclinical seizures and the electrographic seizures. So if you see the algorithm, if a child who is critically ill or has a clinical suspicion of a seizure, the first and foremost investigation to label the child whether it is a neonatal seizure or not, it is mandatory to do a video EEG or an amplitude integrated EEG. If that video EEG does not have a EEG correlate, then that episode or that ictal event will not be considered as a seizure. However, if there is an EEG correlate for that episode, then we can say that if these episodes are having any motor phenomena, these are known as electroclinical seizures, or if there is no motor phenomena, and then these are classified as the electrographic seizures. In the electroclinical seizures, they can be further classified into motor and non-motor seizures, which includes automatisms, clonic, epileptic spasms, myoclonic, tonic, and non-motor phenomena like autonomic and behavior arrest. In the recent classification, a new terminology was added, which is known as the sequential seizures, which I will be describing it later. In case of the electrographic seizures, what the ILE has defined the electrographic seizures without any clinical signs as a sudden abnormal EEG event defined by a repetitive evolving pattern with a minimum of 2 microvolts peak to peak voltage and a duration of at least 10 seconds. So if you see this EEG, there is continuous spikes in the middle part of the recording where this is evolving and it is lasting for at least 10 seconds. This is definitely a neonatal seizure. So the current definition of neonatal seizures is basically it is more EEG based, and now it is an electrographic event with a pattern characterized by sudden repetitive evolving stereotype waveforms with a beginning and an end. Duration is not defined, but this has to be sufficient to demonstrate evolution in frequency and morphology of discharges, and needs to be long enough to allow recognition of onset, evolution, and resolution of the abnormal discharge. So the seizure types as per the ILE, they have classified it, as I told earlier, into motor and non-motor phenomena. And in the motor phenomena, the further categorization is automatisms, clonic seizures, spasms, myoclonic seizures, and tonic seizures. The key is that these clinical events give a more or less idea of the etiological aspect of the seizures. Like oral automatisms in children are common in HIE or preterm neonates. Clonic seizures, a repetitive clonic jerking of the neonate, which is best seen clinically, is more seen in neonatal stroke or a hemorrhage. Infantile spasms are usually rare in the neonatal period, but they have been described in rare disorders of rare genetic causes like STXBP1 or inborn error of metabolisms. Myoclonic seizures in the neonate, again, they can be epileptic or non-epileptic, which are less than 100 milliseconds. They are also described in inborn error of metabolisms and early infantile developmental epileptic encephalopathies. And tonic seizures are also described in genetic neonatal epilepsies. So the new terminology added this time was a sequential seizures, where there is no predominant feature in a child, like a neonate suddenly has a behavior arrest for 10 seconds. In the same seizure, he starts having a clonic jerking of the left upper limb, and in the same seizure, he starts developing myoclonic jerks. So this phenomena in a neonate, which is commonly seen in neonate, is now described as a sequential seizures. And presence of sequential seizures in a neonate is highly suggestive of a genetic epilepsy or a channelopathy. Similarly, the other two non-motor phenomena are behavioral arrest and autonomic seizures. In autonomic seizures, apneas. Apneas are commonly seen in case of intraventricular hemorrhage and occipital lesions. So, for diagnosis of neonatal seizures, as I told earlier, there are three modalities. One is clinical observation, second is an amplitude integrated EEG, and third is a full conventional EEG, which we do. For the clinical observation, this study by Aline Malone showed that this study actually what they did was they took 20 video clips of the neonates and they out of which 11 were seizures and 9 were non-epileptic events, and they circulated it amongst 91 neonatal neurologists. And the average number of collectively identified events clinically were 10 out of 20. With an poor inter-observer agreement, the kappa was 0.21 to 0.229. So merely by clinical observation, it is nowadays very difficult to say whether this event is an epileptic or a non-epileptic event. So the ILE recently has laid down the diagnostic certainty for neonatal seizures. So this algorithm has to be followed. So if a child has a high risk for seizures, so if a child has a high risk for seizures or a baby has a clinical event, we first have a look whether the center has a EEG or not. If the EEG is available and it's a conventional EEG which is available, this is the gold standard for diagnosis when there is a conventional EEG correlate to the event. It is a level 1 evidence and we can label this as a neonatal seizure. However, if that conventional EEG is there and suppose the child is having some jerks and there is no EEG correlate, we can be sure that this is not a seizure. This is a non-epileptic event. We need not treat the child. In case a conventional EEG is not available, an amplitude integrated EEG is available. For amplitude integrated EEG, I would just explain what is an amplitude integrated EEG. It is a compressed version of the EEG where the entire epoch is compressed to a few seconds. So in that case, that has a level 2A evidence for diagnosis of a seizure. Suppose the center is not having any EEG available, and this event has been observed by an experienced personnel clinically. So only two types of event have a higher grade of evidence for labeling it as a seizure. One is a clonic seizure, like a clonic jerking of the limbs, and other being the focal tonic seizure. A focal clonic or a focal tonic seizures, we can say with a level 2B level of evidence that this is a probable diagnosis of seizures. Any other event like automatisms, myoclonic jerks, spasms, or behavioral arrest, they all need EEG correlate on conventional EEG to label it as a neonatal seizures. So the therapeutic options for treatment of seizures in neonates are limited. Frequently used anti-epileptics are not very effective. Concerns regarding the safety and adverse effects, short-term and long-term, including the effects on the neurodevelopmental. And under treatment and over treatment may have adverse consequences. That is why the ILE in the recently in 2023 they laid down the guidelines, consensus-based recommendation guidelines for treatment of neonatal seizures by the ILE task force, of which my guide was also a part of. So they laid down 6 main recommendations and 2 additional recommendations. The first recommendation was the first line medications for anti-seizure medication, and it was an evidence-based recommendation, is phenobarbital. Regardless of the etiology, whether it is an HIE or whether it is an intraventricular hemorrhage, it is phenobarbital. unless and until you are suspecting a channelopathy, like a sodium channelopathy, historically, or clinically you are seeing a sequential seizure, or clinically you are seeing myoclonic seizures, which your high and MRI brain is normal, and you are highly suspecting a genetic etiology in the neonate, you can use eptoin or carbamazepine, because sodium channelopathies, the response to sodium channelopathies is very good in these cases. The second recommendation was, among the neonates with seizures not responding to first line medication, phenytoin, levetiracetam, midazolam, and lidocaine may be used as a second line anti-seizure medication, and this was an expert agreement. In case of a neonates with cardiac disorders, since eptoin and lidocaine cannot be used, levetiracetam was the preferred second line medications for the treatment of the neonatal seizures. The third recommendation is the following cessation of an acute provoked seizures without evidence of neonatal onset epilepsies. Like I told you, in neonates, most 85% of the seizures are acute symptomatic seizures. There is an event, the child will have seizures for first 3 days, and then there will be a latent period for few months, and then probably once the child is 1 or 2 years, start developing epilepsy. So if without any evidence of neonatal onset epilepsies, anti-seizure medications, whatever was started during that time, should be discontinued regardless of the MRI or EEG findings.
Hello.
The fourth recommendation was, therapeutic hypothermia may reduce the seizure burden in the neonates with hypoxic ischemic encephalopathy. This is an evidence-based recommendation. The fifth recommendation was, since I told you that the neonate can have electrographic events also without any clinical correlate, treating neonatal seizures, including the electrographic only seizures, which we defined it earlier, to achieve a lower seizure burden is associated with an improved developmental outcome and reduces the risk of subsequent development of epilepsy. And the sixth agreement is, in case there is no response to the first line and the second line medications, a trial of pyridoxine has to be given in all neonates in children who present with vitamin B6 dependent epilepsy and seizures unresponsive to second line anti-seizure medications. Two additional considerations were there. A standardized pathway for management of neonatal seizures should be available in each neonatal unit, and parents and guardians of a neonate with seizures should be informed regarding the neonate having seizures and possible etiologies and initial treatment options with subsequent discussions based on the neonate condition. So I will discuss the third recommendation, where they say that following cessation of an acute provoked seizures, the guideline says that you discontinue the anti-seizure medications regardless of the MRI or EEG at discharge. Actually, this recommendation is a very definitive recommendation. From my point of view, we should consider the etiology, the neurological status as discharge, the neuroimaging, and the EEG at discharge, and subsequently reassess at 4 to 12 weeks in some cases. And the whole purpose is to avoid prolonged anti-seizure medications in infancy whenever necessary. So this was a study by Sharpe et al., which they have quoted in this study, in this paper, where they have compared the NeoLive study, where they have compared levetiracetam versus phenobarbital for the neonatal seizures, and they have said that 80%, like 24 out of 30, who were randomly assigned phenobarbital were seizure free for 24 hours, compared to 28% randomly assigned levetiracetam. This clearly shows that the phenobarbital as a first line medication has an edge over levetiracetam. There is another meta-analysis in the Indian Journal of Pediatrics published this year, where they have reviewed many articles, but there is very limitation. They have concluded that very low certainty evidence, the results of systematic review suggest that levetiracetam may be non-inferior to phenobarbital for managing neonatal seizures. Considering a better safety profile and marginally better neurodevelopment in the short term, levetiracetam may be considered as an initial choice for managing neonatal seizures. But NeoLive study clearly states that phenobarbital should be the first line management. So this is the treatment pathway for neonatal seizure. These are doses. Anyone can take a pic of this. So seizures in a neonate, first and foremost, we have to do an EEG, then the first line anti-seizure medications, phenobarbital, then second line anti-seizure medications, and special considerations in form of pyridoxine and sodium channel blockers for channelopathies like phenytoin and carbamazepine. So to conclude, I will summarize my talk. Most neonatal seizures are caused by acute symptomatic seizures. The classification emphasizes the key role of EEG for the diagnosis of seizures in this age group. Seizures are considered focal at onset in neonate, thus the division of focal and generalized in neonate is unnecessary, not required. All seizures in neonate are focal onset. Seizures can occur with clinical manifestations or without clinical manifestations in a neonate, that is electrographic only. Descriptors are determined by the predominant clinical feature, like a child may have multiple seizures, but which is the predominant seizures, that is how we'll describe the child. That into motor, non-motor and sequential, and I explained you what is a sequential seizure means. Clinical events without EEG correlate are not included, and you can safely say that this is not a seizure if the clinical event is not having a EEG correlate. Early distinction between acute symptomatic and unprovoked is essential because management differs. Acute symptomatic, you need not treat for a longer time. You can discharge the baby without the antiepileptics, but in an unprovoked seizure, a high possibility of neonatal epilepsy should be kept in mind. Phenobarbital is the first line drug, but it should be used for short term only. Second line is levetiracetam, phenytoin, midazolam, lidocaine, but there is no evidence which is preferable. Prophylactic treatment beyond the neonatal period is not recommended. Thank you.
Thank you very much, sir. Pandey sir, for guiding us the latest guideline for the seizure in neonatal seizures. I think any other questions will be taken afterwards soon.
Okay.
Thank you, sir.
Thank you, Dr. Ankit Pandey. Now I request speaker and chairperson to proceed towards felicitation stage. Good afternoon, friends. I hope you are all having a wonderful time at Nashicon so far. Please join me in welcoming our esteemed chairpersons for next session, Dr. Rahul Patil, Dr. Dinesh Thakur, and Dr. Anand Nagre. Moving to the next session, PET Talk, which promises to be both inspiring and uplifting, it's my honor to invite and introduce Dr. Mahesh Mohite, a renowned pediatric intensivist practicing in Mumbai with years of experience and deep passion for his work. Dr. Mohite has dedicated his career to care of critically ill children, and his expertise and compassion have touched countless lives. In the high-stakes environment of PICU, where challenges are immense and stakes are high, finding joy and fulfillment in our work can sometimes be a daunting task. Dr. Mohite will enlighten us how he navigates these challenges and finds profound joy in the practice of pediatric intensive care. Without much ado, please join me in welcoming Dr. Mahesh Mohite sir to the stage. Over to you, sir.
Salud. Take on full screen. Yeah. Good afternoon. First of all, let me thank the organizers for giving this opportunity. A different kind of a topic for me, a pet talk. And when I see that, I take it like a pep talk. So pep talk, more like a inspirational talk. And obviously, the inspiration is required for the subject where people may not be interested in future, and more people are encouraged to take that talk, that subject. So I'm going to tell you how the PIC is joyful. And the whole story begins because when I got this invite, I got sort of a call. It's not moving. Yeah. On a busy OPD on a Monday morning, way back about 2 years ago, I got a call, a youngster from the other side, which I didn't know at that point in time. He was calling from an airport. Said, Doc, I want to meet you. I said, I'm very busy, I can't. He said, Doc, I dropped at Mumbai airport, took my flight from Singapore going back to Los Angeles, but my father insisted that I have to meet you at some point of time. So I've taken a break and I have to take my flight late night to New York. I said, I had no option but to call him. After about 2 hours, a very young, dynamic person in his 25, 30s enters my clinic with a gift box and touches my feet. I was shocked. I still get kata hai to angar. And the fellow introduced himself as Yash Motwani, must be in 28 years old. He said, my father was a ispat engineer about 20 years ago, and when I was around 8 years ago, and then I was hospitalized in emergency at your place. I was suffering from dengue shock. I was ventilated, lot of lines here and there. And after about 12, 15 days of efforts, I was discharged. Then I did my IIT Kharagpur. Then I am joining in some multinational, and I'm looking after this Asian sector. Friend, that's intensive care. That's intensive care. And you sometimes get that kind of returns. Another very inspiring story. This was post-MIC, 6 years old child was brought to me from Mahad with a total gangrene of the intestine. He was in refractory shock. Very high risky laparotomy was performed overnight. He was pulseless. He was diagnosed as pancreatitis. His amylase were 5,000, 3,000 locally detected, so sent to us for pancreatitis. But he was refractory shock. The surgeon decided to open, and actually it was a gangrene secondary to MISC of the whole bowel. And this ultimately was settled down at our place and left for India's first small bowel transplant. This was India's first small bowel transplant. After 1 year, the parent, happy parent, bring this child. They spent almost 1 CR plus in this whole treatment. But still they are very, very kind of thankful to you. Friend, that's again an intensive care. Kya ho raha hai? It's not working. Slide is not moving. No. So basically, this is a field where you change lives of the children, you change lives of family, and you get instant, everlasting smiles. This is the only field. This is not a geriatric or adult medicine where they, even if they get better, next question is how much is the bill? And they are cribbling at you. This smile, this child, as soon as they get a little bit of recovery, he smiles. So again, that's an intensive care. I was always wondering what is an intensivist life. It's like a life of a pie. And you must have watched this movie. The fellow, once he passes his intensive care, he's in joy. I have won the world. Okay. Within no time, he finds himself into this disastrous ship. Somehow he manages to skip onto a boat, and he finds that I have survived. Just on the very next morning, to find another problem, which is again staring at him. And his whole life goes on and on and on, facing such kind of problems. At the end of the day, few of these intensivists manage to tame that tiger and sit with him, like Dr. Umali and Dr. Sunu Dani, who has been doing it for last 30 years and still staying in the same field. And few of them skipping that boat, patiently sitting outside doing the OPD practice and cold practice. That's what is an intensive care. Unfortunately, that's what an intensive. So is pediatric intensive care is in demand today? Recently, I heard Dr. Ramesh, who is a Rainbow Group's CEO, you know, Rainbow Children's Hospital Groups, 17 hospital, dream story. And what he said, to build up a pediatric corporate, you need an excellent pivotal role of an intensive care. That's the role of intensive care. And that's a demand. And believe me, the trend pediatric intensive has a huge demand, whether it's in domestic front or abroad, everywhere. So why I want to continue as an intensive? I ask myself why I want to continue. I am 60 today, nearing 60. Why I want to still continue? Because this is one field where you can practice everything that you have learned in medicine, irrespective of seriousness. This is one field where you can literally do everything that is available. You are saving the most productive lives. These are the children who are going to stay for 50, 70 years, going to deliver maximum. Sick, dying child, your efforts bring them quick smile, possibly only possible in pediatrics, unlike the adults and geriatrics. And obviously that the field which gives instant happiness. If you see this, this girl, a GPS, was on ventilator for 2 months, not moving any part of the body. And about 2-3 days ago, she started moving her neck. And look, everybody is happy. The doctor treating the child will have to tell me who is more happy. And that's what is intensive care. So that's what, this is our Vadia story. And so many stories we have seen this at Vadia or our intensive care. So that's the beauty of it. Of course, the technology has made, the precision medicine has made so much of changes. You can get exactly what you expect. Not exactly, but more close to than what it was about 20 years ago. Younger children with no or minimal pre-existing morbidity have almost intact survival today. And newer solutions like immunotherapy, ECMO, CRRT, transplant has really brought life. And once they are treated, most of them are permanently cured. That's the biggest part of pediatric critical care. Thus, depressing outcomes are minimal today. Why one don't want to be intensive? Many people keep on giving excuses. So, it is intense hard work right from the training till the end. But believe me, is it so? And where there is no hard work? Everywhere. Being a pet talk, I can say that I have lot stories to tell my grandchildren which they will be very proud of. And you can create those stories for yourself as well. Friends, human limitations do crop. As I said, I am nearing 60, so I feel physical limitations, and that's the excuse given by many. How long I am going to continue with that kind of a stressful work? Fine. You can create a team. You can take the juniors, you can train them, empower them, but don't forget, start sharing them with them also. Then only they will sustain with you. It can still continue for a very long duration of time. So you definitely, there are a lot of hurdles. Your wife asks, how much money you're going to get? You have no answers initially, but yes, over the time you can grow on that as well. There's a peer pressure. Your friend says, I started OPD 3 years ago, I'm having 50 patients, I'm earning so much, and then you are saying, what I'm doing in the ICU? Half the patients are going home paying me only 50% of the bills. So those can be the limitations, yes. There are huge infrastructural demands when it comes to intensive care. You really have to spend a huge amount. Limitation for growth depends upon where you're practicing, but if you're practicing at Nashik with whole northern Maharashtra supporting you, I'm sure sky is the limit. You can do a lot. It's less lucrative, perhaps that's a relative term, because what you need and what you want. There's a famous saying, "Zaruratein to garibon ki bhi puri hoti hai, aur shauk samraton ke bhi pure nahi hue." So it's up to you what you want and what you are satisfied with. Another question is early burnout. PICU is a part of your life. Let it be part only and not whole life. First question, every time we take for a life practice. Perhaps you need to understand just one part of it. At the end, I will be showing you a clip which can change your whole mindset. So consider that is just part of your life, not the whole life. With a good team, learn to switch off. That's the biggest problem we most of have. Patient लेके घर पे जाते हैं, patient इधर लेके घर पे जाते हैं, and रात को सबको तकलीफ देते हैं. So if you can learn that technique of switching off and switching on, that happens in the Western world because they have limited hours of 8 hours, 10 hours, which perhaps is a bit difficult. Take small frequent breaks, pursue some hobbies. Don't forget physical fitness is a mental fitness. This is given by very famous sports starter and Muhammad Azharuddin's statement this was, and I still believe physical fitness reflects your mental fitness. You can take your breaks, you can pursue your hobbies, you can do a lot. You can inspire your next generation. You can do physical fitness and all kind of hobbies. You can still continue with doing that in spite of doing a famous work. Unpredictable outcome is a universal fact of medicine which increases stress. So what is stress in medicine? You are worried. What will happen to this patient? Suddenly he crashes. I am sitting here, that patient in the ICU arrest, what will happen? So perhaps make the things more predictable. That will perhaps make it slightly less stressful to you. Don't forget your strength and your limitations. Follow thoughtful, controlled aggression. This will be time and circumstances related. Don't be over aggressive. You must know what you can do and what you cannot. You can't refer it to a proper place well in time. It's a small case. This was 26 July 2005. All of you must be remembering this date. We can't, like COVID, you can't forget this. This is a date when whole Maharashtra was underwater. Huge flood. My hospital was 8 feet ground floor underwater. 25th July, we got this case. 3 months old baby brought for fever since 5 days. No clinical localization. Primary investigation showing some serious bacterial infection, very likely. On the next morning, so the flood started in the afternoon. This child mother complains that my baby is not latching and sucking well. Some drooling of saliva and respiratory difficulty. This was a baby with a stridor. So she did it.
3 months old baby.
While intubation,
With stridor,
we noticed the
progressively
bulge of the
increasing since
posterior
last 24.
pharyngeal wall. So we did a CT, a massive retropharyngeal abscess was there. Now we are into flood situation. Bombay is closed. No referral center available. No surgeon is willing to come. What you can do? I don't know where this place. So basically, this is what we had to do. We had to drain the abscess ourselves. Now, is it possible to do today in the today's medical legal era? Fine, ketamine, intubation, do a big needle, a CSF needle I got, and intubated, drew about 30 cc pus from the retropharyngeal space, continued with antibiotics. There's no way you could, surgeon was not willing to come, anesthetist was not there, so we as an intensivist anesthetist, we surgeon, we did this, child survived, and I'm still following this child after almost now nearing 20 years, and child is doing quite well. So these are the kind of a controlled aggression that was I'm talking. I was talking relevant to the clinical situation. So before taking intensive care, ask yourself, do you really like it? Most important. Before entering, do you really like it? Not because something is making this or that attraction. Are you okay with 24/7? There's no time limit. At least in India, there is no time limit. How long you can sustain it? If you say I can do it for 40 years, 50 years, fine, you can take the juniors and continue beyond that. Financial logistics you will have to. I believe those working in the periphery outside of metropolis, this has to be part of a general nursing home, pediatric nursing home rather than standalone PICU. Standalone PICU cannot run without multiple super specialty feeding. Like in Vadia, we got 16 bedded PICU. At least more than half of them are referred by onco, neuro, cardio and all. Basic old infective disorders are hardly about 3 or 4 beds. Limitations of PICU and NICU you must know. And once you take it, give initial 5 dedicated years before you say that I'm done with it or I don't want to do it. Once you take a decision, give thoroughly, completely dedicated 5 years at least. I'm sure very few people leave after that. They definitely persist to do that. I hope, hey, ये video run नहीं होता है. 30 seconds.
Graduates, I feel your pain.
Very inspiring.
I know what it's like
of one
when
of the
people keep
legend.
asking
Listen to him
what
carefully.
your plan is for the rest of your life. They ask me, now that you are not a professional tennis player, what do you do? I don't know, and it's okay not to know. So what do I do with my time? I'm a dad first, so I guess I drive my kids to school.
3-minute video.
I play chess online against strangers. I vacuum the house. No, in truth, I'm loving the life of a tennis graduate. A few lessons I've relied on through this transition.
From here it starts.
Let's call
Please
them
listen to it carefully.
tennis lessons. I hope they will be useful in the world beyond Dartmouth. So here's the first. Effortless is a myth. I mean it. I say that as someone who has heard that word a lot. Effortless. People would say my play was effortless. Most of the time, they meant it as a compliment. But it used to frustrate me when they would say he barely broke a sweat. I didn't get where I got on pure talent alone. I got there by trying to outwork my opponents. I believed in myself, but belief in yourself has to be earned. Yes, talent matters. I'm not going to stand here and tell you it doesn't. But talent has a broad definition. Most of the time, it's not about having a gift. It's about having grit. In tennis, a great forehand with sick racket head speed can be called a talent. But in tennis, like in life, discipline is also a talent, and so is patience. Trusting yourself is a talent. Embracing the process, loving the process is a talent. Managing your life, managing yourself, these can be talents too. Some people are born with them. Everybody has to work at them. Second lesson, It's only a point. Let me explain. You can work harder than you thought possible and still lose. I have many times. Tennis is brutal. For me, one of the biggest was the finals at Wimbledon in 2008, me versus Nadal. Some call it the greatest match of all time. Okay, all respect to Rafa, but I think it would have been way, way better if I had won. Some defeats hurt more than others. I knew I would never get another shot at 6 in a row. I lost Wimbledon, I lost my #1 ranking, and suddenly people said, he had a great run. Is this the changing of the guard? But I knew what I had to do. Keep working and keep competing. In tennis, perfection is impossible. In the 1,526 singles matches I played in my career, I won almost 80% of those matches. Now, I have a question for you. What percentage of points do you think I won in those matches? Only 54%. The truth is, whatever game you play in life, sometimes you're going to lose. A point, a match, a season, a job. It's a roller coaster with many ups and downs. The best in the world are not the best because they win every point. It's because they know they'll lose again and again and have learned how to deal with it. Here's the third one. Life is bigger than the court. A tennis court is a small space. Even when I was just starting out, I knew that tennis could show me the world, but tennis could never be the world. I can't wait to see what you all do next. Whatever game you choose, give it your best, go for your shots, play free, try everything. Graduate.
That's the story. So the message I got, this is most inspiring talk recent time I've heard. Nothing is effortless. Take any field. Sincere, full-time, complete effort for 5 years, I meant to say in PICU. Win little over 50%, persist over long period, you can reach the top. He said, I won only 54% of my points. It's a very interesting calculation here. Difference between doing a little more versus little less than what is expected of you each day. So every day I increase by 1%. At the end of the year, I am 37 times stronger. And every day I do 1% less than what I was doing yesterday. I am brought down to 3% of what I am today. That's the importance of having added efforts every day. And last but not the least, don't forget, life is far more beyond profession and your PICU. If you take it in a proper perspective, you will never leave PICU. So that's the summary of success, the joy, and the PICU is no exception to that. Thank you very much.
Thank you. Thank you, sir. Such an inspiring talk, and a lot of us really got goosebumps with your success stories of PICU. I request Mahesh Mohite, sir, to proceed towards the felicitation stage, and I request Dr. Dinesh Thakur to felicitate Dr. Mahesh Mohite, sir. Our next speaker brings a unique blend of medical expertise and his adventurous spirit, which promises to make for an engaging and inspiring talk. It's my privilege to introduce Dr. Rishikesh Thakre, a distinguished neonatologist practicing in Aurangabad, who has made significant contributions to neonatology through his clinical practice, research, and education. His impressive career in neonatology is complemented by his remarkable experiences outside the hospital, most notably his journey to Everest Base Camp. And today we'll hear about this another facet of his life, his journey to EBC and valuable lessons he learned along the way.
Thank you so much. Very good afternoon to you all. It's indeed a pleasure and a privilege to be with you all. And let me take you beyond the walls of the pediatric world. The PICU, the NICU, or the OPD practice, wherever you are. This is a journey of a lifetime to the Everest Base Camp. To the world, it is Mount Everest, but to the Himalayan people, it is Sagarmatha mountain. And this is an epic trek, once in a lifetime, in a UNESCO World Heritage declared conservative area. Over a period of 14 days, you hike from a height of 2,000 feet to somewhere up to 18,000 feet. And the story begins with this video. Ends. For this is where video. And from here, what you have are people and animals with you, generations of herds of people who have been going through this journey, and you become part of this journey. As you go, video, right, you are mesmerized by the Buddhist scripts which are there all along the journey, the roads, the flags, on the bells. And they are all with spiritual scripts, and the people there feel that when you have these spiritual things happening, they get thrown into the environment, and directly, indirectly, each of us become influenced by this spiritual journey. And the panorama of nature as you walk through the water, and one of the highest suspension bridges that you would see and walk through makes this journey quite mesmerizing. There are two bridges here. One is the downward, which is now closed, but this is a one-way traffic, so you have to wait here till the yaks and the people from the other end walk through, and then you cross over. Or if you happen to be in the traffic jam, then it requires a lot of courage. This is what happens as you walk through. The environment changes. What starts to build something suddenly gets overcrowded with and we hardly have any over the next 100 meters. Video. You walk through the waters as the rain falls. Most of us would not want to ever walk in those rains, or you walk through and it falls simply because never ever you have had an So the first lesson I learned, come what you may prepare for ever in life, expect the unexpected. Every turn that you have, as you walk through those days, you are going to see the nature's life's unexpected moments to which you start becoming more and more tuned to. The journey walks you down, the journey makes you walk up. And every time you walk through and you ask your Sherpa, how much long do we need to walk? He says, और 20 कदम ही चलना है, 20 मिनट ही चलना है. And that 20 minutes never ends, for it is at least 4 to 6 hours a day. And then we started making a joke, we are just going to walk 20 minutes. Look at the Sherpa, and he used to smile at us. And this is how we walk 20 minutes, breaking the goal into small manageable goals. And you saw the mountains in and around, and you walked through, and as you walked through, you realized how small you were in this huge world of mountains. Look at our faces, grumpy, asking ourselves why the hell I'm here, leaving behind my soft, comfortable world. And this is again a photo, all of us lying down along the blunders of the road, very much tired and wondering what this exhaustion ever will land up to. But this is where a change in perspective took place. As you walked, you were overtaken by these Sherpas. They carried all the food, all the food items, and everything and anything that is required simply because there is no car which can take these items up. 2 cylinders, you can't even lift a 1 cylinder. And here you are walking through at that height, and imagine this fellow single-handedly on two shoulders carrying these two. Look at the amount of luggage and baggage these people are carrying. And to my surprise, as we were walking up, we were overtaken by a group of small school children in flip-flops. And that was the time I realized that never ever give up. There are people who are far better than you, and these are the people, common people, day-to-day life people who teach us a lot, and that was what was there as we started moving up. When you look around, if you have some time, it happens, especially in the first half, simply because you are energetic and you look around and you are mesmerized by the beauty. The snow-clad mountains, the valleys, the flowers, all of them make for a beautiful day. As you wake up in the morning, you find the clouds sitting next to you, very unusual sight, but something that makes you feel wonderful, and it's worth spending that 5 minutes for the entire 24 hours that you're going to slog out. And this is what happens as you look behind, look down, go around, look at the bottom, because these are small things that make you grow further and further. And if you happen to have some time more, and this happens especially if you are slow, and I became very slow as I started moving up the mountains, and then you start realizing there is a lot of beauty around. There were flowers, and everything looked like as if it was a mystical world, a magical world beyond dreams. And look how small we are in these valleys. And all these photographs, retrospectively, when I was asked to make the talk by Praveen, that was when I realized that I had gone through this journey and these were clicked by me only. Retrospectively, I realized it was a world where you are too small, insignificant, irrelevant. There I am at the foothill of the mountain, and look at the mighty mountains that are there. So what did we learn? As you look down, there was beauty. As you looked up, there was beauty. And this was also the time when you realized that nature is supreme. And in front of this nature, anything and everything that you plan is all by destiny, and you are very small, irrelevant, and hardly make any impact in terms of your near or long-term outcome. What you also realized as you move up is loss of vegetations. That tells us the oxygen is started to going down. And if you see, the pictures now suddenly become barren, the land becomes like a desert. And you walk through those long routes. There you are trying to see a barren land in front of you, hardly any vegetations compared to the first half where you would see forest and water, everything has now disappeared. You take one step at a time, you take long and winding roads, you think that there is a destination to be reached, and the destination doesn't seem to come any time, any near future. Every day started at 7 in the morning, and the distances were not long, but because of high altitude, you became hypoxic and you became slow. And look at all of us walking in a small ant-like way, hardly visible in that entire barren land, and hoping against hope, every step making us realize that breathing became difficult. At this high altitude, the amount of oxygen is about 50% of what it is at sea level. And this is where you again move towards the last step of this entire journey towards Gorak shape, which serves as a base. And this is the last descent which happens towards the Everest Base Camp. What you see is the last place or last area where you could stay, and thereafter comes the Everest Base Camp. Mighty alone, but you walk through. And this is where, as you walk through, you start realizing one of the biggest life lessons, and that is get comfortable with the uncomfortable. What else did we notice? All these faces of children, of people, all smiling through and through. I was wondering at this altitude and with hardly anything that a modern world would desire for, what was commonly seen on all their faces, which I still recollect and remember, is the smile. And this infectious smile was the one which was very contagious. And you realize that in life you hardly need anything more. We have so much of possessions, but we also have a lot of burdens which we carry. And we had also the privilege of meeting what is called as the Lion of the Everest, and that is Mingma. The Sherpa there in the blue jersey is the highest sought and highest paid Sherpa of the Everest, and he must be in his early 30s, but one of the most fantastic human beings, having done almost dozens of Everest expeditions. And when you talked with him, you realize the simplicity and the humility with which these people move along. The thing that always stayed with me was that all of these local people looked at you as guests. And for the first time, you realize the importance of what is meant by Atiti Deva Bhava. None of them, how many times you ask them to please sit with us and have food, would ever have food with you. They will always have food once the guest's food is over. Even if there was a donkey or a yak which was carrying our luggage, if he was empty, we would ask them to put their luggage onto those. They would say, no, this is meant for the guest, this is not meant for us. And that reflected their commitment, their simplicity, and their discipline at that stage. During the entire journey, nobody ever hassled with us about the fees for a cup of tea or coffee. Go to Lonavala, you will be charged 5 times, 10 times the amount of fees for that cup of tea or coffee or Maggie. That reflected their sincerity, their dedication, and come what may, they will never ever cheat you. So what else did we see? We saw a lot. As you end towards the journey of this trek, this is where all the dead people have been cremated. These are people who died during their expeditions to Mount Everest, and they are a reflection of how deadly the mountains can be. And time and again, everybody fears that such an event should never ever take place. And that is the legendary Scott Fisher. What Tendulkar is to cricket, Scott Fisher is to mountains. And this was a fellow who died there for no fault of his, for simply the nature had become too brutal. And that is how you learn so many stories which make you realize that this is where had a difficulty and had to be shifted back. But what I learned was I was not one of those. What it makes you realize is gratitude, that you have more than enough. What you need in life is simplicity. What you need in life is just a shelter, a cloth, a food, and the sight of near and dear ones. So let me end by saying that it is not the mountains we conquer, but ourselves. The mountains are within. The mountains are within. We each carry the mountains in terms of burden of anxieties, stress, fear, anger, expectations. The world that we need to conquer is within, not without. What EBC to me was a metaphor of the mountains to be conquered. Die with memories, not with your dreams. Thank you so much.
Thank you. Thank you, Dr. Thackeray. Your talk had made us to think about how lessons from such an extraordinary adventure can be applied to our daily lives. I request Dr. Thackeray to proceed towards felicitation stage. I request Dr. Rahul Patil to felicitate Dr. Thackeray.
For our next inspiring talk, I will like to invite our Ironman, Dr. Arun Gachale sir. He has made us immensely proud through his remarkable achievements, representing our country with distinction on multiple international platforms. Sir has completed half marathon and prestigious Tata Mumbai Marathon 8 times. He has started Ironman journey with Goa Half Ironman in 2019 and completed Australia Ironman in December 2019 and Germany Ironman in August 2021. He has completed his Ironman Kazakhstan in August 2022 along with his son Avishkar, who is also the youngest Ironman so far. His dedication to excellence is exemplified by his completion of the prestigious Ironman multiple times, showcasing unparalleled perseverance and sportsmanship. Moreover, Dr. Gachale sir has recently scaled new heights by conquering the grueling and physically demanding Comrade Ultra Marathon in South Africa, which is a 90 kilometers up run. Apart from all this, he has also worked as secretary and treasurer in Nasik IIP and is current president of IMA Pimpalgaon Vaswant. Sir organizes Pimpalgaon runs to spread awareness for fitness and also has started Siddhivinayak Fitness Club to boost sportsmanship. Over to you, sir.
थँक्यू मॅडम. थँक्यू मॅडम, खूप छान इंट्रोडक्शन दिलं. सर्वप्रथम आम्हा नाशिक IIPच्या विनंतीला मान देऊन इथे उपस्थित असलेले सर्व डेलिगेट्स, मी आपलं सर्वांचे खूप खूप स्वागत करतो. तसेच टीम नाशिकॉननी माझ्यासाठी इतकं छान आणि इतकं प्रेस्टिजियस असं व्यासपीठ उपलब्ध करून दिलं, त्याबद्दल मी त्यांना खूप सारे धन्यवाद देतो. मॅडमनी माझी जर्नी सांगितलीच आहे. मी अगोदर म्हणजे 10 ते 12 वर्षापासून या फिटनेस जर्नीमध्ये आलो. साधारणतः अगोदर मी रनिंग स्टार्ट केली, नंतर सायकलिंग, मी ॲट द एज ऑफ 37 मी स्विमिंग शिकलो. नंतर काहीतरी एक चॅलेंज घ्यावं म्हणून मग मी आयर्नमॅनकडे वळालो. हाफ आयर्नमॅन केलं. त्याच्यानंतर 2019मध्ये मी फुल आयर्नमॅन ऑस्ट्रेलियाला केले. नंतर जर्मनीला केलं आणि 2022 ऑगस्टमध्ये मी आणि माझा मुलगा जो 17 वर्ष आणि 4 महिन्याचा होता, म्हणजे ही इज यंगेस्ट आयर्नमॅन सो फार इन द वर्ल्ड, म्हणजे तो आम्हा गचाले कुटुंबीय तसेच नाशिककरांसाठी खूप अविस्मरणीय असा क्षण होता की तो यंगेस्ट आयर्नमॅन बनला. आता आयर्नमॅनबद्दल सांगायचं म्हणजे तुम्हाला सर्वांना माहितीच आहे, 4 किलोमीटर सी स्विमिंग असतं, 180 किलोमीटर सायकलिंग असतं आणि 42 किलोमीटर रनिंग असतं. हा सगळा इव्हेंट तुम्हाला बॅक टू बॅक करावा लागतो. आयर्नमॅनबद्दल बऱ्याचदा आपण बोलून झालंय, त्यामुळं मी त्याच्यावर जास्त हे करणार नाही, इन्सिस्ट करणार नाही. आता माझे मित्र, माझे नातेवाईक सगळे मला इतके शिव्या देतात. मी दरवर्षी काहीतरी एक टास्क घेतो आणि काहीतरी एक वेगळा उपक्रम राबवतो. तर मी साधारणतः खूप दिवसापासून माझं एक स्वप्न होतं की मला कॉम्रेड्स मॅरेथॉन पळायची होती. तर कॉम्रेड्स मॅरेथॉनचं डिस्टन्स जे असतं ते असं 90 किलोमीटर. म्हणजे तो विचार करूनच मी 1-2 वर्ष नको बाबा, आपलं आयर्नमॅन चांगलं. पण ते असतं ना की एक वेळ लागल्याशिवाय इतिहास घडत नाही, तसं मला ते झोपच येऊ द्यायचं नाही. म्हणजे स्वप्न असे होते की ते झोप येऊ द्यायचे नव्हते मला, जिवंतपणे म्हणजे जागे असताना ते स्वप्न पडायचे आयर्नमॅनचे, आपल्या कॉम्रेडचे. मग मी डिसाईड केलं की यार करायचं तर कॉम्रेड्स करायचं. तर कॉम्रेड्समध्ये 2 प्रकार असतात, मी त्याच्यात तुम्हाला थोडंसं वर्णन करतो. कॉम्रेड्स मॅरेथॉन ही स्टार्ट झाली 1921 साली, ज्यावेळेस म्हणजे पहिलं महायुद्ध चालू होतं. त्यावेळेस जे हुतात्मा झाले होते सोल्जर्स, त्यांना श्रद्धांजली अर्पण करण्यासाठी म्हणून कॉम्रेड्स मॅरेथॉन सुरू झाली. तिचे 2 रूट, एक डर्बन टू पीटर्समॅरिट्सबर्ग आणि एक पीटर्समॅरिट्सबर्ग टू डर्बन. म्हणजे साधारणतः अल्टरनेट वर्षी, म्हणजे समजा ह्या वर्षी अप रन झाली, पुढच्या वर्षी डाऊन रन राहील, असे साधारणतः ते रन असतात. अप रन म्हणजे तिचं 1950 मीटर इलेव्हेशन. साधारणतः कोणी जर सप्तशृंगी देवीच्या गडावर जर गेलं असेल तर सप्तशृंगी गडाचं इलेव्हेशन फक्त 550 मीटर आहे, फ्रॉम बॉटम टू पूर्ण देवीच्या माथ्यापर्यंत. आणि ते जे होतं ते 1950 मीटर म्हणजे सप्तशृंगीच्या ऑलमोस्ट 4 पट. आता आमचा जो कोच आहे डॉक्टर योगेश सातव, मला सांगायला आनंद वाटेल, कोणाचा तरी मित्र पण असेल तो, तर ते स्वतः पीडियाट्रिशियन आहे. नाशकात रनोलिक्स नावाचा ग्रुप चालवता. त्यांनी मागच्या वर्षी कॉम्रेड्स मॅरेथॉन केली आणि ही इज सेकंड फास्टेस्ट इन इंडिया. त्यांनी 7 तास 42 मिनिटात कॉम्रेड्स मॅरेथॉन कंप्लीट केली होती, 90 किलोमीटरची. पण ती डाऊन रन होती. डाऊन रनला कसं असतं, थोडंसं 70 साधारणतः 70% डाऊन हिल असतं आणि 30% अप हिल असतं. तुलनेनं थोडीशी सोपी म्हणता येईल डाऊन रन. ह्या वर्षी ती अप रन होती. अप रन म्हणजे 70% तुमचं पूर्ण अप हिल आणि 30% डाऊन हिल. ज्यावेळेस आम्ही सगळी ट्रेनिंग चालू केली तर सरांनी मला सांगितलं की गाचाले सर, शक्यतो विचार करा, ही रन जी असते अप रन असते, इथं DNF व्हायचं म्हणजे डिस्क्वालिफाय व्हायचं प्रमाण खूप जास्त असतं. सरांना म्हटलं सर माझ्याकडं गमावण्यासारखं काहीच नाहीये. मी पहिल्यापासून तोच विचार केलेला होता. मला स्वतःला पण कधी कधी असं स्वप्नावत वाटतं की मी आयर्नमॅन कसा झालो. तर मी कॉम्रेड पण एक विचार करू आणि सगळ्यांचे थोराबोटांचे आशीर्वाद, आमचे सिनियर मंडळींचे शुभाशीर्वाद, आमचे मित्र कंपनींचे पॉझिटिव्ह वाईब्स, या सगळ्यांचं हे करून मी 1 एप्रिलला रजिस्ट्रेशन केलं. आता रजिस्ट्रेशनसाठी एक क्रायटेरिया असतो, जी मुंबई मॅरेथॉन, दिल्ली मॅरेथॉन म्हणजे कोणतीही हैदराबाद मॅरेथॉन, कोणतीही स्टँडर्ड मॅरेथॉन ते 4 तास 50 मिनिटात पळालेले पाहिजे, म्हणजे तो कंप्लीट झालेला पाहिजे 42 किलोमीटरची. आता मॅरेथॉन म्हणजे काय असतं, हे 5 किलोमीटर 10 किलोमीटरला आपण मॅरेथॉन म्हणत नाही, त्याला रन म्हणतो. 5 किलोमीटर रन, 10 किलोमीटर रन. 21 किलोमीटरला आपण हाफ मॅरेथॉन म्हणतो. 42 किलोमीटरला आपण मॅरेथॉन म्हणतो आणि 50 किलोमीटरच्या पुढे अल्ट्रा मॅरेथॉन म्हणतो. तर आता ती जी 42 किलोमीटरची जी मॅरेथॉन असते ती तुम्ही 4 तास 50 मिनिटं. परत त्याच्यात पण 2 विषय असते, एक गन टाइम आणि एक आपला चिप टाइम, म्हणजे जी आपली चिप लावलेली असते त्याच्यात GPS असतं. मग त्यात बऱ्याचदा कन्फ्युजन होतं, कारण कसं आहे का चिपमध्ये ना 2-3 मिनिटाचा डिफरन्स येऊ शकतो चिप टायमिंगला. आणि गन टायमिंग म्हणजे तुमचं एकदा गन फायर झाली का तुमचा रन सुरू झाला, ते कॉम्रेडच्या बाबतीत असतं. त्यामुळं काय होतं, जो पहिला असतो त्याला तो बेनिफिट मिळतो, पण जो शेवटी किंवा लेट असतो त्यांचे 5 ते 7 मिनिटं 10 मिनिटं वेस्ट जातात. म्हणून ती जो चिप टायमिंग असतो, आम्ही 4 तास 50 मिनिटं न पकडता 4 तास 45 मिनिटच टार्गेट ठेवतो. बाबा 4 तास 45 मिनिटात 42 किलोमीटर पळालं तरच आपल्याला कॉम्रेडसाठी रजिस्ट्रेशन होणार आहे. सुदैवाने आमचं रजिस्ट्रेशन म्हणजे मुंबईलाच आमचं 4 तास 25 मिनिटाचा टायमिंग आला, खूप छान टायमिंग आला आणि मग आम्ही रजिस्ट्रेशन केलं. म्हणजे रजिस्ट्रेशन होईस्तोवर आमचं इतकी धगधग चाललेलं होतं की होईल का नाही, हाच खूप मनात खूप भीती होती. पण एक विचार केला की आयर्नमॅनची एक टॅगलाईन असते, एनिथिंग इज पॉसिबल. आता सरांनी जी व्हिडिओ दाखवलं त्याच्यात पण नेव्हर गिव्ह अप, म्हटलं विचार करू, आपण करू, काय जे काय व्हायचं ते होईल. नंतर आम्ही रजिस्ट्रेशन केलं आणि प्रॅक्टिस सुरू केली. पण आता ह्या कॉम्रेडची प्रॅक्टिस जी ट्रेनिंग असते ना ती पूर्ण रात्रीचे करावी लागते. म्हणजे आता रुटीनली काय असतं, जूनमध्ये तो इव्हेंट असतो आणि मार्च, एप्रिल, मे, जून आपल्या भारतात मरणाचं ऊन, इतका उन्हाळा असतो भयानक, आणि ती 8-8, 9-9 तास तुम्हाला कंटिन्युअस लॉंग रन कराव्या लागतात. म्हणजे रात्री 10 वाजता जर लॉंग रन केली तर आम्ही सकाळी 7 वाजेपर्यंत पळत असतो. रात्री 11ला सुरू केली तर ती सकाळी 8 वाजेपर्यंत, रात्री 12ला सुरू केली तर 9 वाजेपर्यंत. बरं, आता ही अपरन होती, त्या गोष्टीमुळे काय होतं का आम्हाला सगळे असे रोलिंग रस्ते पाहिजे होते किंवा सगळे डोंगर पाहिजे होते. मग आम्ही आमची सगळी ट्रेनिंग जी केली ती वणीला केली, काही लवासाला केली, काही लोणावळ्याला केली, म्हणजे असं जिथं रोलिंग हिल्स आहेत अशा ठिकाणी आम्ही ती ट्रेनिंग केली. आणि ट्रेनिंग आमची इतकी छान झालेली होती, म्हणजे साधारणतः एक मायलेज येतं दर महिन्याला आपलं 300-350 किलोमीटर जर झालेलं असलं तर इव्हेंट इझी होतो, असं हे इथून मागचे जे कॉम्रेड झालेले होते त्यांनी सगळ्यांनी सांगितलेलं होतं. आमचं साधारणतः 3 महिन्यामध्ये 1200 किलोमीटरचं मायलेज झालेलं होतं, म्हणजे आम्ही खूप कॉन्फिडंट होतो तो इव्हेंटसाठी. पण काय झालं, ज्यावेळेस आम्ही इव्हेंट सुरू केलं त्यावेळेस वातावरण बरंच बदललं तिथलं, म्हणजे तिथं पाऊस पण झाला, ह्युमिड पण होतं. इव्हेंट पण सुरू केला आम्ही डर्बन टू पिटर्स मॅरिसबर्ग. पण त्या दरम्यान त्या पूर्ण इव्हेंटला इतकं सुंदर आपले जे इंडियन्स, म्हणजे आता आपले 2ऱ्या किंवा 3ऱ्या जनरेशन्स त्यांचे तिथं आहेत, त्यांनी इतका सपोर्ट केला, खूप सपोर्ट केला पूर्ण. म्हणजे त्या 90 किलोमीटरच्या पॅचमध्ये जसं आपली आषाढी एकादशी वगैरे असते, आता सध्या जी पंढरपूरची वारी चालू आहे, रस्ते पूर्ण गावगावचे लोक तिथं बसलेले असतात आणि आपल्याला चीअरअप करत असतात, तसे आपले जे NRI इंडियन्स असतात तिथं ते चीअरअप करता आपल्याला कॉम्रेड्सला. आणि इतकं सुंदर ते आपलं अवभगत करता, म्हणजे इतकं छान स्वागत करता, खरोखर असं वाटतं का परत परत ते कॉम्रेड्स मॅरेथॉन करावे. आता ह्या कॉम्रेडचे जो 90 किलोमीटरचा पॅच असतो याच्यात तुमचे 6 कट ऑफ्स असतात. म्हणजे 18 किलोमीटर, 30 किलोमीटर, 42 किलोमीटर, नंतर परत तुमचे 57 किलोमीटर, 70 किलोमीटर आणि 80 किलोमीटर असे 6 कट ऑफ्स. आणि समजा 18 किलोमीटर आपण 2 तास 45 मिनिटात जायचं आहे आपल्याला, तर जर समजा जर ती 18 किलोमीटर पर्यंत जर आपण आपलं 18 किलोमीटर समजा लेट झालो, 1 सेकंद जरी लेट झालो, शेजारी लगेच बसेस लागलेल्या असतात आणि बॅरिकेड्स ठेवलेले असतात. आयुष्यात मी खरं सांगतो त्या बस बघून भीती पहिल्यांदा आम्हाला त्या दिवशी वाटली, कारण काय असं तो रस्ता बंद होतो आणि आपल्या सगळ्यांना लगेच बसमध्ये बसवतात, चलो नाशिक. म्हणजे इतकं भयानक 6 ठिकाणी तुम्हाला कट ऑफ द्यायचे असतात ते. तर खूप छान ऑर्गनाईज करता, ट्रेनिंग चांगली असल्यामुळं आमचं तो इव्हेंट पण खूप सुंदर झाला. म्हणजे 90 किलोमीटर अक्षरशः असं ते इट्स मेडिटेशन फॉर अस, म्हणजे असं आम्ही अक्षरशः मेडिटेशन सारखं एकदम स्वतःत इन्व्हॉल्व होऊन ते पळत होतो. 90 किलोमीटर स्पर्धा झाली आणि जे आम्हाला कॉम्रेडचं मेडल मिळालं, तेवढ्यात मी मुद्दाम ही जर्सी घातली आज. कारण काय, ह्या जर्सीमुळे एका माणसाचे प्राण मी तिथं वाचवले. काय झालं, आम्ही जे 300-350 इंडियन्स होतो, प्रत्येकाने आम्ही ती जर्सी घातलेली होती आणि जो कोणी इंडियन दिसला प्रत्येक जण त्याला इन्स्पायर करत, प्रमोट करत, पुश करत आम्ही पळत होतो सगळे. मेडल घेतलं आणि तिथं एक जण इंडियन कोलॅप्स झाला, मग तो पडला अक्षरशः. मग मी बघितलं त्याला ॲज अ डॉक्टर म्हणून, कारण मी पाठीमाग मुद्दाम डॉक्टर अरुण लिहिलेलं होतं, कारण बऱ्याचदा काय होतं त्यांचं कन्फ्युजन होतं ते अलाउ करत नाही, हात लावू देत नाही. त्यांना सांगितलं बाबा मी डॉक्टर आहे. त्याला उचललं, त्याला अक्षरशः 90 किलोमीटर पळाल्यानंतर पण मी त्याला खांद्यावर उचललं, कॅज्युअल्टीत नेलं, त्याला 1.5-2 तास त्यांनी सगळे फ्लुइड्स वगैरे दिले, IV फ्लुइड्स लावलं. आणि तिथं पीटर्स मॅरिजबर्गला प्रचंड थंडी, म्हणजे मे बी त्याला असं शॉकमध्ये गेल्यासारखं झालं. त्याला त्यांनी सिल्वर फॉईल गुंडाळलं, फ्लुइड्स वगैरे दिले, सगळे इंजेक्शन्स वगैरे दिल्यानंतर तो 2-1 तासानंतर शुद्धीवर आला. नंतर तो आला तर तो आम्हाला भेटला, तर अक्षरशः तो गळ्यातच पडला की यार तुमच्यामुळे मी आज वाचलो. मला ते आनंद वाटला की यार ही जर्सी जर नसते तर ती कदाचित माझ्या तो लक्षात नसता आला, किंवा त्याला पण मी कळालं नसतं की मी इंडियन म्हणून. तो कुठं बँगलोरचा वगैरे होता. आणि खूप छान वाटतं ह्या सगळे ज्यावेळेस आम्ही जर्नी करतो, म्हणजे आयर्नमॅनची जर्नी किंवा कॉम्रेडची जर्नी, याच्यात खूप मजा येते, खूप चांगले चांगले लोक भेटतात, इतकं छान व्यासपीठ आम्हाला उपलब्ध करून दिलं जातं. त्यामुळं असं वाटतं की प्रत्येक वर्षी एखादा इव्हेंट करावा. यात काही इफेक्ट्स असतात, काही साईड इफेक्ट असतात. इफेक्ट एकच असतो, म्हणजे फायदे एक असतात की बाबा तो ज्या इंडियाच्या तिरंग्यासाठी, ट्रायकलरसाठी लोक मरायला पण तयार असतात, तो आम्ही अंगा खांद्यावर मिरवतो. दुसरी गोष्ट, तुमची बॉडी इतकी दगडासारखी होते का तुमचं लोअर बॉडी आणि कोअर इतके स्ट्रॉंग, खूप स्ट्रॉंग होता, तुमचं फिजिकल फिटनेस खूप वाढतं. आणि तिसरं मला सांगायला आनंद वाटेल का, तुमचं ज्यावेळेस तुम्ही इंटरनॅशनली असे इव्हेंट्स करता तर सगळ्यांच्या नजरेत प्रचंड प्रेस्टिज तयार होतं. चौथं, ट्रेनिंग करताना ज्यावेळेस सगळे कुत्रे असताना सगळे फ्रेंड्स होता आमचे, कारण ते ज्यावेळेस अगोदर आम्ही ट्रेनिंग करायचो 4-4, 5-5 कुत्रे पाठीमागा लागायचे. नंतर अशी परिस्थिती निर्माण होती की सगळे मित्र होऊन जातात. ज्यावेळेस आपण रनिंग करत असतो ते बरोबर शेपटी हलवत येतात, किंवा सायकलिंग करत असतो त्यावेळेस ते बरोबर आपलं असं स्वागत करतात आणि अजिबात त्रास देत नाही. साईड इफेक्ट असे असतात की घरामध्ये ऑलवेज संचारबंदी लागलेली असते. थोडं जरी काही जर झालं, शनिवार रविवार लॉंग रन जर असली, थोडं म्हणजे भांडं जरी पडलं तर लगेच युद्धजन्य परिस्थिती निर्माण होते. त्या गोष्टीमुळे घरात बायका पोरांना पण वेळ द्यावा लागतो, फॅमिलीला पण वेळ द्यावा लागतो, आई वडिलांना, सासऱ्यांना, बाकीच्या नातेवाईकांना. ते थोडंसं जरा ती टेन्स सिच्युएशन असते. पण ही जी जर्नी ज्यावेळेस आम्ही आठवतो त्यावेळेस इतकं छान वाटतं की असं मस्त वाटतं. आणि मला असं वाटतं का प्रत्येकानं कोणत्या ना कोणत्या स्वरूपात छोटीशी होईनात, इथं बसलेले बरेच जण आहेत, आता सरांनी सांगितलंच की ते एव्हरेस्ट बेस कॅम्पला जाऊन आले, काही बरेच भरपूर जण स्पोर्ट्समध्ये इन्व्हॉल्व आहे. 1 तास तरी स्वतःसाठी देणं गरजेचं आहे. का तर ती ही एकमेव, हेल्थ इज वेल्थ म्हणतो आपण, म्हणजे इतकी महत्वाची गोष्ट आहे ही. आणि मी सुद्धा, म्हणजे मला ज्यावेळेस बॅकएकचा त्रास सुरू झाला, हायपरटेन्शन सुरू झालं, मी पण त्यावेळेस सुरू केलं. मग मी नवीन मुलांना तेच सांगू इच्छितो की बाबा तुमचा वेळ अजून गेलेला नाही, कोणतेच आजार तुम्हाला लागलेले नाही, लवकरात लवकर ही जर्नी सुरू करा आणि मजा येते. आणि ग्रुपमध्ये पळा, म्हणजे समजा तुम्हाला असं वाटतं की मी एकटा, मला खूप बोर होत आहे, तुम्ही कोणीतरी मित्र तयार करा, त्याला काहीतरी आमिष दाखवा का बाबा मी तुला पार्टी देईल, काही कराल म्हणून. त्याचं ग्रुपमध्ये तुम्ही 2-2, 4-4 जण जर काहीतरी ऍक्टिव्हिटी सुरू केली तर मग मजा येते. आणि जीवनात पण आनंद म्हणजे खूप आनंद मिळतो. मला फिमेल्स पिडिएट्रिशियनला अशी रिक्वेस्ट करावीशी वाटते की आम्ही आता जो आपण चॅलेंज घेतला राजश्री पाठक मॅडम, काय तर मॅडमचं डेडिकेशन आहे त्यांचं सगळं जम्पिंग जॅक्स नंतर पुशअप्स प्लँक्स खूप सुंदर. आणि खरोखर मॅडमकडून काहीतरी आपण प्रेरणा घेणं गरजेचं आहे. आणि फिमेलसाठी मी एकच सांगेल की आपल्या स्किनचा ग्लो जर बरकरार ठेवायचा असेल तर तुम्ही फिटनेसमध्ये या. खूप जास्त टाईम नाही घेत कारण आम्ही ॲथलीट आहे, आम्हाला टाईमचं महत्त्व माहीत असतं आणि फिनिशिंग लाईनच्या अगोदर आम्हाला पटकन म्हणजे त्या टायमिंगमध्ये यायचं असतं. थँक्यू वरण थँक्यू.
Thank you, sir. Your accomplishments not only inspire us, but also serve as a testament to your commitment to pushing boundaries. You are an exemplary role model in both medical and sporting communities. I request Dr. Dinesh Thakur, sir, to felicitate Dr. Arun Gachale, sir. AIMS, All India Institute of Medical Sciences, renowned for its excellence in medical education. It instills a deep sense of pride when one secures admission in it. Here, a pediatrician couple doubly stands proud as both their sons have gained admission into this prestigious institute. Yes, you all have guessed it right. It's Mr. and Mrs. Dr. Bharadia couple. I'm sure they definitely have a very inspiring story to share with us. It's my privilege to invite the hardworking mother, beautiful pediatrician, and a loving person, Dr. Vaishali Bharadia, to share her journey with us. Welcome, ma'am.
It's a pleasure to be here with you all. I thank Scientific Committee Chairman Dr. Praveen Kale and Dr. Amol Murkute in Nashicon 24 for giving me this opportunity to give this talk. So here comes our aim, how to aim for AIMS Delhi. Left, right. AIMS New Delhi. Yeah, it's a premier medical institute in our country. It's a dream of our every medical aspirant to secure the admission for UG study and PG study here. Let us start with our school journey, when we should decide for a career. I get so many phone calls from the parents after the results of my both the kids कि मैम कब से हम लोग कॉम्पिटिटिव एग्ज़ाम के लिए क्लासेस लगाना चाहिए, 4th स्टैंडर्ड में मेरा बच्चा है, 5th स्टैंडर्ड में मेरा बच्चा है. नो नॉट अभी इतनी जल्दी कोई ज़रूरत नहीं है. लेट देम एंजॉय देयर स्कूल लाइफ, लेट देम प्ले अराउंड. It's a time when he comes in the 8th or 9th standard, you start for preparing it. Decide for your career. There are usually students who are focusing on the science streams. They have the two options, either to take the biology group or maths group. So if your son or daughter opts for the biology group, then her main subjects will be the biology, physics and chemistry for the NEET exam. As we all know, there is only one exam carried out throughout the country, NEET exam for medical admissions. Last year, there were 23 lakh students who appeared for it, and we have only 1 lakh medicine seats available here. In short, this exam is of 720 marks, 360 marks for biology, 180 for chemistry, and 180 is for physics. NEET exam, as we know, it is based on the CBSE curriculum. So you opt for the CBSE curriculum in your school days and also in college days. It will help you to study it thoroughly. There are 3 main pillars to crack this NEET exam. The first and the foremost is the hard work of the student. Second is guidance from an experienced teacher. And third one is the support from parents. Once you finish off with your board exams in the 10th, you have join a coaching where all the 3 subjects, physics, chemistry and biology, they are taught under one roof. So ऐसा नहीं कि फिजिक्स का क्लास गंगापुर रोड पे है, केमिस्ट्री का क्लास कॉलेज रोड पे है और बायोलॉजी चल रहा है जेहान सर्कल पे. बच्चे का बहुत सारा टाइम यहाँ से वहाँ ट्रैवल करने में ही चला जाता है, स्टडी के लिए कम टाइम मिलता है और उसका स्ट्रेस भी बढ़ाता है. सो ट्राई दैट all the 3 subjects are taught under one roof. Preferably have a strong base for the preparation. Start early and having the basics clear is the key to success. Having the strong base. So strong base means 11th should be your perfect. And start preparing from day 1 of the 11th standard rather than waiting for the 12th standard. अभी 11th ही चल रहा है, देखूंगा मैं बाद में कर लूँगा, 12th में थोड़ा gear up कर लूँगा, नहीं कवर नहीं होगा. Start early in 11th standard. A strong foundation in 11th standard makes your 12th standard easy and helps to consolidate everything. There are some special advice for the preparation for the students. Structured preparation always necessary. Prepare your own timetable for the study, subject wise also and topic wise also. One needs to identify the key topics in each subject and you should go thoroughly through it. And maintain some realistic timetable, neither too hard to follow and nor too lax. You have to keep your weekly targets to complete the syllabus, weekly tests which are helpful to gain insight for your progress and your strength and your weaknesses. Evaluate yourself after each weekly test. Rectify your mistakes. Analyze it, whether it's a conceptual mistake or silly mistakes. And try to correct it and see to that it should not get repeated in next time. Focus on improving each week. Set the deadlines. Any planning without a deadline will not give the desired result. So perfect planning is required. In this 2-year journey, if you get a good peer group, it will be a blessings for you. Group study sessions allow the sharing of the knowledge and resources. Students can learn from each other's strength and they can clarify the doubts by discussing with each other. Healthy competition, a competitive but should a healthy environment, it can push the students to perform the better. Seeing the peers work hard can inspire the others also to put more efforts into it. आगे का क्वेश्चन रहता है हमेशा पेरेंट्स का कि मैं कौन सा रिसोर्सेस यूज करने चाहिए. तो स्टिक टू बेसिक टेक्स्ट बुक एज दिस एग्जाम इज NCERT based. NCERT textbooks are for each subject is a must. For biology, NCERT book is the Bible. And physics and chemistry, with this NCERT books, question solving is important and it will build your concepts. Some more books I will try to recommend. For biology, MTG, NCERT at your fingertips for practicing questions for the NEET exam. Campbell is not necessary, but you can refer it for the Olympiad exams. For chemistry and physics, everyone have the different resources, but the resources which we followed is MTG and Aryan books and also supplementary coaching modules which are available with your coaching. For test series, at least try to join one national test series which will make you clear where you are standing at your national level. Apart from the coaching, you have to follow 6 to 8 hours regular study for these 2 years. Plan your timetable, schedule for various exams, mock tests and Olympiads. Keep monitoring your progress, your test results also, and constantly try to learn and improve yourself. Only self-motivation and motivation is the key to your success. Things which you have to keep in mind during this preparation, keep the distractions to the minimum. Keep yourself away from the gadgets and social media. Decide a fixed time, half an hour or 1 hour. I think half an hour is more than sufficient in 11th and 12th. Only this much you can give for these gadgets and social media. Be optimistic. one step at one time. Be aware of your capacity. अगर बच्चे को वीकली टेस्ट में 80 मिल रहे हैं तो आप उससे 85 to 90 एक्सपेक्ट करो, ना कि 95. Don't pressurize your kids. Don't make any negative statements or comparison. ये टेस्ट में तो तेरे फ्रेंड को इतने अच्छे मार्क्स आए हैं, why you are so down? No comparison like this. Try to compare yourself with yourself only. Comparison of average marks in previous exams and next exams, like this comparison should go on. Family also plays a crucial role during this preparation. Try to give a separate room if possible, which will be a noise free and have a cool and clean atmosphere for the study. Parent can also get involved in preparing for timetable. Schedule for your various exams during these 2 years, some Olympiads and mock tests. Celebrate whatever the success you achieve during this 2 years. It will keep you motivating. Sound sleep for 7 to 8 hours during this journey is also important. Nutrition should be taken care. And try to maintain your hobbies and physical activity for an hour a day. Continuous 1 hour तो possible नहीं होता है, क्योंकि 11th और 12th में काफ़ी पैक शेड्यूल रहता है. तो जो भी आपका स्टडी ब्रेक है उसके बीच में आपकी जो भी हॉबी है या जो भी एक गेम आप पसंद करते हो, बैडमिंटन, फुटबॉल, टेबल टेनिस, वो आप खेलना ज़रूरी है. इट विल कीप योर माइंड फ्रेश. This journey is full of sacrifices for next 2 years, studying during the week and having the test on weekend. और जबकि आपके कोई फ्रेंड्स मूवीज एंजॉय कर रहे हैं, सीसीडी में एंजॉय कर रहे हैं, आउटिंग एंजॉय कर रहे हैं और आप टेस्ट दे रहे हो, बट डोंट फील बैड फॉर दैट. दिस 2 years आर बिल्डिंग योर करियर फॉर योर लाइफ. ट्राई टू एंजॉय दिस प्रोसेस. ये जर्नी में थोड़ा सा बीच में ओलंपियाड्स के एग्ज़ाम्स आते हैं. बायोलॉजी, केमिस्ट्री और फिजिक्स तीनों सब्जेक्ट के लिए 3 लेवल्स के एग्ज़ाम रहते हैं. ट्राई टू अपियर फॉर इट एटलीस्ट फॉर लेवल 1. ये आपको बताएंगे कि आपका प्रिपरेशन कौन से लेवल तक हो गया है. और एग्ज़ाम एनवायरनमेंट के लिए भी आपका बच्चा थोड़ा सा अर्ली एक्सपोज हो जाता है. एग्ज़ाम का स्ट्रेस हैंडल करने की थोड़ी आदत लग जाती है. इफ सेलेक्टेड इन लेवल 1 एट द ओलंपियाड्स लेवल, your student has to appear for level 2 and level 3 in the next year. And after the level 3, 4 students selected each year to represent India at the international level for biology, physics and chemistry. 3 Olympiads, 4 students are selected. ये हो गया स्टूडेंट्स के लिए. अभी रोल आता है टीचर का. 11 से ही कोई अच्छा सा कोचिंग क्लास पहले ही थोड़ा सा देख के रहिए आपको कहाँ पे कोचिंग लेना है. जैसे पहले भी बता चुके, पीसीबी अंडर 1 रूफ रहेगा तो बेटर रहेगा. वीकली पीसीबी टेस्ट चलते रहेंगे तो नीट के लिए आप अच्छे से प्रिपेयर हो पाएंगे. गुड टीचर्स मेक डिफ़िकल्ट कंसेप्ट्स ईजी टू अंडरस्टैंड. दे हेल्प द स्टूडेंट टू वर्क ऑन देयर वीक एरियाज. दे हेल्प टू बिल्ड द टेम्पो एंड कंटिन्यू मोटिवेटिंग द स्टूडेंट्स. सबसे इम्पॉर्टेंट है डाउट सॉल्विंग. आफ्टर ईच टेस्ट जिस क्लास में डिस्कशन होता है उस टेस्ट के बारे में और डाउट सॉल्विंग होता है, वो आपके रिजल्ट को काफ़ी बूस्ट करेगा. ये जीतू भाई दिख रहे हैं, कोटा फैक्ट्री. ऐसा एक टीचर तो भी आपको बच्चे को अगर मिल जाए ना ये 2 साल में, तो आपका रिजल्ट तो श्योर शॉट है. ही विल कीप यू मोटिवेटिंग. ही विल बी विथ यू इन ऑल योर अप्स एंड डाउन्स. Here come now role of parents. The most precious thing which a parent can give to their child is their time, जो आज बहुत कम लोगों के पास है. लेकिन ये 2 साल में अपने बच्चे के लिए निकालना चाहिए. Give them your full time at whenever they are at home. Try to be there at home. हमारा एक स्पेशल टाइम जो रहता था डिवोट करने का, उनको क्लास को ड्रॉप करना और पिकअप करना. पापा हमेशा ड्रॉप करने जाते थे, मैं पिकअप. तो वो दरमियान उनके क्लासेस में जो भी हुआ है हम सब डिस्कस करते थे उनके साथ. बी अ कंपेनियन ऑफ योर चिल्ड्रन इन दिस जर्नी. शेयर देयर हाइज एंड लोज ऑल्सो. कीप देयर मोरल्स हाई. प्रोवाइड देम अ केयरिंग एंड नर्चरिंग एनवायरमेंट. provide a balanced diet, mother का role है, to keep the student healthy and focused. So here comes the rapid fire for the NEET exam. Complete the syllabus by December end. 3 revisions of the whole syllabus before the final exams in May. Join the national test series to assess your standing at national level. Try to balance the board exams. Don't let them distract from you from your main goal, NEET exam. It comes in February month, board exams. And in last 2 months, solve the past 10 years paper of the NEET exam with the timer and evaluate yourself. टेस्ट सीरीज के लिए पहले भी जैसे बताया है, टू मैनी कुक्स स्पॉइल द फूड, फोकस ऑन योर क्लास टेस्ट एंड 1 नेशनल लेवल टेस्ट टू एनहांस योर परफॉर्मेंस. आखिरी के 2 महीने में ये क्लास की भी टेस्ट देनी है, वहाँ की भी देनी है, यहाँ की भी देनी है. ज़रूरत नहीं है, परफॉर्मेंस डाउन हो जाएगा इधर से उधर जाने में ही. सो थैंक यू. वी होप टू सी यू इन एम्स सून. थैंक यू. थैंक यू.
Thank you, ma'am. Thank you, ma'am.
Hello. I would
Thank you.
like to summarize, if you allow me. At the end of this pediatric talk, listening to all these expert and eligible speakers, what we learn? We learn is dream big, set a goal, work hard for it. Never give up. You will definitely end up achieving it. वो कहते हैं ना, किसी चीज को अगर तुम शिद्दत से चाहो तो सारी कायनात उसको मिलाने में जुट जाती है. तसंच, and last but not the least, आरोग्यम धन संपदा. धन्यवाद.
Thank you, ma'am. I can sense, feel, and experience the sentiments of joy and pride on your face. I request the chairpersons to accompany Dr. Vaishali ma'am towards the felicitation stage. Announcement for winners of jumping jack in females for more than 45 years. First prize goes to Dr. Rajeshri Pathak ma'am. Second, Dr. Sadhna Patil ma'am. Third, Dr. Shalaka Bagul ma'am.
So coming to our next session, common neurological emergencies, which will be delivered by Dr. Mahesh Mohite. He doesn't require any introduction. And I'll request Dr. Shama Kulkarni, Dr. Sagar Bhalerao, and Dr. Sulbha Pawar come to us the stage as a chairpersons.
आतमध्ये पॉइंटर क्रिएट करता येतो. पॉवर पॉइंट है ना, तिकडून रिप्लेस करतो. वो ठीक है. ये होता है ना, मजा नहीं है. नाहीतर ना ह्याच्यावर एक पॉवर पॉइंट लावतो, तिकडून ऑपरेट करता येतो. ठीक आहे. हे स्लाइड करू. ठीक आहे.
Earnest appeal to register for upcoming 24th National Conference of Adolescent Health Academy, Adolescon 2024, which will be held on 27 to 29th of September at Express in Nasik. This will be a unique opportunity to learn about newer approaches to deal with various adolescent health issues. Please contact registration desk at entrance for further details.
Yep. Thank you, organizers. Actually, the last session was really wonderful. And pick of it was the AIMS entry. Best one. I wish I heard it 25 years ago. Maybe it will be helpful to my next generation. But amazing session. And thanks for keeping that session, because it was of
extempore. We don't listen to those kind of things more often. Coming to the, not the business, but the profession. So common neurological emergencies, what a pediatrician can do. That thing was actually common neurological emergencies, but I thought I'll make it what we can do in a common pediatrician can do in that. This is a very, I'm sure all of you are facing almost every day at least one sort of this emergency in office practice, wherever you are practicing, either in the OPD, emergency room or ICU, wherever it is. And the common thing that we see in practice are basically either something presenting as status epilepticus, an unconscious child, a traumatic brain injury, an intracranial infection, encephalopathy, a syncope, quadriplegic weakness, acute ataxia, status. So when I look at this topic as such, in 2022 I was heading the pediatric critical care chapter. We made 5 super specialty subgroups and one of them was neurocritical care. And today we are having standalone 3 days conferences only on pediatric critical care neurology. So that is a spectrum of this disease. To finish in 30 minutes is going to be impossible. So what I've done is I have defined kind of an approach, sort of a gross management approach in the first section, and later on I will be taking 4 common emergencies which you take, and I will sort of update you what is happening today. This will be slightly faster lecture, so if you have any questions you can ask me at the end. So to all the clinical emergencies which I mentioned, those 7 or 8 things, there are a few more beyond that. The underlying pathology is of various types. Either you are dealing with a clinical or subclinical seizures as underlying pathology, or raised intracranial pressure, or ischemia of the brain tissue. It could be hypoxia, hemorrhage, loss of cerebral autoregulation. Few of the terms I am going to discuss and describe when I am going further with the lecture. And finally, direct injury to the brain, which may be by infection, inflammation, immunological and metabolic, of which I am sure most of you are seeing immunological complications quite often nowadays. In fact, the spectrum is changing from infection to immunological disorders, even in the Indian scenario. Far back it has happened in the Western world, but we are also seeing more and more immunological complications today. So when a neurological emergency of any kind, all those conditions which I mentioned came to us first, comes to you first in the emergency room, perhaps we have to go through these 6 things. You have to stabilize, you have to diagnose and evaluate, you have to control of the pathology and prevent the secondary injury, recognize underlying etiology and specific treatment if any, safe triaging when needed, and finally counseling and communication. Let's go through that one by one. So first and foremost, irrespective of underlying pathology, you need to stabilize this child. And that stabilization essentially comes, I am sure most of you gone through the advanced life support course. Stabilization comes with airway and breathing support. And again, the targets are slightly different when it comes to neurological condition. The hemodynamic support stabilization, that means you are monitoring his pulse rate, you are monitoring his blood pressures, urine output, the capillary fill time, the central peripheral core temperatures, those kind of things. So that's a hemodynamic we need to stabilize. And if you know a specific condition causing that disease, or you know it's a poisoning and you know the antidote, then that definitely comes upfront in the early stabilization period. Once you stabilize, then a diagnostic evaluation, which again will go under 3 gross headings. The emergency labs, which will do specific as well as in general in most of the conditions, which could be just hemogram, the systemic evaluations, so LFTs, KFTs, hematological parameters, and then condition specific diagnostic parameters. In the radiology, suitable to the appropriate conditions, a head trauma condition comes in, CT will be sufficient to do that. But if it's a status epilepticus, let's say encephalopathy, unconscious child, probably MRI. If it's a vascular anomaly, then you may be looking at maybe MR angio. So specific to the condition will ask for the radiology, and whenever appropriate and safe. So if there is a raised ICP, obviously one won't be doing CSF, but in the rest of the condition, if required, you will be doing a CSF. So that's about the diagnostic evaluation. Then comes control of pathology and prevention of secondary injury. Essentially, when you are doing the ALS support, what you are doing is preventing the secondary injury, because secondary injury is something which will be coming following the patient has had the primary injury is something which has happened at the event. So somebody had a road traffic accident, direct injury to the brain, something which has happened already, you can't change that. But subsequently, Secondary to that, this patient becomes unconscious, he vomits, he aspirates, become hypoxic, that added injury to the brain. He bleeds, he becomes ischemic, shocky, that's added injury to the brain. So those secondary injury to be prevented, that is to be done by airway breathing, circulation, stabilization. Controlling the seizure is going to add to the secondary injury. Measures to control the raised ICP, the ongoing inflammation to be corrected, euthermia, euglycemia, extremely important. Correction of dyselectrolytemia, this patient develops hyponatremia, it develops some other electrolyte imbalances, they will add to the problem, and loss of cerebral autoregulation. Now, this terminology, I am sure many of you must be already knowing that is nothing but the brain is smart enough that through some autonomic regulatory mechanisms, brain will, so if you look at this graph, this is cerebral blood flow and this is mean arterial pressure, and in this range of mean arterial pressure, so in adult it's 60 to 150 millimeters of mercury, in this range the cerebral blood flow is stable by virtue of your intact autonomic nervous system. If the blood pressure goes above that, then suddenly the perfusion will increase and cause cerebral edema, something like press. If it goes below this, then there will be serious hypovolemia and decreased supply to the brain and ischemia of the brain. Similarly, rising CO2 will cause increased supply to the brain and dropping oxygenation will increase the blood supply. So by autoregulation, I mean to say, you need to maintain these parameters. When there is loss of autoregulatory mechanism, the autonomic system is lost in certain, so severe traumatic brain injury, encephalitis, the autoregulation is lost, and then the perfusion becomes pressure passive, means as the blood pressure increases, the perfusion will increase, cerebral blood flow increase, which is quite dangerous. So there, your safety margin remains very, very small margin of error. Anything going slightly higher, you will be having cerebral edema. Anything coming slightly lower will cause ischemia, which will aggravate the secondary injury. That's what I meant to say, the autoregulatory mechanisms. They need to be stabilized, they need to be maintained as part and parcel of a cerebral protection. And these become irrespective of underlying pathology. Whenever you have any kind of a neurological injury, this will go hand in hand. Then recognize the underlying etiology and specific treatment if you have. And you have got all kind of gamut of pathology which can cause acute neurological emergency. It could be infection, immunological, stroke, epilepsy, post-surgical, tumors, genetic, neurometabolic. So many things can cause the primary emergencies in the neurology. If you can get hold of it, know that, then you can give a specific treatment of this condition. So problem and treatment modality which can be used immediately is all infection that you have. Immunological conditions are coming in a big way. So steroids, IVIG, the various biological that are available, and then of course intervention radiology whenever applicable. Surgical intervention, the raised ICP, going all possibilities tried, then maybe a decompressive craniectomy can be tried. And not to forget, neurology consult. When it comes to this emergency, always involve a good neurologist to help you in diagnosing as well as management. Coming to the next part, the safe triaging. Now, a general pediatrician who comes across this status epilepticus child or encephalopathic child, unconscious child, once he stabilizes it, next most important question, can you manage this child further in your setup, or you need to transfer this? If you cannot, then definitely what options you have, you discuss with the parents, find out whether they're okay with government hospital, public hospital or private, and then accordingly you confirm the vacancy. Most important, when you are transferring this patient, optimally stabilize this patient, and for the stabilization, the mnemonic is stable, S-T-A-B-L-E. S stands for sugar, T stands for temperature, maintain euthermia, E stands for stabilize the airway, because commonest cause of death is hypoxia and not the seizure. Stabilize the airway, maintain the good breathing. B stands for blood pressure and your bleeding, blood pressures, and yeah, that's all, blood pressures mainly. So hemodynamic stabilization. L for all the lines which are going to be giving the drugs on the way, and E for the equipments, or if you are on ventilator, you are on kind of suction machine or all monitors, then they should be confirmed that everything is in line, and then you stabilize. Try and send a more competent person because along with this patient, because on the way you may come across some critical emergency. If you are intubated, the tube goes out, then it will be disaster. So person who can take care of those emergencies should accompany this patient. Care while transport should be as good as a referring center. ICU ambulance is desirable, and pre and post transfer checklist and documented handover to avoid. Now, The initial 5 or 6 points which I am discussing, as I said, are common to all neurocritical emergencies, and this particular aspect of stabilizing and transport is perhaps the most neglected aspect in a pediatric critical field in the periphery, especially we working at Nashik, and we are having patient coming from Yeola, Sinnar, Nodasal. Patient had some critical emergency there and just leakage out. That's, I think, most dangerous. Stabilize there. If the airway is at compromise and intubate the patient, somebody should stay there. So target is this patient should be reaching the place in such a condition where something can be done for the patient. This is your primary emergency, your primary responsibility, that much should be given to the patient. Then the last and most, not the least, perhaps counseling and communication. So when you have this kind of an emergency, this is one part which is again failed, and that brings a lot of medico-legal problems subsequently. It's as important as patient management. Preferably one person continuously or regular allocating for primary information and updates. Explain the disease probably progress and all those things. I'm sure all of you are doing it, but maybe that's one aspect sometimes neglected. So one people keeps in communication continuously with the patient, with the relatives, and other one keeps managing. Option to transfer if critical and likely poor outcome. Essentially transfer if higher facility is needed. That's all. Now coming to certain common condition that we deal with. So I hope the initial aspect is to all the critical emergencies, neurocritical emergencies that we come across in a clinical practice. Let's go through some common case scenarios. The first, I am sure, unconscious child. So here was a 3-year-old child, normal at 3 a.m., left for babysitting. Parents left the baby with the grandparents for babysitting. Mother gets a call for irritability with unconsciousness and abnormal neck and limb movements at 4 p.m. and is rushed to local pediatrician, who notices there are some abnormal moments. So he gives anti-epileptic drug and baby stabilizes. No relief, so is referred to level 3. That's how it comes from all the way 100 kilometers and travels to us. Going into more details of the history, we realize actually it was not a seizure, it was a dystonic posturing. Going more into the detailed history, the grandfather was on haloperidol and he had consumed some pill. The simple clues to the diagnosis, a good thorough history and sometimes clinical examination solves most of the problem. Every unconscious child does not require MRI to diagnose it. Another case, 8-year-old boy went to school at 9 a.m. He was uneasy feeling and lethargy and later giddiness. So the mother was called. By the time she comes at 11 o'clock, child convulses in the school. He is taken to the nearby hospital. Seizures is controlled by lorazepam immediately. But history suggested focal seizure, so CT was done. And a CT revealed a leptomeningeal cyst which was in left parietal region. So oxcarbazine was started. And the child was left like that in the nursing home. In next 12 to 18 hours, the child was not getting up. So just till that time nobody noticed. They gave seizures, रुक गया अभी ठीक है चल रहा है IV fluid चल रहा है everything. Mother after 12 hours says साहब अभी उठता क्यों नहीं है. So that's how the primary nursing home thought there's something serious and was referred to us. And to our surprise, he had hypertension. His blood pressure was 160 by 140. Nobody has taken the blood pressure in this child. Simple mistakes are done in the periphery. He had papilledema. Detailed evaluation revealed left kidney contracted with clot in the aorta at the origin of the left renal artery. Child had intractable hypertension, could not be revived. He died. So he was going through subclinical seizures for last maybe 12-16 hours. And so simple things. So unconsciousness, which can be encephalitis or encephalopathy, its awareness of self and its surroundings. It relies upon intact, so a little bit of anatomy of unconsciousness. If you know the brain, you can have unconsciousness due to supratentorial lesions or infratentorial lesions. For supratentorial to cause, you need to have a bihemispheric pathology. It's a uniside, so large hematoma, it has to compress that side as well as the other side to cause unconsciousness. But a small region in the brainstem which is affecting the reticular activating system, that can cause unconsciousness. So small lesion here, so brainstem encephalitis can make somebody unconscious. But for this area to get affected and cause unconsciousness, you need to have a very large area to be affected. Classically, subdural, extradural hematomas, or maybe a large tumor, a single tumor. You have seen large tumor, still patient comes walking to you. No unconsciousness. Unless and until it starts compressing both the side of the brain, it will not cause unconsciousness. So etiology of unconsciousness, it could be major groups grossly. Either they are direct brain injury, like meningitis, encephalitis, immunological causes. We are seeing lot of autoimmune encephalitis nowadays. Trauma, tumor or complications, but not to forget the systemic disorders like plain ischemia, hypoxia, In fact, in ICU scenario, status epilepticus, if I ruled out intracranial infection and encephalopathy, the transiently recovering ones are predominantly shock related. In a dengue period, you see an unconscious child, you revive the shock and the child becomes conscious. So this group is also not less, ischemia and hypoxia, and of course toxins, poisons, all those things can cause unconsciousness. The clinical evaluation, once you get unconscious child, obviously stabilize ABCD as I already told you, the detailed history, the examination which will give you clue. One which is commonly missed is the eyes. आंखें बहुत कुछ बोलती है. Are they equal? Pupils are equal. Are they reacting to light? Are their eye movement normal? Is the voluntary movement normal? Are the reflexes normal? How is the fundus? You can get, I can tell you many patients we have picked up just looking at the eyes. Poisonings are the commonest ones. We have seen the belladonna poisons, we have seen the organophosphate poisons and all. Just picked up on these little kind of clues. Investigations are guided by history and examination. The basic hemogram, the emergency labs, apart from that, CSF whenever it is stable or safe, there is no evidence of raised ICP, you'll go for it. Slightest doubt of it, preferably don't do that. You can do it after 48-72 hours after controlling the ICP. Infection evaluation appropriate to clinical condition, the basic LFTs, KFTs, and one last point, age is most important to rule out. If this child who comes with status epilepticus or unconsciousness, if the child is not getting up after next 2 to 4 hours, always do a EEG. Bedside EEG will definitely help you. At least you can stop this child for going towards a ultimate kind of a mortality. Supportive management to prevent. So once you've done this investigation, simultaneously you are doing the supportive management apart from stabilization. The specific management will be relevant to the suspected or confirmed diagnosis. Correction of metabolic derangements which are commonly missed, the electrolytes, calcium, etc. Antibiotics and antiviral appropriate to the condition. Immunomodulators nowadays we are using a lot. Antidotes and SOS surgical. So unconscious child is a big kind of a spectrum. Based on the underlying pathology you are going to specify, but what is most important, stabilize airway, breathing, circulation has to be controlled first and then look for the probable pathology. Status epilepticus, another common condition. So here's a 6-year-old girl brought for fever for low grade 2 days, fever low grade for 2 days. 1 day later she gets first JTC, hospitalized, seizure controlled immediately, had repeat seizures next day. So these are typical scenario of fires. एक दिन आया सीजर, बच्चा अच्छा लग रहा है, हमने रखा. दूसरा दिन 2 सीजर आए, हमने मेंटेन किया. तीसरा दिन से कंटिन्यू से आ गया. अभी पेरेंट्स को बताना मुश्किल होता है अभी क्या करें. And then it goes to 3 drug, 4 drug, 5 drug, and you're absolutely locked. The typical fires we are seeing. I'm sure many of you must have seen child between somewhere like 5 to 7 years of age, and that's a time when 4th or 5th day you say, तो अभी तक क्या कर रहा था, पहले क्यों नहीं बोला? Whole controversy starts. It's a very difficult condition to anticipate many times. So fever-induced refractory status epilepticus is a condition, and believe me, if they are not picked up early, they are the ones who will stay in your ICU for 1 month, 2 months, and they will be left with severe morbidity, many times mortality. So status epilepticus, as you know, it's a common below 2 years. Morbidity post status epilepticus is almost 15%. There are various terms, refractory status. So any child brought seizure into your hospital is status epilepticus. Any child having seizure more than 5 minutes, or any prolonged multiple seizures with intermittent period of no sensorium or unconsciousness is a status epilepticus. When it's called as refractory status, when 2 common drugs, of which the first one being benzodiazepine and one more drug, either levetiracetam or phenytoin is given, still it is not getting controlled and generally beyond 1 hour, then we call it as refractory status epilepticus. Why this terminology? Because beyond this, what is going to be required will also cause destabilization of his respiration and hemodynamics. So ideally, henceforth, beyond this point, he should be transported to a setup where all these ventilation and hemodynamic monitoring facilities are available. And what is super refractory? Something which is going beyond 24 hours. And then chances of this child's intact survival is very less. Very aggressive management, anesthesia drugs, immunomodulations, ketogenic diet, everything will be required. So be careful of these definitions and then kind of manage this patient. This new terminology, I'm sure few of you may be knowing, T1 and T2. The T1, so basically there are a lot of electrical currents happening in the body, but your brain is trained to control them within first 3 to 5 minutes, irrespective of your efforts. So if any seizure lasts beyond that controlling point, then you definitely require treatment. That point is T1. So beyond that time, if the seizure continues,
you have to give medication, that is T1. And after a certain point of time, it continues beyond that time, the chances of that seizure or that status epilepticus damaging the brain is high, irreversibly or permanently. That is called as T2. In case of a GTC, generalized tonic-clonic seizure, T1 is 5 minutes, T2 is 30 minutes. In case of a focal seizure, T1 is 10 minutes, T2 is 60 minutes. In case of absence, we don't know how long. But this is very important because this will tell you how aggressively you need to control this seizure. Important categories nowadays we talk about new onset refractory status epilepticus, fires, I already told you, fever induced status epilepticus. It's important to decide aggression of treatment. That's what I mentioned about T1, T2. And at refractory status, if you land up super refractory. So at refractory, you're going to go with 2 drugs, 3 drugs, anesthesia, gases. At super refractory, you will be thinking of straightaway alternative modality like immunomodulation or ketogenic diets. As far as evaluation, after stabilization, history of probable cause, it could be acute symptomatic, remote symptomatic, you will be looking up to the history. In non-epileptic patient, possible triggers including non-compliance, you might have missed certain doses and that could be the cause, and evaluation for the functional derangement of various systems, so LFTs, KFTs and rest of the supportive things. You are going to use a lot of medication which will be having some systemic dysfunction coming, so you must know the baseline parameters. And investigations are almost same as unconscious child. This statement I am repeating again and again and again. The post-control of convulsive status epilepticus, if child is non-responsive for say more than 1 hour, 2 hours, go for EEG. He may be having subclinical seizure. If that goes undetected for 2 hours, 3 hours, 4 hours, that kind of a metabolic demand cannot be sustained by heart, and these are the patients you will find dead after 6 to 8 hours if they are not picked up early. So don't miss, this can be the whole lecture series of status epilepticus. This is the most important point. Last week only we saw a child coming with febrile seizure, was referred to us after 4 hours because she is not getting up still. Turned out to be a NEC, acute necrotizing encephalitis. Touch wood, she came at least at 4 hours. So everything aggressively done. She survived, but very likely will be a morbidity. So be careful. Child is not getting up after 2 to 3 hours of your stoppage of seizures. Be very aggressive in evaluating. These protocols you will find anywhere in the book. I will give you the summary of this which we follow in our center, and this is a summary. Those who want to take it, you can take a snap. So after doing airway breathing circulation, first dose we use is Loraz 0.1 mg per kg, which we repeat after 5 minutes if the seizure is not controlled. Then we use levetiracetam. That's a new thing which you are using now aggressively, 60 milligram per kg, not the dose. Loading dose is 60 milligram per kg followed by 10 milligram per kg twice a day. If sometimes we may use phenytoin or fosphenytoin, if that is not working, so now we are almost entering into the refractory status wherein Midas infusion we use preferably. If there is no response, then we are quickly into preparing for keto diet. So in my unit, after 12 hours, if the seizure is not under control, we are almost started to prepare for the keto diet, especially in the refractory, that FIRES group, because evidence is shown that FIRES group, the keto diet is much better. General anesthesia, drugs like ketamine, thiopentone, propofol, monitor hemodynamics in Vasilium, support the respiration, all those things. Try other anti-epileptic. There is a seizure simulator. Obviously, at this time, you definitely involve a good neurologist for your help. Avoid secondary injury. So doing all those things, never ever neglect A, B, C, airway, breathing, circulation, because secondary injury is going to further damage the brain. Traumatic brain injury, head trauma, 3 years old, had fall from 2nd floor balcony, brought convulsing, seizure stopped after lorazepam, admitted for monitoring. He had recurrent seizures following that, subsequently deteriorated, ventilated, pupils are unequal, his posturing, aggressive evaluation and management followed. And this is a condition where I was, so all you may be knowing this doctrine, Monroe-Collet doctrine, the skull has 3 component, brain, which is 80%, blood and CSF 10%. Increase in any of the component will be the compromise of others, especially if the brain cell edema increases by even 5% of the volume, it's going to seriously compromise the blood supply, hence the secondary injury, and that we need to keep in mind when you are treating this patient. Obviously, with the raised ICP, you have the presentation as headache, vomiting, altered sensorium. So monitoring the GCS is extremely important when you're monitoring such kind of patients. Features of underlying pathology and etiology has to be looked at. Examination, you will be looking at the pupillary changes. So following the pupillary changes, unequal pupil, non-reacting pupil, fundus, focal defects, all those things. I'm sure you know all these things. The imaging, you all know, you can have loss of cortical or kind of gray-white differentiation. You have got a packed basal cisterns. You may be having this white cerebellar sign as a feature of again kind of a severe raised ICP. You will have a hydrocephalus with periventricular ooze. You may be having a slit ventricle in case of a shunt which is obstructed. You may have a large hematoma with a shift of midline due to subdural hematoma. So all kind of features you can get, you can pick up on a MRI. Commonly MRI is deferred many times for want of child both serious hai, ye hai, hila nahi sakta, don't do that. Take with your unbowing, take with your lines, take your inotrough, quickly get the imaging, because many times you may have a treatable condition inside which will be picked up. NX you cannot pick up on clinical, you will have to do an MRI and then you are aggressive. So whatever minimal little optimum stabilization, quickly move into radiology, you will be really delighted to see the results, and that will be helpful to manage this patient. Management principles of ridge ICP, you all know quickly about the ICP bundle that we do. Head high position 30 degrees, midline position of the head so as to avoid the compression of the interjugular vein and to raise ICP. Avoid stimulation of all kinds, sedation, analgesia, paralysis, optimizing ICP. Pre-procedure medication very important, lidocaine, prevent and control the seizure. So it's all about giving minimal stimulus to the brain and avoiding the secondary injury by giving optimum oxygen and circulation to the brain. Very important this part, the targets which I told you about stabilization, the airway and breathing and circulation. Here we want the hemodynamic target, mean arterial pressure should be kept on a higher side so as to the brain will be perfused. Raise ICP brain, the pressure is high, you want to keep the arterial pressure high. So keep the mean arterial pressure high, that is up to 95th percentile target, and you will be slightly hyperventilating the child to keep the CO2 between 35 to 40. At times in case of acute severe ICP surges, we may have to further take it down. We may be ventilating between 30 to 35 of CO2. Deep sedation, analgesia and paralysis whenever essential, and perhaps in most of the raised ICP patient, we want to keep them absolutely knocked down as far as possible and avoid hyperthermia. There are no specific therapies, but yes, in case of cytosis, so ischemic heart is there, or ischemic kind of a brain is there, then therapeutic hypothermia, now there are limited kind of papers on this. People are moving away from that. You all know about osmotic therapy. There is a increased perfusion, brain cell edema, then one may be using mannitol at 3%. There is vasogenic edema like TBM or tumor, you may use steroids, and then if everything is tried and not working, then decompressive craniectomy. Specific treatment, treat the underlying cause. Last case, maybe another 2 minutes. So very interesting, and I'm sure you will be shocked to see these cases. So be careful about this kind of cases. This is the one which is not a routine one. A 10-year-old boy admitted to primary pediatrician with a history of fever for 2 days. Confirmed NS1, dengue. All right for next 36 hours. At 10 p.m., this is a true story which happened last year in Raigad itself. 10 p.m. on second day of admission, had sudden severe headache with fever spike of 102. Rapid deterioration in the next 6 hours. He went into shock, progressive encephalopathy. He was intubated. He was traveling from almost 100 kilometers away. The pediatrician himself accompanied him, but by the time he reaches us, 2 hours transport, reached pulseless. The GCS was 5. We did a bedside echo, ejection fraction was 10 to 20%. Deterioration started, since the history started with encephalopathy as a deterioration, we did an MRI. And this is an MRI. You can see the hemorrhagic necrosis of the brainstem and thalami. This is acute necrotizing encephalitis. A nightmare for a pediatric intensivist. But if you go with this diagnosis and you know this diagnosis, you have a medical explanation. You can imagine the pediatrician, primary pediatrician treating this child without any facility. This child suddenly dies within 6 hours, and I have seen at least 6 cases behaving like this. They literally die in front of you within hours. So you don't pick them up, you are going to be in disaster, because everything, the mob and everything will happen. So thalamic hemorrhagic infarct, steroids are pushed first, methylprednisolone. Additional investigation is ferritin was 7,540, fibrinogen was high, OTPT were high, he received IVIG, but there was poor response, so prognosis was explained, and child succumbed within 12 hours. Its final diagnosis was NEC. What more can be done? Most important, low index of suspicion. Sudden, severe, acute, potential condition. Think of NEC. Don't waste time. And it requires MRI to diagnose it. If you have a slightest suspect, give first dose of methylprednisolone immediately, IVIG, and nowadays this new study has come by Dr. Lokesh Lingapar from Hyderabad. They have studied 42 cases with tocilizumab upfront. The mortality is reduced. Don't ask me about morbidity. Believe me, morbidity is still the same. Perhaps we are in that learning curve. Previously, 100 used to die. Today, maybe 50 are dying. They may come, and those 50 are morbid. They may come that 50 will be normal and 50 will be morbid. So that's kind of a learning curve we have. We may find some better drugs in future. So with decreasing incidence of infections, immunological disorder is making larger proportion of neurological emergencies. So we are seeing a lot of cases of immune demyelination, degenerations, and anechoic conditions. So friends, to summarize, pediatric neurological emergencies are common next only to respiratory ones in pediatric practice, but carry far more morbidity and morbidity, and they may not give you time. Early recognition of red flag signs in common conditions will ensure prompt intervention, reduced morbidity and mortality, and office pediatricians should sensitize themselves for such red flags in seemingly not so sick children. Trend is changing from infection to autoimmune disorders. Recognize them early to avoid. Infection are a subacute category, as Dr. Ambedkar says. Hyperacute, acute, subacute, and chronic. Hyperacute is immunological, vascular, traumatic, metabolic, allergic. Acute is infection, or subacute is infection. So subacute will give you some time. Infection don't kill anybody immediately. But this hyperacute category, the new coming immunological ones, those who have seen those 4 or 5 cases, they'll be scared to see these cases. So recognize them early, transfer them to the proper condition in time. Thank you very much.
Thank you, sir, for such an informative talk. I request speaker and chairpersons to proceed towards a felicitation stage. Thank you, sir. There is one important announcement. Excuse me, there is a car MH15FT4527 that is not parked properly and it is blocking other vehicles. We request the owner of this car to please remove it immediately. I repeat, MH15FT4527. There is one more important announcement. There will be a 20% discount on registration charges for Adolescon only for Nashicon delegates for today and tomorrow. So don't miss this opportunity. Register at the earliest.
For our next talk, it gives me immense pleasure to invite the senior most pediatrician of Nasik, Dr. Ramakant Patil sir. He needs no introduction. Words will fall short of to describe his qualities. And he is known for simplifying what is often very complicated and confusing in the areas of clinical practice. Adenotonsillar hypertrophy is the most common cause of upper airway obstruction in children that usually presents with chronic upper airway obstruction and most notably obstructive symptoms at night. Over to you, sir. The chairpersons for this session are Dr. Prashant Wagh, Dr. Deepak Pawar, Dr. Piyush Ranbor, Dr. Vilas Mahajan.
Thank you, organizing committee. Are the chairpersons, I take the privilege to invite them. So adenotonsillar hypertrophy, which way to go? I remember the eulogy, Quo Vadis. Saint Peter was asking Jesus, Quo Vadis. It is idiomatically suggesting that where are we going? So which way to go? It is time to reflect in adenotonsillar hypertrophy. Gone are the days when isolated tonsillectomies were done. It must have reduced to 5% or 10%. So where and which way to go? So Juan Voltaire described this Voltaire ring. It is mucosal associated lymphoid tissue. The classical tonsils are palatine tonsils. There is a lingual tonsil. There is a tubal tonsil surrounding eustachian tube and a nasopharyngeal tonsil which we classically say as adenoids. And what is the enigma of this adenotonsillar hypertrophy? These are the sentinels at the crossroads. These are sentries at the entry. These are reservoirs of microorganisms, and these sentries sometimes kumpana shet khata, and in that case we have to decide which way to go. And the complexities of airway constrictions are important in adenotonsillar hypertrophy, and there are too many challenges in the treatment. What is the basic difference in tonsils and adenoids? Tonsils are having deep crypts. Adenoids are lesser having crypts. Tonsils are having more of a problem of infection and inflammation. Since crypts are deep, the debris and microorganism get embedded and it causes recurrent tonsillitis. As many of us do not accept the term chronic appendicitis, we say it is a recurrent appendicitis and acute appendicitis. Similarly, tonsillitis is only acute and recurrent tonsillitis and not a chronic tonsillitis. Many school of thought say that it is not a chronic tonsillitis. What is problem with adenoids? The crypts are not so deep, so there is a problem more of a hypertrophy rather than infection and inflammation. And this hypertrophy causes the space oriented problem, and the nasopharyngeal space is obstructed and it has got its pathogenesis. So these two distinct suggest of the same thing. So evaluation of acute and recurrent tonsillitis. I have got my senior colleague from my alma mater, BJMC Pune, Dr. Umesh Torne, who is going to talk about this adenotonsillar hypertrophy, which way to go for surgical matter. So I will not delve deep into the indications of this, but how do we evaluate acute and recurrent tonsillitis and when we should really refer to them? For that, clinically, we have to, in case of acute tonsillitis, we know that only 15% are bacterial tonsillitis. I welcome my chairperson, Dinesh Thakur Sagar Bhalerao, on the dais. So, so in acute, how it is going to differentiate, and there are definite criteria for this, Centaur criteria and Mackissack criteria. But rather than how many times we do really evaluate the scores and criteria. In our busy OPD, or even if we feign the busy OPD, that what is more important, these are the 4 things. That presence of fever, if it is not there, score is 0. If it is there, score 1. If there is odynophagia, painful dysphagia is there, or pain while swallowing, fever, acute anterior cervical lymphadenitis with size of more than 2 centimeter and tender, and cough. Absence of cough is given +1. Presence of cough is given -1. And Mackissack score, which is slight modification of this, and which is further modified by Fine in 2012, that age group 3 to 14 years is given +1 more, and age less than 3 years is 0, and age more than 45 years is -1. In addition to that, there are throat swab, particularly we are not in the era of KLB like bacilli, diphtheria, but when we were doing our residency, bull neck patient and KLB like bacilli were very common. Umesh will be remembering that. Throat swab cultures, this is particularly for whether bacterial tonsillitis is there, and rapid diagnostic test for streptococcal antigens. These are to be done only if you are clinically suspecting bacterial tonsillitis, and if you want to grade it by Centaur score, it is given in next slide. There is no role for ASO titers. So Centaur and Mackissack score, I have already said most of the things about this. The age group was added into Mackissack, modified by Fine in 2012. And if the score is 0 or 1,
there is no possibility of bacterial tonsillitis or risk is less than 10%. If score is 2, it is 10 to 17. If it is 3, it is up to 35%. And score more than 4 in case of Mackey-Sacks, suggests it is 50 to 53%. But it is not the sacrosanct, it will be there. If you are in a doubt, and if you want to go in a stronger antibiotic steward role, you will definitely do a rapid antigen test to discern whether this is a bacteriological or it is a viral, and you decide about the antibiotic. And even there are so many schools of thoughts are there about treatment of tonsillitis and tonsilloadenoiditis. Should we really treat tonsillitis? And why? We want to prevent suppurative and non-suppurative complications. What are the suppurative complications? The suppurative complications are local extension or hematogenic extension like retropharyngeal abscess, parapharyngeal abscess, retropharyngeal abscess if they are going to be there, and non-suppurative complications like particularly rheumatic fever. Probably in a wake of going to the $5 trillion economy, we are going inching towards a developed country, and that is the reason probably we do not. I have diagnosed acute rheumatic fever 1.5 months back. I posted in IAP group after nearly span of 7 years, a new case of rheumatic fever. So rheumatic fever has definitely gone down, but new entity pandas, post-acute streptococcal infection related neuropsychiatric problems are there, and glomerulonephritis are there, and probably this is the reason we need to treat acute tonsillitis. So these are the Paradise criteria and modified Paradise criteria for tonsillectomy modified in 2019. Dr. Umesh will talk about it, and I won't be wasting my time on that. But just to say that this criteria are 7 episodes in 1 year, 5 episodes in consecutive 2 years means 10 episodes of proven bacterial tonsillitis. If not proven, documented by clinician that antibiotic has been given and it was definitely acute bacterial tonsillitis, or 3 episodes in consecutive 3 years, that means 9 episodes in 3 years. There are some modifying factor. Which are those modifying factor? Particularly if you are suspecting of FAPA, periodic fever after stomatitis, adenitis. If it is there, this patient definitely respond and they become all right with tonsillectomy. And if there is a history of peritonsillar or retropharyngeal abscess, Umesh will delve deep into that. Pathogenesis of adenoid hypertrophy. First, tonsillar hypertrophy doesn't cause any problem. It is a tonsillitis, recurrent tonsillitis. But hypertrophy issue is mostly with the adenoids, and there are so many pathogenetic reasons for adenoidal hypertrophy. The aberrant immune reactions. What they have said that the effector cells are less and naive lymphocytes are more. If this expression is there, then it is more likely to cause adenoidal hypertrophy. There are some factors which genetic, like that CD64 expression on the monocyte. If it is more, these are the patients who are likely to have adenoid hypertrophy. Other local factors, and most important is that this is the chick and egg phenomena. Whether adenoid hypertrophy is causing problem or it is an anatomical problem which is causing adenoid hypertrophy. So it is not yet decided, and there is a gracilization theory and the gravitational hypothesis. What is gracilization theory? आपण लहानपणी ऊस तोडून खात होतो. So we are eating hard food, and this hard food was making the muscles of mastication stronger, and probably the airway, hard palate, soft palate, and nasopharyngeal airway was having a more spacious, and which was not giving a ogival palate and reduction in the, this is the gracilization theory. So more and more soft food, modern food is causing problem with the adenoidal hypertrophy. Gravitational hypothesis, it has been found that whether it is again an effect or reason, we don't know, but it has been said that the position definitely precipitates, or it is an effect of the adenoidal hypertrophy. I have told about this increase in naive lymphocytes and decrease in effector lymphocytes and CD4 expression more on the, why we should, on the monocytes, why we should really worry about adenotonsillar hypertrophy, why it is significant. obstructive sleep apnea syndrome, and probably this is the single most important reason why we should be discussing this tonsillar adenoid hypertrophy. And it has got far-reaching consequences, including neuroendocrine and the developmental issues and so much and so many things, poor scholastic performance, daytime, obesity is a cause and effect of also obstructive sleep apnea, and so many things are there. It precipitates chronic rhinosinusitis, otitis media with middle ear effusion, which is lasting more than 3 months. And this OME, if it is in a critical period, that is of 2 to 4 years, and that will definitely cause a language problem, poor scholastic problem. So this middle ear effusion with otitis has to be treated, and most of the time it is adenoid hypertrophy and the tubal tonsils around eustachian tube which are getting hypertrophy along with that. Even dental malformation, malocclusions are the reasons, speech disturbances, intellectual development and all these things. What is symptomatology? We all know, I will not go into details of that. But what is important is obstructive sleep apnea syndrome. We cannot go for polysomnography every now and then. No good sleep lab is there even in a tier 3 city of Nashik for pediatric age group. But you can be have a surrogate sleep monitoring. And what is that? Have a good pulse ox of Massimo. Ask mother to take videos and show you the videos. Whether how is the snoring, a simple snoring in layabadda, talabadda is not a problem. But if it is snorting like this, or it is apnea, and if this apnea is associated with desaturation of less than 80, and if there are more than 10 episodes, you can refer this patient directly to your ENT colleague without even go for the polysomnography. So obstructive sleep apnea is very important, and it can cause far-reaching consequences of cor pulmonale, pulmonary edema, growth failure, neurocognitive disturbances, and so forth. Evaluation of adenotonsillar hypertrophy, there are 3 things. Is a clinical evaluation, clinical scoring, lateral X-ray, and nasopharyngeal endoscopy. Gold standard is nasopharyngeal endoscopy, and in some cases, if awake nasopharyngeal endoscopy is not there, then you can, under sedation, nasopharyngeal endoscopy has to be done. The clinical scoring, there are scores has been given to difficulty in breathing during sleep, 0, 1, 2, and 3, occasionally, frequently, or always. Same thing for the snoring. And apnea, if it is there, it is 1, and not there, it is 0. If there is a mild obstruction, if the score is below 1, moderate if the score is 3, more than 4, it definitely warrants the ENT opinion. Lateral X-ray, they have found that they have compared clinical scoring, lateral X-ray scoring, and the nasopharyngeal endoscopy and under sedation nasopharyngeal endoscopy. The clinical scoring correlated 80 to 90% with the nasopharyngeal endoscopy, but the lateral X-ray correlated only in 30% cases. So I think in spite of good X-rays, this is just a completion at the most. There are so many things there about the how Cohen and Konak method, Fujioka method, or Johansen method. Cohen and Konak method has been used, and it is the space and the palatal thickness. If the score is less than 0.5, it indicates severe hypertrophy. Scoring under is that nasopharyngeal endoscopy scoring less than 50% obstruction grade 1, 50 to 75% grade 2, and more than 75 obstruction of choanal obstruction is grade 3. Approach conservative management, watchful waiting. Watchful waiting will be done if there are no those 6 indication of malocclusion, otitis media with effusion more than 3 months, no signs of obstructive sleep apnea, and other things. Along with that, you will be doing the nasopharyngeal endoscopy, medical management, intranasal steroid, leukotriene 4 inhibitors, surgery, CPAP, and experimental modalities. There is a review by otolaryngology journal which says that even nasal steroid does not hold water. It delayed surgery for 35 days, but I took it with pinch of salt because there is a surgical bias to otolaryngology. The Cochrane review said that Cochrane review definitely said that the medical treatment did help intranasal corticosteroid for nasal airway obstruction in children. It has improved obstruction symptoms, moderate to severe adenoid hypertrophy. But important things are where it has reduced, where the patients had allergic rhinitis with adenoid hypertrophy, and this mometasone or any intranasal steroids, particularly furoate, not the propionate, that decreases nasal obstruction, snoring, nasal symptoms. It improved puritan audiometry also, decreased otitis media with effusion, adenoid size, and quality of life has improved. Efficacy of montelukast along with this mometasone, they have said that alone leukotriene inhibitors are having minimal role. What they have said that the combination group along with LT4 inhibitors and mometasone had better results. It was definitely superior than placebo in cases of montelukast to decrease snoring, sleep discomfort, adenoid and nasopharyngeal ratio improved and mouth breathing decreased. But alone leukotriene inhibitor, I particularly in my personal view and the studies does not allow it. So if you are giving combination and alone nasal steroids, the results are same. So why to give leukotriene inhibitor? Give only the nasal. Indication for adenoidectomy will be again covered by Dr. Umesh Torne. But what is more important in this indication is that look for obstructive sleep apnea syndrome, middle ear effusion in age group of 1.5 years to 3 years, very critical period, and inferior terminal hypertrophy and neuroendocrine symptoms. These are the important indications. I will not go, and one more just for the food for thought for Umesh also, a lingual tonsillectomy for disturbed sleep breathing. So lingual tonsillectomy, they have said that drug-induced sleep endoscopy have suggested that there is a dynamic airway collapse and the lingual tonsils are also, and coblation therapy of lingual tonsillectomy has improved because it has been found that up to 60% patients after even adenoidectomy, the obstructive sleep apnea is not resolved. It required CPAP. So probably this lingual tonsillectomy has to be done. This is the last slide. A novel way of giving omalizumab for treatment of adenoid hypertrophy. The size was fairly large. This article in it has suggested that it decreased the obstructive sleep apnea syndrome more than adenoidectomy. But larger studies is required for this. This is still at the experimental level, cannot be recommended as a standard treatment modality. In nutshell, suspect adenoid hypertrophy causing obstructive sleep apnea, middle ear effusion more than 3 months, dental malocclusion, neurocognitive problems and neuroendocrine problems. Thank you for patient listening, and thank you Nashik Organizing Committee for giving me an opportunity.
Thank you, sir. It is always a golden opportunity to witness your talk. I request Dr. Sagar Bhalerao, sir, to felicitate Dr. Ramakant Patil, sir. After this, I request sir to proceed towards the felicitation stage. There is one more vehicle, four-wheeler, which is obstructing the path of others, MH15 4X 7422. After listening to the medical management, we are eager to know the surgical aspects of adenotonsillar hypertrophy. I am honored to invite and introduce the renowned ENT surgeon of Nasik, Dr. Umesh Torne, sir. Sir has his own state of an art for ENT and head and neck surgery. Sir has got so many achievements, like he has done the highest number of rigid bronchoscopies in private ENT and head neck surgery setup. He has developed Center for Cochlear Implant Program and Salivary Gland Endoscopy. He has been invited as a speaker, moderator, panelist for crosstalks operating faculty in state, national and international academic forums. Over to you, sir. I request chairperson to be seated for this session also.
Hello. Respected chairpersons, dear friends, good evening to all. Thank you for a wonderful intro. Thank you, Nashicon, Team Nashicon, for inviting me to present myself in front of this auspicious gathering. Ramakant, you had made my life easy by giving, covering most of the medical aspect of the tonsillar adenoid hypertrophy. So I don't want to cover it again about the Walder's ring. It's acting as a first defense system against pathogens to engulf in the form of innate immunity, and also helpful for the adaptive responses by delivering the T and beta lymphocytic enhancement. In this multimillionaire body, nothing is extra. Nothing is really extra. So why to go for this tonsillectomy and adenoidectomy? No, not at all. So there is a big no for this surgery. But there are certain things, there are certain situations which advise us, which ask us to subject these cases for this surgery. And there are almost about thousands and thousands of indications for this surgery. There are local indication, the general indication, and the focal indications. However, beyond doubt, there are certain indications they need surgery and only surgery. So, as far as gamut of the surgical treatment is concerned, it is not only tonsillectomy. It may not be only tonsillectomy and adenoidectomy, but most of the time the adenoid resection is the commonest procedure amongst the all. Many a time we have to do a concomitant procedures like putting a ventilating tube or grommet, or we have to do something about the inferior turbinate, middle turbinate, and so on. So first indication according to me is snoring and obstructive sleep apnea. In 2018, I have myself has conducted a trial of a level 2 sleep study in almost about 34 patients. All patients were subjected, they were cooperative group between the 11 and 14 years, and on very next day they were supposed to subject for this surgery, and during the preoperative night I have done this particular test, and I have, digged out certain indices, and, surprisingly, the oxygen saturation level of all these significant snorers has got almost about 80 and below. And that was associated with a minimum pulse rate of almost about 50 and 60s. So why to subject this group for the vital organ desaturation and hampering their growth as far as vital organs are concerned in a developing age? So this is a very strong indication for this surgery. Secretory otitis media, according to me, is again secondary indication, because most of the time this is neglected issue. If I see 10 children of about suffering with upper airway infection, out of which almost about 4 people has got an associated secretory otitis media without any symptoms. A secretory otitis media is there is a proteinaceous material which accumulates in the middle ear cleft with a very low virulent organisms which tend to cause lot of damage inside. So anything, the secretory otitis media with not responding to medical arm of treatment for 4 to 6 weeks, they are strong indication for this surgery. Otherwise, they are exhibiting its different sequelae like recurrent acute exacerbation, chronic superior otitis media, adhesive otitis media with plaster drum, and there may be a necrosis or fixity of the ossicular chain. Sometimes you may get absorption also. You can see here, okay. So this is almost completely plaster drum, just like a perforation, total perforation. This is a round window, this is eustachian tubal cushion, and absolutely loss of ossicular chain here. This is a very routine situation what we are seeing. This is a concomitant along with the tonsillectomy and adenoidectomy. This is a concomitant procedure where we are taking an incision on anterior-inferior quadrant of the tympanic membrane, aspirating all the proteinaceous material with just like a glue, care has to be taken not to damage the tympanic membrane and middle ear cleft, causing hemorrhage for no reason. And then we are putting a titanium grommet or ventilating tube or tympanostomy tube here. Chronic suppurative otitis media is again a very, very unhygienic condition, invariably associated with this kind of perforation. You may get a very large perforation and it's a very edematous tissue, a very recalcitrant condition, not responding to routine line of treatment, and most of the time you may get a cholesteatoma. For these cases need a surgical intervention, but this has to be preceded with tonsillectomy and adenodectomy. Many a time, enlarged adenodectomy, here you can see a surgical video where diagnostic nasal endoscopy, this is a the right nose nasal passage, this is inferior terminate, this is septum, and you can see a large adenoid which is compromising almost about 90% of the nasopharyngeal space. This is at the left side of the same patient where I am introducing my scope right up to the nasopharynx, and you can see a complete obstruction or almost about 90% of the obstruction in supine position when there is a gravitational fall of the uvula that causes complete obstruction to the nasopharyngeal airway. Here you can see almost about grade 3 and grade 4 tonsillar hypertrophy. So these are the very strong indications for this surgery. Most of the time these cases gives rise to this kind of picture where you get a Danny Morgan's line, which is a curvilinear line which is situated on the inferior aspect of the middle canthus. There is a little shiny of the paranasal skin. You may get malar maxillary hypoplasia. You may get a receded chin, hypertrophied upper and lower lips with crowding and malaligned teeth, and loss of nasolabial fold. All this gives rise to a typical, idiotic faces that is nothing but the adenoid faces. So these are again indication because this is a lifetime problem. So these are the indication, very strong indication for this surgery. Ala to pleura. This is a unified airway. So you cannot distinguish between upper airway and lower airway. Anything that affects upper airway has got some effect on the lower airway. So we have to consider these also things. So recurrent chronic rhinosinusitis or follicular or ulcer membranous tonsillitis, that is necrotizing tonsillitis, which gives rise to recurrent lower respiratory tract infection. Again, this may be forming a indication for this surgery of tonsil and adenoid resection. Here we have to consider about the concept of biofilm. Biofilm is nothing but the aggregates of the colonies of microorganisms. They are encased with a capsule which is formed by proteoglycine matrix, which invariably grows in mucosa associated lymphoid tissue and on surfaces of the nose and paranasal sinuses. Here you can see there is a, the organism there starts accumulating with this quorum sensing mechanism, and then they form a capsule here, which is very, very difficult to be penetrated by the antimicrobials. So these are again, this biofilm had to be removed. What are the contraindication? Acute upper airway infection, acute viral epidemic, especially measles, mumps, poliomyelitis, and so on. Bleeding disorder can form a little relative contraindication because the blood components can, invite you for the surgery. And again, cleft palate is again strong contraindication for this surgery in order to prevent very unpleasant and morbid velopharyngeal insufficiency. At the same time, we have to think of certain comorbidities which existing with the tonsillar and adenoid hypertrophy. The foremost is allergic rhinitis. They may need concomitant posterior nasal neurectomy or allergic skin prick test or either sublingual or subcutaneous immunotherapy. A chronic rhinosinusitis may need antal puncture at the same time and at a long-term installation of the normal saline or ringer lactate nasal installation. Deviated nasal septum has to be addressed at around 17 years of age. Inferior turbinate hypertrophy may need volume reduction turbinoplasty, which is a very, very routine procedure which we are, formulating along with the tonsil or adenoid surgery. And conchobulosa. Conchobulosa is pneumatized middle turbinate which causes obstruction to the outflow tract of the paranasal sinuses, especially maxillary sinus. So this has to be dealt with excision of its lateral lamina. So in all this situation, nasopharyngeal scanogram is of great help. There are different surgical techniques which can incorporated as far as adenoid dissections are concerned, like adenoid curate, microdebrider and cobbletter, and tonsillectomy is by dissection method and by cobbletter method. So this is adenoid curate, 3rd MBBS ENT posting. Patient has to be lying down in with cervical extension and flexion at atlanto-occipital joint, which is known as Rose position, and then Boyle-Davis mouth gag has been engaged, which is supported with Draffin's bipod, and then we have to put curate just like a dragger. We have to go capillard of the adenoid and then just scoop it and just remove this. But it is associated with a remnant of the adenoid, which gives rise to a recurrence of as much as about 15%. This is a cobbletter adenoidectomy. Diagnostic nasal endoscopy shows a large adenoid. A cobbletter generator is a radiofrequency generator which is introduced to the oropharyngeal opening with the endoscopic guidance, and we have to pick each and every bits of the adenoid tissue right from one place to the another. All the care has to be taken not to damage to the parapharyngeal space, and all the soft tissue bits has been removed in this particular procedure. The most advantage of this procedure is there is hardly any bleeding, and post-operative pain is also about 1/3. So this is microdebrider, again one armamentarian in removal of this particular procedure. Here, endoscopic debridement of the adenoid with the help of microdebrider. Microdebrider is a powered oscillating blade which is having a speed of almost about 2000 RPM, and then we are removing each and every bit of the adenoid tissue right from one fossa rosenbular to the other side. Care has to be taken not to damage the paramycium which is covering the rectus and longitimous capitis. This is adenoid cobbletter adenoidectomy, which is same as that of the dissection method, but in dissection method we are using a cold instrument. Here we are using cobbletter. Cobbletter is gradually taking out each and every soft tissue which is not needed, and pharyngobasilar fascia is the base of the adenoid that need to be protected, and the body, the superior pole and the inferior pole has been removed. Again, this is a painless procedure, or painless, not very painless, but it is causing literally 1/3 of the pain. And the complication profile is also less in these particular cases. Post-operative care, everybody knows, nurse in lateral position, kneel by mouth for 4 to 6 hours, watch for bleeding, monitor vitals, give everything. We are encouraging to eat everything after 4 to 6 hours. Tonsil and adenoid resection has got its own complication of hemorrhage, primary, reaction and secondary hemorrhages, injury to the local organs like lip, tips, uvula, infection at surgical bed, velopharyngeal insufficiency, remnants and aspiration. I think we have to give you more justice to this particular slide. You can see nasopharyngeal scanogram, a very, a smart sort of scan, where in the sagittal section you can see a very large adenoid which is causing near total area of the nasopharynx, and this is the neuropharyngeal airway which is grossly compromised. Here you can see oropharyngeal space which is compromised with almost kissing tonsil. You can see the few cuts of temporal bone where the mastoid pneumatic system is very clearly seen. That is clearly suggestive that in this patient there is no involvement of the associated, otomastoiditis in this particular case. In this particular situation, a large adenoid with, deviated nasal septum towards the right, and then again there is no otomastoiditis in this particular situation. Here you can see adenoid with pan-sinus disease. Both the maxillary sinus, both the ethmoid sinus, sphenoid sinus on either side is grossly, with mucoperiosteal thickening, and you can see that these mastoid air cells are again, they are showing a haziness or sclerosis that suggests of otomastoiditis. Here you can see a large conchobulosa which is compromising the maxillary sinus outflow tract. So, to summarize, tonsil adenoid dissection is a common surgical procedure being indicated in specific situations which we already dealt with. A properly performed procedure gives a good results and least complication. Adenotonsillar hypertrophy with associated comorbidities, which is a very common finding, which definitely alters surgical outcome and may need little extra counseling, and hence concomitant surgical and management is indicated in these particular cases. Nasopharyngeal scanogram is of great help for contributing clinical diagnostic acumen and for documentation purpose. Thank you very much.
Thank you. Thank you, Torne sir, for such an informative session. I request speaker and chairpersons of this session to proceed towards felicitation stage. Our next session is crucial one, focusing on essential practices of aseptic techniques and antibiotic policy in NICU. We are privileged to have esteemed panel of experts with us today. Today each bringing wealth of knowledge and experience in this field. Dr. Sunil Gawane, Professor Head Division Neonatology, MGM Hospital, Sambhaji Nagar. Dr. Jalil Mujawar, neonatologist practicing in Pune. Dr. Sachin Shah, Chief Neonatologist, Anand Children's Hospital, Surat. Dr. Om Prakash Jamadar, neonatologist practicing in Mumbai. Moderating this session is Dr. Rishikesh Thakre, a renowned neonatologist from Aurangabad. I will now hand over to Dr. Rishikesh Thakre to begin our panel discussion. And please join me in welcoming our distinguished panelists. Over to you, sir.
Thank you, and a very good afternoon to you all. It's indeed a pleasure and privilege to be again back with you. And the objective of our panel discussion would be to lay down policies on usage of antibiotics and asepsis. The dictum in NICU is all newborns are septic unless proved otherwise. And therefore, it is but natural that we need to discuss and debate on this vital issue. For what we do or what we don't do would have huge implications, both short term and long term, and we have expertise with us to share their experience. And let's set the ball rolling. So the story begins, in an ideal world you would want a definite antibiotic. That means we know the organism which has been cultured, we know the sensitivity pattern based on which you would titrate the antibiotic. But not most of us would have access to that in the first few hours. So my question is, should we use prophylactic antibiotics for the newborn? Dr. Sachin?
So any admission to the NICU, and most of it occurs that by default we start with antibiotics. Either we admit a patient for simple respiratory distress like a TTN patient, we admit a patient for meconium aspiration, we admit a patient just because of feeding issues, or we admit a patient for jaundice. So there are a lot of things we admit the patient in the NICU, and most of the cases are such that the incidence of sepsis is less or negligible. So there is no role of prophylactic antibiotic in all these conditions where sepsis is a least possibility. There are some conditions where there are risk factors related to the baby where the chances of infection are more, and they are very specific things, like in a preterm child is one of the most important risk factors. A mother having a history suggestive of chorioamnionitis, like a mother having high grade fever, she's having leukocytosis, she's having foul smelling discharge. So these are the risk factors where the incidence of infection in the baby is more. In such conditions, there is a role of prophylactic antibiotics. Otherwise, in most of the conditions, there is no role of prophylactic antibiotics.
So prophylactic antibiotics need to be given when there is no infection. But this is meant to prevent infection. As rightly said, none of the NICU babies would qualify. There are very few exceptions. Baby born to mother with HIV, UTI documented in the newborn, infective endocarditis, again uncommon, and maybe candidemia, where you would be thinking in terms of considering, but as rightly said, there is no role otherwise to give. But in presence of risk factors, we have an option of treating the baby by means of giving empiric antibiotics. So here we are going to start treatment, and my question here is, Dr. Om Prakash, which of these conditions in the NICU would warrant an antibiotic?
So many a times we see babies with common problems like polycythemias, thrombocytopenias, and some babies are very precious IVF pregnancies. So these are not the real indications for starting antibiotics. There are many cesarean sections which are done for the maternal indication, and babies coming to NICU for the sake of maybe some component of transient tachypnea, or maybe some component of just feeding and growing baby LBW care. So these are not the babies who needs antibiotic, but babies who are having maternal risk factors which are more than 3 as enlisted by Dr. Sachin, and associated with some symptoms, maybe tachycardia is there, tachypnea is there, lethargy is there. These are the babies who will think of sepsis, and these are the babies where we should send blood tests, particularly blood culture, before we start antibiotics. So babies who are having risk factors with symptoms, who are having flourished signs of sepsis in terms of shock, these are the babies where we should think of empiric antibiotics.
So again, what Dr. Om Prakash is telling us, if the baby is sick, please go ahead, start with antibiotics unless infection is ruled out. You don't want to miss a baby or lose a baby because of stopping or not starting an antibiotic. But most of the other conditions where the baby is there for any other reason, without suspicion of infection, please don't start antibiotics. My next question is, what would be our choice of antibiotics if we have to start empiric antibiotics for sepsis, shock, multi-organ dysfunction syndrome? Does it matter to quantify the gradient? Because we are talking about empiric antibiotics.
So the purpose of empiric antibiotic is to cover the maximum organisms that you are having.
In other words, tell me when we would use first line, second line, or third line antibiotic without naming the antibiotic.
Yes.
In one
So
of
in
these
case of sepsis, it is a commonest situation that we face where we should think of first line antibiotics. We should cover almost 60-70% of your bacteria. In case of shock, where the situation is more critical, you should think of second line where you are covering 80 to 90% of your organisms, and same with the multi-organ dysfunction, which is again a further deterioration from the shock.
In other words, more the severity of gradient of the baby, your first line shifts over to a second line antibiotic, but empirically, please do not start third line antibiotics, and we would soon learn what is the hazard or harm in starting these babies with third line antibiotic. Okay, now the commonest scenario that you and me are going to face is the baby is well, but there are risk factors. And we do know maternal PROM, preterm premature rupture of membrane, prolonged rupture of membrane, maternal fever, history of UTI, chorioamnionitis, blah, 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 blah. In such situations, the baby is otherwise well, so Dr. Sunil, should I look at CRP in making a decision to start or not to start antibiotics?
To start or not to start antibiotics. Now this is again a very sort of complicated issue, but just based on the CRP, if just to be specific, just based on the CRP, we should not think of starting or antibiotics. All the septic screen what we do, most of the time is very poor sensitivity test. Specificity means if I do that test, with how much confidence I can see the child is having sepsis or no, that is very low with septic screen. The part of that is CRP. CRP is actually, if you see CRP is falsely positive in first 2-3 days, up to 72 hours is physiologically raised, and there are reasons where it is falsely, like MS is there, baby stress, birth asphyxia is there, your meconium is there, or if it is any other acidotic conditions are there, even MODS without sepsis, even non-septic NEC also there can be CRP inflammation. So CRP based on the asymptomatic baby with risk factors, but to start antibiotic or not based purely on the CRP, I will not say. CRP can be helpful in other way round. It can be like, suppose if you have septic screen or part of that is CRP, if CRP is negative or your septic screen is negative, you have very good confidence, like you can have very good specificity to say that there is no sepsis. So CRP can be used to rule out the sepsis rather than starting the antibiotics. So that can be helpful.
Please do not rely on CRP to start antibiotics. An editorial said CRP stands for C unreliable protein. And Sunil rightly said, number of non-infectious conditions that would give rise to a high CRP, so don't get misled by looking at CRP. The new kid on the block is procalcitonin. So Dr. Jalil, would you look at procalcitonin in an asymptomatic baby with risk factors to decide for or against antibiotics?
Yes, it is as like a better CRP. The way CRP came up with a hype when we were students, and that time ESR, better ESR was CRP. So now better CRP is procalcitonin, nothing much. But it has definitely more positive predictive value, it has more negative predictive value, specificity and sensitivity is better than CRP. But again, the whole purpose of this discussion remains the same. If the baby is clinically stable and you are thinking about asymptomatic baby and there are risk factors, so this should always be discussed with the clinical scenario. Just to complete, I'll just give you one liner for 3 setups. 34-weeker premature rupture of membrane of 19 hours. Are you going to start antibiotics or not? How many of you will start the antibiotics? I'll repeat, 34-weeker, 18-19 hours of PPROM, whether, and baby is asymptomatic, 2.1 kg. Distress, no distress, feeding well. Are you going to start antibiotic or not? So this is how you have to discuss. This is the best way to discuss things. So if in this case you did blood culture, one may start antibiotic thinking, I am not, you don't know when the baby is deteriorated. So I'll start my first liner. I'll take culture before I start antibiotic, and then I'll do CRP at 12 hours. Some people will do at 12, some will do at 24 hours. And at 72 hours, at 48 hours you got the culture negative, and at 72 hours CRP was, previously CRP also was negative, this CRP is also negative. So in this scenario, if you go by clinical acumen with asymptomatic or symptomatic, and then you take CRP or procalcitonin into account, then as Dr. Sunil said, that it is better if the CRP is coming down, it is better to stop antibiotic depending on CRP rather than starting antibiotic on CRP.
So in other words, both these molecules, CRP and procalcitonin, are not good for making a diagnosis of sepsis. They are very good in ruling out sepsis. So two values, 12 to 24 hours apart, if negative, conveniently, reliably rules out that it is not a bacterial infection. So the utility is in ruling out sepsis rather than ruling in sepsis. And this helps us in stopping antibiotics if you have already started for some reason or the other. And again, it will also shorten the duration of antibiotics. What Jalil was telling us, treat the baby, not the reports. Interpret the reports looking at the baby. That's the strong message, and therefore keep that in mind. The gold standard is for diagnosis of bacterial sepsis, a blood culture. You just need 1 ml of blood in the automated system, and the time to turn positive if there is an infection is approximately 36 to 48 hours. Okay, and it can detect less than 10 colony forming units per ml. And what it also means is this is 99% likely to be positive if you have less than 10 colony forming units per ml in that blood. So that is the utility of looking at blood culture. But despite having such a good tool, most of us don't do a blood culture, or when we do a blood culture, the cultures come negative. So my question here is, Dr. Sachin, why do we get the negative cultures to an extent that we lose the value of doing a blood culture?
See, blood culture is the most important investigation to confirm sepsis, but it is important only if it is taken properly. The technique of taking the blood culture is most important. Proper disinfection and preparation of the skin, taking appropriate volume of blood, minimum 1 ml is needed. For bigger babies, we can take about 2 to 3 ml also because it has a better catch-up of the organisms. Immediately putting that blood properly into the culture bottle, transported to the microbiology lab immediately, and then incubated and done in a proper way. So it has a proper technique. If it is done properly, then the chances of coming negative is quite less. Second thing, it is also dependent upon the previous antibiotic use. The baby was on previous broad spectrum antibiotic, then there is a possibility that you will get a culture negative in spite of the baby being or having sepsis. So I think this is the most important thing.
And does it matter whether it's an adult blood culture or a pediatric blood culture?
No, the blood culture bottle for the neonates and for the adults are different. So it has to be, the blood has to be taken into the proper volume of the neonatal blood culture bottle. That is important.
So if we look at these issues critically, and you start collecting blood culture in all babies with suspected sepsis, you would have the highest dividends, and you would have that confidence to say, yes, at 36, 48 hours down the line, if the culture is negative, you say, I would stop antibiotics. The point here to be noted is, do a study in your own unit of doing blood cultures routinely with all these precautions, based on which you would be able to then make a change in your antibiotic policy. What about a culture where an organism is identified but the baby is otherwise well? In other words, how do we look at contaminants and how do we identify them?
So false positive culture is very common problem. So whenever I see, the process of collection of blood culture, it has to be a 2% technique. And the way we are collecting is with a proper preparation, where we are putting first cleaning the area with betadine from center to periphery, followed by spirit. And then, many times we, as a resident, I have also done this mistake, as well as I see others. After doing cleaning and everything, we put our thumb in that area with gloves on the place and then try to palpate the vessel again. So we have cleaned the area and again we are contaminating the area. And that is the commonest reason for getting contamination. Second, as I said earlier, it is a 2% technique where one person is helping you to maybe taking the needle, taking the syringe and needle, which is in a sterile way, or the second person is just opening the cap part of the bottle, because they are all packed bottles. So you open the cap properly and then directly needle is inserted into the bottle, and not that you collect the sample first and then put some other bulbs for CBC, CRP and then put in the culture bottle. It should be a properly collected sample and properly put into in a sterile way into the bactec bottle that we have got. The second part is, after collecting the sample, don't store in the fridge. And even I will say, before you collect sample, these bottles should never be kept in the fridge. Otherwise, they won't be turning, in a good way of getting the results. And then you deliver the sample at room temperature to the lab within 2 to 4 hours of collection, so that the golden time of getting the culture report in 36 to 72 hours is very likely to be there. So contamination is the commonest cause, and we should take precautions to prevent contamination. And many times, what are the contaminants? These are all your staph or your staph epidermidis. These are the commonest contaminants. Second part, when you are collecting sample, many times there are central line in place, but it is a better idea to collect from a peripheral clean place rather than having a central line, because again the chances of contaminations will be higher in that situation.
So no touch technique for sample collections. So how do we optimize blood culture? Sunil.
Okay, so optimizing blood culture, as Om sir said, collection, indication, have a practice or culture of sending culture first, send it before starting antibiotics, aseptic techniques, don't touch it once you have cleaned that area, adequate sample, 2 persons, gloves, clean the bottle properly, upright bottles, never refrigeration or freezing the bottle, earliest transport, and then interpretation as per the protocol I just said. Now, in optimizing the blood culture, our interpretation of the sensitivity pattern, upgrade, downgrade, and isolate, never to be ignored. Now, the first question is interpretation of sensitivity pattern. आपण सगळ्यांनी blood culture, we have seen the blood culture sensitivity report. बऱ्याच ठिकाणी it's like either they are written sensitive or resistant. There can be sensitive, there can be intermediate sensitivity, there can be resistance, there can be a values after that. If you see the good culture report, there will be values like sensitivity. This is something you must have heard about MIC. That is called as minimal inhibitory concentration. What is this MIC? This is have practical implications of we are seeing, what discussing is. MIC is a minimum inhibitory concentration of that particular antibiotic in the blood, which is going to prevent the growth or it's effective against that bacteria. That doesn't mean that is actually that will be true for every pathogens or the same pathogen in a different scenario. In that particular scenario, that specific concentration should be achieved. Now, if you read the culture report further, there are two values in this particular blood concentration of that antibiotic that is sensitive. Now, suppose I have E. coli, and this is sensitive, like piperacillin tazobactam is saying that is sensitive, and the blood concentration MIC this written is like 2 to 14. Okay, so in that range of blood concentration of that antibiotic, it's going to be sensitive. Suppose 2 to 14, above 14, it's going to be resistant. As simple as that. That's called in mycological, it is called a breakpoint concentration. So after that, we call that as a resistant. Like if that piperacillin needs dose of more than 14, still it's not working. That means it's a resistant for that particular organism. Now, here, suppose you have piperacillin and ampicillin also. Suppose both are have concentration of like sensitivity pattern between like 2 to 14. Both are having 2 to 14. Ampicillin is 2, piperacillin is 8. Now, ampicillin is having like, if you dilute, dilution techniques, they say like how much dilution technique, in spite of that it is helpful. Ampicillin is much more effective or sensitive compared to piperacillin now here, because ampicillin is having MIC of 2 and piperacillin is having MIC of 8. Now, based on that, if you are already on ampicillin, it's fine. But if you are on piptas, if you can consider, I'm not saying like again clinical scenarios are important. As we all are discussing about clinical features, management of sepsis, labs are there just to guide you. So even blood cultures also. If at all this it might happen, you have baby, there is something intermediate or resistant also. Medical legally I'm not saying, but intermediate sensitivity. You have started on the antibiotic or you don't know the sensitivity pattern which is not checked. BB is clinically improving, you might continue. But based on the sensitivity pattern, the one which is having least MIC, you can go for that antibiotics.
Okay, and last question, which isolates if present should not be ignored?
You have a symptomatic child with you, the child is looking septic or whatever the signs of early onset sepsis are there, your lab features are also there, and you have pathogens which is in a significant amount. Growth is in significant colony forming units. It grows very fast. Suppose you have the reports in 36, 48 hours, and it has grown non-commensal organisms, which is always pathogenic. Most of the time they are pathogenic. And it's taken from the peripheral line again. It's not taken from the central lines. In that these are conditions where you should never neglect that growth.
So look at the MIC, choose an antibiotic with least MIC, upgrade or downgrade the antibiotics to the one with the narrowest spectrum. Two organisms, Candida, never ever ignore saying it is a contaminant, it is always pathological. We have burnt our fingers saying that they are contaminant, and the second organism is MRSA, and the rest of the features were rightly shared. The thing is that the culture is sterile but the baby is sick. So Dr. Jalil, in such situations where the culture is sterile, should I rely on CRP procalcitonin or should I rely on sepsis screening?
We should not rely on anything else apart from the clinical condition of the baby. All other things can be supportive, but the conclusive evidence or conclusive thing is baby, how your baby is interacting, what is the baby's heart rate, what is the baby's RR, what is the baby's temperature, what are the fluctuations. I'm not just talking about one temperature, but if you see throughout the day whether the baby is remaining hypothermic or hyperthermic, what are the BSL values, how is your nurse saying, how is the baby doing. You come, you go in 5 minutes, 8 hours the staff is standing beside the baby, and the baby is, she says, yes, kal se baby acha lag raha hai. That is one more point. So clinical status cannot be replaced by any investigation for that matter.
So if you are making use of CRP or procalcitonin or sepsis screen, two screens 24 hours apart rule out bacterial sepsis.
So in that
but look at the baby is what the strong message is.
One more additional point I would like to put across here is, first CRP if you are doing in 24 hours, it is going to give you a reflection of the mother. Even the inflammatory process of the cesarean section is going to give you a result. As sir said, two CRPs at least 24 hours apart, then you decide whether it is trend is increasing trend or decreasing trend, and then see the clinical thing, and then you decide what to do about
Dr. Sachin, how do I choose a first line, second line, third line empiric antibiotic in my NICU to make my policy?
Yeah, see, for making antibiotic policy of the unit, first you need to have a detailed blood culture scenario of your unit. You should be auditing your data of the last 3 years, and every 6 monthly you should be seeing what are the common organisms, what you see in early onset sepsis and late onset sepsis. So once you are aware of the organisms which are there in your unit, what you are getting, and then you have to do a proper audit of the antibiotic sensitivity policy. So the first line antibiotic what we choose should be covering at least 60 to 70% of the common organisms what we are getting into our cultures as per our data. What we read in the Western world is not true to our unit, and what we see in the government setup is not true in a private setup. So it is rather than just making it fixed that everyone is using this, we will use this. This is not the correct policy. You should have your data. This is the first thing. You should know what organisms you are catering to and what clinical response you got in those antibiotics, and then you choose a small spectrum antibiotic which is taking care of mostly 60-70% of the. So that would be the first line antibiotic. Second line would be an antibiotic which covers most of the organisms, even the sicker babies which are going into shock or where the organisms have known to be hospital acquired infection or have to be some organ which has come from outside your unit also. So then the second line antibiotic should be an addition to that.
So second line 80 to 90% coverage is expected again based on your unit's antibiogram, and the third line should have almost 90% and above coverage. But what about third generation, fourth generation cephalosporins and carbapenems to be used empirically?
So there is a lot of evidence in terms of how we should be rational about choosing the antibiotic, first line, second line, third line. When it comes to cephalosporins, it has been very clearly observed, the more the use of cephalosporin, third generation cephalosporin is there is higher chances of resistance, particularly ESBL is very known fact. So we need to use in certain situations, particularly cefotaxime, we use third generation cephalosporins. In certain situations like meningitis, where we know there is a good penetration of CNS in comparison to the other antibiotic that we use, that is one. Now carbapenem, I have seen so many babies coming from peripheries using carbapenems as the first or second line, first line in fact many times, first line antibiotics. So there is the Danish study has opened eyes of many of us, where there is almost like a 70-80% resistance to cephalosporins and 60 to 70% resistance to carbapenem. And mind you that this is like studies done good many years time. So by this time I must say that carbapenem resistance has also gone significantly. So we need to be very careful when we are thinking of starting with cephalosporins and carbapenems.
So beware, if you empirically want to start a broad spectrum antibiotics, it leads to huge hazards, both short-term and long-term, increased risk for late onset sepsis, increased mortality, increased incidence of invasive fungal infections. So WHO came with this smart way by which you would become aware about usage of antibiotics. The A of aware stands for access, which I have marked for gram-positive, gram-negative antibiotic coverage. The yellow one is the W, that is watch. So those are the second line of antibiotics, and the third is the reserve, which should rarely be ever used unless you have a proof. And the reason is that with that background of hierarchy of antibiotics, question is how should I choose an inborn with an early onset sepsis, outborn, NEC and all such conditions. Sunil.
Hello. Okay. So just continue with the
Just one line answers, one antibiotic, so that take home message is very clear.
Okay. Early onset sepsis, inborn, cover gram negative. So you can start baseline amikacin.
Monotherapy is okay?
Yes.
Good. So no MP with aminoglycoside, no cephalosporin with aminoglycoside. So only aminoglycoside is good enough. Good. Outborn?
So outborn you can start with AMPI, amikacin. So you can cover the gram positive
gram
here.
Positive with gram negative based on?
Both depends.
Yeah, okay.
NEC you have to cover like in broad spectrum with anaerobics. You have to go for anaerobic.
So this is the only condition in newborns where you would, if there is a perforation and anaerobic cover is required. Otherwise, there is no role of metronidazole in NICU. Very good. Okay.
Now, henceforth, higher antibiotics you can use as per unit protocol. MODS, you have to go higher antibiotics. Now again, you have a very strong clinical suspicions here. Again, it's easy, like we are discussing about starting empiric antibiotics, but remember one thing, If birth asphyxia, severe dysfunction, multi-organ dysfunctions, again see if there is a really sepsis or no. Just don't go for blanketly like the babies having ARF, babies having PPHN, babies ventilated, and that the sake of your purpose, you're starting with higher antibiotics. Mind you, if you have your antibiograms, what we're discussing about antibiotic empiric antitherapy, ampicillin doesn't come anywhere in antibiogram. It doesn't help actually. Piperacillin is 90% resistance. So you are going to just start for your satisfaction. It is not going to help you. If you see the
But baby
cultures,
is going to deteriorate.
yeah, if you see the cultures, if you see your own cultures in your hospital, what is the main common organisms? Klebsiella, E. coli, Acinetobacters, then are your strepto or fungus. So strepto fungus, they are not coming up at the birth, early onset. You have all 3 gram
What
negatives.
about late onset sepsis?
Yellow is same organism is same. Even in EOS or LOS organisms are same, except for the baby coming from the community, where you have to cover either staph, gram positive or fungus. If baby is very preterm, prolonged NICU stay, a lot of interventions, you have to cover fungus also in that case. UTI gram negative most of the time. If it's contaminant, yes, we can have others also. But remember, if you see any NICU, if you have done antibiogram, amikacin is okay, fine, 50-60%, but meropenem resistant in Klebsiella, ESBL, all these things, 80% are resistant. This is Indian statistics. This is Aurangabad statistics. Even our statistics is the same. So,
Okay. So,
so crux will be, you have to prevent infection.
Yeah.
Just want to give that message.
So now we have started antibiotics. Dr. Jalil, in short, what would be the duration of antibiotics? Approximately. Baby well, culture sterile. Stop antibiotics? Pardon? Okay. Baby is sick, culture is sterile, and CRP and our procalcitonins are also negative.
Review your diagnosis.
Very good. So, if 2 antibiotics have failed, review the diagnosis rather than changing to a third line antibiotic. Okay. The CRP and procal, since we are hell-bent on looking after them, I have started rising. And the baby is still sick. The culture is negative.
You can upgrade here if the baby is sick
So
and
upgrade
you are having
antibiotics.
CRP and procal
Yeah.
positive.
So look at complications. So the complications in the form of an abscess, deep-seated infection, a meningitis, UTI, an osteomyelitis, a candidemia, all those are likely.
Examine the baby again.
What about culture positive early onset sepsis?
So you continue at least for 10 days, and so these guidelines are categorically, they will never tell you that it is 10 or it is 14. Again,
Give you a duration.
10 days. At 10 days, you review what you are doing. If baby is absolutely normal taking breastfeeding, don't go ahead for 14 days.
Correct.
If baby is not, still baby is requiring oxygen, and you
Late
have given
onset
10 days,
sepsis.
then you give for 14 days.
Yeah, late onset sepsis,
Same, at least 14 days.
meningitis.
21 days at least. So that there also all the guidelines are coming down on the duration, but for practical purposes, continue 21 days.
Yeah, minimum. And what about UTI?
7 days and review.
Okay. So these are not based on evidence. These are empiric duration. Rightly said, look at the baby, look at the clinical course, make use of inflammatory markers to say there is no infection, and then you would be bold enough to say stop antibiotics. Monsoon is ongoing, but NICU has monsoon of antibiotics and it rains antibiotics in the NICU. What is the hazard of having indiscriminate use of antibiotics? Sachin, short term, and Om Prakash, long term. Briefly.
Hello, yeah. So we are aware that the use of antibiotics is very rampant everywhere, and there are a lot of short-term, long-term complications. First thing, there is a very high rampant epidemic of fungal sepsis in last few years in all the NICUs because of significant overuse of broad-spectrum antibiotic. Second, increase in incidence of NEC. There is a lot of evidence also that babies who have got more antibiotics develop NEC later on. Third thing, there is chances of mortality of these babies with multiple antibiotics is more. So in the short run, apart from drug resistance, which we all are aware, NEC, invasive fungal sepsis and mortality is high.
What long-term complications we expect?
So there is a good study done in Mayo clinics where they observe the long-term complications to the baby that were, there is a higher risk of allergies, asthmas to these babies. there is a good observation that these babies have got a obesity in future, and then obviously sugar imbalances, the diabetes is on a higher side for these babies. And as we know in our clinical practices also, the preterm babies who are there in the NICU for a longer time, on follow-up also we see there are a lot of emotional disturbances that they stay, and higher the course of antibiotics for them, there is a gut-brain axis that also gets disturbed, and there is some evidence that says that they have got a higher chances of attention deficit hyperactivity syndrome as well.
So misuse or disproportionate use of antibiotics is definitely harmful to the baby, both short-term and long-term. And imagine a baby who has been there, instead of saving the baby, we will leave behind this baby with sequelae which will be there lifelong. So at this stage, we change gears, and Sunil had said the best way to treat infection is to prevent it. Let me just start with this is the NICU we have. Which are the highest contaminated places in the NICU? Jalil?
Doctor's hands.
Sam's?
Doctor's hands.
Doctor's hands. Okay, good.
Yeah, genuinely.
Yeah.
It has been
What
proven
else?
by this
Yeah,
thing.
what
Then
else?
apart from that, the environment. It is the first is the base in which we think of. The where the baby is kept, the area where the babies are touched upon, and most importantly the IV lines. So the last point which we were discussing about, giving more antibiotics means you are invading the skin barrier, and that's why you should use less
So
antibiotic.
this
And the
brings
same
me
thing
to
here.
Sunil. Briefly tell us how we can improve the compliance of hand hygiene in the NICU.
Okay, so improving hand hygiene compliance is actually an ongoing process again, and it's one of the most important. Everybody should take up this project, like improve the hand washing compliance in the NICU. So if you see the slide, person, place, and procedure, everything should be in a place. You see the education, training, display, reminders, monitoring, feedbacks, places like access, everything is there in place. What I observed personally in NICU, like shouting at the staff or just temper tantrums, nothing is going to help. Train them and encourage them. Rewards, awards, personal communication with the staffs where the compliance is poor. That can be done either by the CCTV or personal monitoring the patients. If you have good staff, if you've seen the airports again, what we are practicing that same thing. In my NICU, like we are putting the board, like best staff or the best compliance of the hand washing. So that helps. Positive encouragement is going to help a lot in your hand washing compliance. You have individual also, you can have the percentage of compliance. Even doctors, staff, residents, Maushis, Daya, everybody's compliance, and review it. In infection control committee meet every 2 weekly or 1 weekly or monthly, you can have that percentage statistics. Now, if it is not improving, you can do all these bottleneck things. Like, where is the problem? You can sit with them. Again, if you want to improve the hand washing compliance, it is not one way it's going to help you. Sit with the staff. You are a grade 4 worker, you have to sit with them. What is their problem? Why they are not washing hands? And if you see, like, if you're the busy unit, like in a GMC or anybody is there, and if there's no manpower or manpower shortage is there, the basic concept of improving any quality, like hand washing, first thing you should have adequate staff also. So that also should be done.
So take all the stakeholders together and lead the team by example. Okay, we will skip this. I want you to talk about low-cost interventions, because these are something which is doable for each one of us. So Dr. Jalil, could you...
Patient ratio 1:1 if there is multi-drug resistant infection or proven sepsis in that baby, 1:1. 1:2 if common organism and common sensitivity patterns are there. 1:3 if you are suspecting but there is nothing proven. So these are there is nothing black and white, but this is how you treat. Or if you think that clinically babies are stable, what is spoon chammach wale 3 bच्चे एक साथ दे दिए किसी staff को, then one baby is on CPAP, one baby is on oxygen, can be given together. So you decide your own NICU protocol, but thumb rule is that if multi-drug resistant organism is there, 1:1 ratio, no escape for that. Yeah. The guidelines say from 4 to 8 feet, but in general 4 to 6 feet should be okay. Again, it depends on your own this thing. Disposables, try to use...
Don't compromise.
Don't compromise. Try to use as much as possible. Actually,
Should
it
I
is going to
invest in
save the
laminar
money.
flow?
Yes, definitely. Every NICU if you say that you have NICU, you should have a laminar flow.
The single most factor which has been known to prove hospital infection is your crowding and nurse-patient ratio. These are under-recognized, underappreciated. Rather than investing in technology, invest in resources. That's the message that we should keep in mind. And what about these bundles that we talk about? And what do they exactly mean? And how do I implement them?
Okay, VAP and CLABSI. This is ventilator-associated pneumonia and central line associated bloodstream infections. If you see the bundles, basically the common interventions, like list of the interventions which you can do to prevent this ventilator-associated pneumonia or central line associated bloodstream infections. The common practices remain same: hand washing, aseptic techniques. Don't do unnecessary interventions. If central line is required, then only it should be there. If not required, remove it. ET, if it is required, it's okay. If it can be extubated non-nasal, it's fine. Suction not required, don't do it. Head elevation, good physiotherapy, oral care, your staff handling. Unnecessary interventions, if you avoid stickings, even ET stickings, unnecessary manipulation of the ETs, all these things going to increase the infection in the even condensation which is happening. Tubings, you are in like disposables we were discussing. If you're too long, you're using tubings. That also can be helpful. Change the water which is there in the humidifier frequently. You have filters in the telic just to prevent the VABs. So these are the bundles which can help you to decrease the VAB. Even the central and associated infections, same thing. More you are careful. It doesn't matter how qualified you are. But if you want to prevent these things, you have to be more attentive, more protocolized, and more concerned about that. Then only you can do it. And write down these things.
So the simplest way to implement what Sunil is telling us, use a checklist every time you have such an intervention. And lastly,
Indian Academy of Pediatrics has already given
checklists are there.
Download it and use
Lastly, there is huge role of mother's own milk. There is huge role of mother in the care of the baby. Just one take-home message from your side.
So most important thing what you can do in the NICU is to involve the parents, the mother for kangaroo mother care and give breast milk. Even the babies, the sickest one, if it is possible, you should try giving mother's milk. You should try feeding as early as possible so that a lot of complications or the advantages of breast milk is more of importance rather than an antibiotic. Mother's milk is going to be more useful.
There is dose-response relationship between mother's milk and the outcome. The earlier you reach 70 cc per kg in a preterm, the better is the outcome of this baby if you are on mother's own milk. At this stage, we will stop. One take-home message from each of our expert panelists.
After seeing the talk on, Everest climb by the sir, I remember his words on CBC, where we monitor the consciousness, the breathing pattern of the babies for breathing pattern, and C is the circulation, look at the perfusion.
So look clinically, look at the CBC, consciousness, breathing color, don't look at the labs.
Preventing sepsis is common. You have been listening to these things since last 20 years, but implementation is difficult. So try to implement the things, take 3 things from today's talk and try to put it into practice on Monday, Tuesday.
So narrow the gap between what we know and what we do.
Yeah.
Jalil, thank you.
Auditing. Your own NICU is a separate NICU from the person who has the NICU 2 kilometers away from you.
Very good.
Audit your own data. Try to write down your data. Work on that data. So auditing is the most important thing which I will try.
You don't have control over starting antibiotics. A lot of problems are there. Gray zones are there. You definitely can stop antibiotics if you stand at the bedside entity. And every round you ask, can I stop antibiotics? Clinically normal, lab normal, culture is normal, baby is doing good. Stop antibiotics.
So have an exit policy for antibiotics. So I think at this stage we will stop. Thank you so much. And my sincere thanks to our experts for sharing their knowledge.
Thank you for such a wonderful panel discussion. I request moderator and our esteemed panelists to proceed towards felicitation stage. Dear friends, I hope you all are finding Nashicon an invaluable experience filled with knowledge and networking opportunities. Our next session addresses an important aspect of our professional lives that we sometimes overlook, but it is crucial for our peace of mind and financial security. Professional indemnity, how much and why? It's my pleasure to introduce our next speaker, Dr. Nilesh Nafde, the founder and current president, ISA Kokon, whose areas of interest are anesthesia, radiology, and medico-legal subjects. So without much ado, please join me in welcoming Dr. Nilesh Nafde to the stage. I request chairpersons for this session, Dr. Kedar Malvatkar sir, Dr. Sucheta Malvatkar and Dr. Nitin Maikarkar. Please be on stage for the to chair this session.
So, with the scantiest statistics of the crowd at the end of the day, I start my topic. I hope I'm able to throw some light on whatever few listeners we have in the hall. I have been given a responsibility of speaking about the indemnity insurance, the 360 degrees view in 25 minutes. So I'll try my best. Indemnity, I'll go straight to the point. A promise to pay. What is indemnity? The simple English meaning of the word indemnity is a promise to pay somebody an amount of money if he or she suffers any damage or loss. That is what indemnity actually means. Or in other words, क्षति की पूर्ति के रूप में धन देने की वचनबद्धता. So the basic if and but is if there is a loss. And unless there is a loss, there is no compensation. So there is no indemnity if no loss. A person who has an indemnity insurance is said to have been indemnified. These are all certain terms which we need to understand. Friends, while I talk in the next 10-15 minutes, it is very likely that you will start feeling that you are listening to an insurance agent. But believe me, I am not one. I am a postgraduate doctor and I'm in practice for the last 26 years. And despite this caveat, I am telling you that all the things that I am going to speak and elaborate on are things which we all need to know. So all of us need to sound like an insurance agent when you go for an indemnity. So why are we discussing indemnity in such details? 5 reasons. First is Consumer Protection Act has been applied. That has made patients more aggressive. These kind of pictures are seen in every hospital, every town, every day. Too many agencies have got powers to show us the red card: Medical Council, Consumer Court, Civil Courts, Criminal Courts, Human Rights Commissions, and Competition Commission as well. Numerous insurance companies have introduced indemnity policy. All the logos that you have seen on the screen now, almost each of them has an indemnity policy. And courts and commissions have pronounced dreadful judgments. I hope everybody listening to me now is aware that the highest compensation awarded to a negligence case in India is 12 crores. So when litigations are raining, the only umbrella that can cover a doctor is the indemnity policy. A doctor who looks hale, hearty, beautiful and smart in his practice, when an indemnity claim strikes, the strike has the ability to convert him into a pauper and a very unhappy man. So whenever you receive a legal notice or court summons, or whenever you go through a litigation, these are two different things. Only receiving a notice and going through a litigation are two different things. In both the cases, you have 7 losses to incur. First is there is a dip in self-esteem, there is severe embarrassment, there is emotional stress, there is social gossip, your people, your neighbors, your colony people start talking about you, there is peer harassment, your own specialty peers also start talking about the failure or the mishap that has occurred in your place, and there is a huge amount of self-blame which literally demolishes your self-confidence. But all these 6 can be handled if you have a good mentation, you have good friends, and you have a good association in your case, you have a good local IAP, all those 6 issues can be handled. But nothing can, there is only one loss that can protect, that you can protect yourself from, that is financial losses. And how you can protect yourself from financial losses is by having a good indemnity policy. Now, there are innumerable terms related to indemnity policy, which I would like to tell you a few of them. Out of all the people here, may I please ask you for a raise of hand, how many of you have an indemnity policy? Wonderful. So that's almost more than 90-95%. Thank you. Now, I will like to enumerate certain terminologies related to indemnity insurance, and I will ask something related to that later. I call it the indemnity jargon. The terms are indemnitor, indemnity, AOA, AOY ratio, retroactive date, nose coverage, tail coverage, claim merits basis, and occurrence basis. Now, of all those people who raised the hands, how many of you know the meanings of these words? None. Wonderful. So if all of you have policies, I am sure you must be having bombastic policies of 50 lakhs, 1 crore, or maybe more than that also. And if none of you don't know of any of these words, then believe me, you are all nothing better than this man, because only you feel that you are covered. Only you believe that the policy that you have in your cupboard at home protects you from indemnity claims. So I will like to elaborate all those terms one by one so that you go home wiser today about indemnity at the end of my talk. Indemnity, please note the spelling, it's different from the TY indemnity. A person or a doctor or an organization held harmless in a contract is called as the indemnity. So in our case, the doctors are the indemnities. Indemnitor is the party or insurance company which holds harmless a person or organization in an indemnity contract is called as the indemnitor. Please note the difference between the word indemnity and indemnity. I hope there is a clarity on the terms indemnity, indemnity, indemnitor, indemnify, and indemnification. So with this, we will proceed further. Limit of indemnity. We all need to understand every indemnity policy has a limit. The sum for which you are insured is an indemnity policy. So when you sit with friends and you say, "Mera 1 crore ka hai ya mera 50 lakh ka hai," so your limit of that indemnity is 1 crore or 50 lakhs. The other definition is maximum policy amount in an indemnity policy is the limit of indemnity. But there are two caveats to understanding the limit of indemnity. You need to know two more terms. One is AOY limit and the other is AOA limit. Do you know about this? Okay. Now, mera 1 crore ka policy hai does not mean that any claim slapped against me, any compensation granted by a court up to 1 crore will be met. Why? Because of these two terms. AOY limit is total limit of the indemnity policy per year. AOY stands for any 1 year. Total limit of the indemnity policy per year, which means mera 1 crore ka policy hai, so in 1 year I am expected to be compensated for 1 crore by the insurance company. That is AOY limit. But there is something called as AOA limit. Maximum sum you want to be paid per accident. You want to be paid, which means you choose it. It is not the insurance company kuch thopti nahi hai apne upar. They don't force anything on you. You choose a AOA limit, which means you want one accident to be covered in that 1 year and your policy is 1 crore. So it means that you want that accident to be covered by 1 crore. You want 2 accidents to be covered, then it means that you are allotting only 50 lakhs per accident. Your policy is of 1 crore and you have asked for an AOA limit of 2. तो 2 एक्सीडेंट कवर चाहिए मुझे 1 करोड़ में, तो इसका मतलब आपको एक केस में सिर्फ 50 लाख का कवर चाहिए. तो आपका 50 लाख का पॉलिसी है, कवर पॉलिसी 1 करोड़ का है लेकिन कवर 50 लाख का है पर एक्सीडेंट. This is how it differs. This is how it gives rise to frustrations in indemnity claims. Okay. Next. So you have, I will explain this in a little more details. You have a 1 crore indemnity policy. You believe that any compensation below 1 crore will be met by your indemnity insurance. So you make a claim. But what happens after you make a claim? You get back an answer that your claim has been denied. Now why this happens? Because just now what I told you, AOA ratio is 1. The second is validity. Validity of an insurance policy, validity of the indemnity policy. Now as soon as I say this, I am confident each one of you must be thinking 1st January to 31st December, that is the validity, the dates. But there is much more to validity than date, I will like to tell you. In order to understand what I am going to say further, I will explain this with the help of a pig. The indemnity policy is a pig, and the first arrow is when the policy begins, and the second arrow is when the policy ends. Okay? When you buy the policy, that is the first arrow, and when the policy is stopped, for whatever reason, let us say policy band ho gaya, so that is the second arrow. Now this is the main part of the policy, and this is the nose area, and this is the tail area. With the help of these terms, I am going to explain further. In order to explain what is nose coverage, I'll ask you a few questions. Here is a young doctor who has started practice 8 months ago in Nashik. Somebody tells him about an indemnity insurance. He decides to buy a policy when he is 1 year into practice. 1 saal baad, he says, I want to buy a policy now. Can he be indemnified for the bygone 1 year of practice? What is the popular answer? No. The answer is no. It is a wrong answer. Can he be indemnified for the bygone 1 year of practice? The answer is yes. In other words, can the period before buying a policy be covered? वो first arrow के पहले वाला nose area. Can that be covered in the proposed policy? The answer is yes. But so that is called nose coverage. The feature in an indemnity policy that covers professional acts prior to the purchase of the policy is called as a nose coverage. How much prior period is covered is stipulated in the policy document. So one person can have a nose coverage of 6 months, another one can have a nose coverage of 1 year. But you have to pay. 6 महीने के लिए अलग पेमेंट करना पड़ता है, 1 year के लिए अलग पेमेंट करना पड़ता है. So besides the policy value, you will have to pay something more for the nose coverage. So any newcomers in your branch, if they want to buy an indemnity policy, their policy can be backdated provided they buy a nose coverage. When you bought an indemnity policy, had you known this, you could have also spoken to the agent and asked for this. Unfortunately, we are not educated on the various nitty-gritties of an indemnity policy, because of which we don't ask for these questions. Next. Okay, now so you know this, now let us go further. Tail coverage. Similarly, jaise the feature in an indemnity policy that covers professional acts even after the policy is discontinued, policy is cancelled, or policy shifted elsewhere, is called as tail coverage. Simple, like nose, right? So let us go further. Now I will tell you 2 different terms related to an indemnity policy. First is occurrence-based policies. What are occurrence-based policies? The policies which cover incidents that occur when the policy is in force, irrespective of when the claim is made or when the case is filed. I will rephrase this just to make it a little simpler to understand. Whenever a mishap happens, the policy has to be in force. When the complaint is made is immaterial, when the police case is filed is immaterial. So even if the case is filed after the policy has ceased to exist, if the policy honors the commitment, it is called occurrence-based policy. जब occurrence हुआ, तब policy force में थी, हाँ थी, so it will be honored. This is called occurrence-based policy. Even if tenure is over or policy has been cancelled, claims are honored if incidents occurred when the policy was in force, which means that they are long tail policies. सेकंड एरो के बाद भी कवरेज चालू है उन घटनाओं के लिए जो उसके पॉलिसी फोर्स में होने के दौरान घटी हैं. सो द इवेंट्स व्हिच हैव अकर्ड इन द मेन बॉडी पार्ट ऑफ द पॉलिसी, इन दिस हियर अगेन, पहले और दूसरे एरो के बीच में जो कुछ घटा उसका कवरेज सेकंड एरो के बाद भी चालू रहेगा, उसको बोलते हैं ऑकरेंस बेस्ड पॉलिसी. दिस इज द बेस्ट. दिस इज द बेस्ट. नन ऑफ यू नोज whether your policy is occurrence based or claims made. We need to know that. Claims made policy is the second type of policy in which the policy is required to be in force when the incident occurs as well as when the claim is made or the complaint is filed. So it means that policy should be in force always. जब घटना घटती है तब और उसके बाद जब कंप्लेंट होती है तब भी. Because okay, now I will elaborate further. So it means that in a claims made policy there is no nose cover period and no tail cover period. जब पॉलिसी का मेन पार्ट है वही होगा तो पॉलिसी ऑनर होगी, नहीं तो नहीं होगा. सो in order to understand, this is how main body of the policy should be linked to the main body of the next policy, should be linked to the main body of the third, fourth, fifth, and so on and so forth. So every year policies have to be timely, punctually renewed. There is no tail coverage. So this is what a claims made policy is. Now let us come to the next term. So now you have understood that your policy, if it is claims made, it will be invalid if it has ended and the claim comes after that. But if it's an occurrence based, it will be valid. So validity is not only dates, it has so many other things. Similarly, validity is something to do with AOA, AOY ratio as well. Now, I told you AOA is any one accident, AOY is any one year. I'm rushing a little bit because time is less and I want to cover a lot of things. Indemnity policy, I'm going to give you an example of a doctor. I'm going to say you while I narrate this because you are a doctor. I'm going to telling you about your policy. I'll tell you that about a story of 2 claims, 2 compensations slabbed against you. Indemnity policies of 1 crore. You have been slabbed a 1 crore rupees compensation in the first case. I'm going to tell you 2 cases in the same year. ठीक है, ऐसा मान के चलते for example's sake. So 1 crore compensation has been slabbed. AOA AOY ratio is 1:1. 1 crore will be paid by the insurance company, correct? Okay. AOA AOY ratio is 1:2. So insurance company will pay only 50 lakhs. I'm just taking an example to make it more well remembered. Now in the next third example, AOA AOY ratio is 1:4. Court has slapped a compensation of 1 crore. So insurance company will give only 25 lakhs and you will have to foot the remaining 75 lakhs. You understand? This will give rise to huge frustration. You will say, I am buying an indemnity policy for the last 25 years और अभी मेरे को 75 लाख रुपया भरना पड़ रहा है. याला क्या अर्थ है? But the fact is that you have never studied your policy. That is why this has happened. Okay, now again in the same year another claim is made against you. पहला वाला हुआ है, वो claim settle हो चुका है. Another claim is made. Indemnity policies of 1 crore. You have been slabbed a second order of 50 lakhs. AOA AOI 1:1. आपका पिछले पॉलिसी में 1 करोड़ insurance company has already paid. This time there is a 50 lakh compensation. So who will pay? Answer is you will pay. Insurance company will pay nothing. If the AOI would have been 1:2, पिछली बार insurance has paid 50 lakhs. Oh my. Second claim of 50 lakhs. Who will pay? Answer is insurance company. Because 50 lakhs. You understand? Now, if the AOI ratio is 1:4, last time company had paid 25 lakhs, you had paid 75 lakhs, this time 50 lakhs claim. Now there is a second claim of 50 lakhs. Insurance company will again pay 25 lakhs and you will again pay 25 lakhs. Is this clear? Okay, now I'll go further. AOI ratio of 1:5 and 1:6 does not exist in India, which means that the IRDA, the Insurance Regulatory and Development Authority of India, believes कि अगर आपको लगता है कि आपके ऊपर एक साल में 5 या 6 केस हो सकते हैं तो आप प्रैक्टिस बंद कर दो. Okay, so another term I want to explain to everybody. You stop practice in June 23, you start enjoying the retired life, and since you have stopped practice, you don't renew your indemnity policy, and then a claim comes 8 months later about a case which was conducted by you in May 23, 1 month before you retired. So if yours is a claims made policy, जब claim किया गया, claims made policy is not occurrence based. अब भी policy force में होना जरूरी है, आपने उसको renew नहीं किया है. So your indemnity policy is invalid. But at the same time, if for the same incident you have an occurrence based policy, your policy is valid. Have you understood? I have tried to tell you what validity is. So what you need in this case is a runoff cover. What is a runoff cover? You want to stop medical practice, you have a claims made policy, then for a valid indemnity cover after stopping practice, what you need to purchase is called runoff cover. I am stopping practice this month, I still buy a policy for 5 years. Provided you stop practice. You say I stop practice, you buy a policy and then you are caught treating some patients, your policy is null and void. But if you really stop practice and you have bought a runoff cover, 5 साल के policy के लिए 2-3 साल के premium में वो खरीद सकते हैं आप. Policies, companies have different schemes. They give you the policy for 5 years for a lesser fee. So if somebody says you were negligent and you are scared, you say I have retired, you should extend your indemnity cover by buying a runoff cover. Many complicated names for policies. Errors and omission insurance is also an indemnity insurance. So errors and omission insurance is same as professional liability insurance, same as malpractice insurance, same as indemnity insurance. All the 4 term green color words are the same. Now what does a policy cover and what it does not cover? Everything on the green surface is what is covered. Professional negligence is covered. Loss of data or documents. Patients का data loss हो गया, patient ने case किया, it can be covered under indemnity. Unintentional breach of confidentiality. Unintentional breach of confidentiality. I'll give you an example. I'm an anesthesiologist, that is why I have taken an anesthesia example. You are called at a Dr. Kamat's hospital for an MTP on Mrs. Rao, who happens to be the wife of your friend Vivek Rao, who stays and works abroad. MTP goes well, you ascertain the well-being of Mrs. Rao and depart from the hospital. A month later, you meet Vivek Rao at a Rotary Club dinner, and after exchanging pleasantries, you ask Vivek Rao, so Vivek, how is your wife? So he says, what's wrong with my wife? So he says, oh, just a month back, we had done a medical termination of pregnancy on her, isn't it? So there is total silence after that, which means that Vivek did not know anything about it. And now there is going to be a big furor in the Rao household. How many of you believe that what the anesthesiologist has done is wrong? How many of you believe? Asking Vivek Rao, how is your wife? Only one person, rest of the people feel it is right. Let me tell you, you are all in for a big indemnity claim tomorrow, because there is no business of the spouse also knowing about the other spouse, as long as there is not an express or explicit consent for disclosure. Okay, so the pregnancy of Mrs. Rao was a pregnancy out of wedlock. Mrs. Rao had faltered in a weak moment of loneliness. Vivek didn't know about it, and because of your disclosure, there is a big storm in their household, and now Mrs. Rao is going to slap a case against you for a 1 crore compensation. Believe me, this is a true case from Bombay, which I have quoted. All the names and everything has been changed. I'm just telling you, this is happening around us today. So you have to be very firm about what disclosures you are entitled to make and not. So I deliberately called it an unintentional breach of confidentiality. Only an unintentional breach will be covered by your indemnity. So your lawyer will have to work very hard to prove it in the court that this was an unintentional breach. Okay. Next. So if you give an interview in a court tomorrow, in a newspaper press conference tomorrow, that the deputy chief minister I operated upon yesterday has pancreatic cancer, this is an intentional breach. So then nobody can, your indemnity policy also cannot cover you. Defamation, libel and slander. Defamation of any type. There are 2 types: uttered defamation and published or written defamation. Libel and slander are the meanings, are the 2 words for the same. Defense cost. Defense cost means wakil ka fee. to defend you in the court, an out of court settlement. This is the most highlighted. You need to find out if your insurance policy allows out of court settlement. And if it doesn't, then I'll tell you, do you know why courts, policies don't allow out of court settlement? Most of the times indemnity claims or negligence cases run for 15-20 years, and after 5 or 7 or 8 or 10 years, there is a time when the patient becomes weak and there is a good time for an out of court settlement. But policies don't allow, insurance company says, no, out of court settlement, case ko pura hone do. Agar insurance claim, you are having sleepless nights for the last 7 years, you want to settle your out of court, but the insurance companies say no. You know why? Because the insurance company fear that their malpractice will begin where a doctor will hobnob with the patient, operate upon him, tell him to file a case against him, file for 50 lakhs, both will hobnob, he will make a claim of negligence against him, and the doctor and patient both will go to the court, they will do out of court settlement for 20 lakhs and divide between both of them. This is the malpractice which industry fears, because of which out of court settlements are not allowed. So they are not wrong. But yet there are policies in which out of court settlements are allowed. My policy gives me a right for out of court settlement. Does your policy do? Go and find out. What the policy does not cover: criminal acts, frauds and other violations of law, being under the influence of alcohol or drugs during providing medical services, intentional damage to the patient of well-being, being involved in a kidney racket and all that. No, not covered by indemnity. Loan liability, आपका कर्जा थका हुआ है और आपको लगता है इंडेमनिटी पॉलिसी से वो भर सकते हैं क्या, तो नहीं भर सकते. So another thing which an insurance policy should cover or must cover is, so what all it covers? It covers the compensation awarded. Compensation, court ने 10 लाख रुपया दिया 2010 में. The court has awarded a compensation of 10 lakhs in the year 2010. So that 10 lakhs insurance company will give. Legal expenses, उसके दौरान जो वकील का खर्चा आया, that also indemnity policy pays. And the interest liability on compensation, invariably you appeal in the higher court. तो वो 10 लाख final decision तक 20 लाख हो जाता है with interest. That interest also insurance companies pay. You must know this, that not only the awarded compensation, but the interest accrued on that compensation also insurance companies pay. Out of court settlement, insurance companies pay. And supplementary expenses. Now what are supplementary expenses? Air travel. You face a case which is heard in the Supreme Court or the National Consumers Disputes Redressal Forum in Delhi. You need to travel to Delhi. Who pays for the airfare? Believe me, all doctors are well-to-do. You don't need an insurance company to pay your Delhi airfare. But when an indemnity claim strikes, you are sacked from the hospital where you are working very unceremoniously. You are into private practice. You are not in the usual finances as you were before. At such times, even the airfare looks like a burden. So if the insurance company is going to pay, well and good, they should pay. And also a reasonable hotel cost in Delhi also can be paid by the insurance company. I think I need to rush because... So in Marathi there is a saying, you know, Kapila. There is a Kapila नावाची एक गाय असते. ती कशी असते? आखूड शिंगी, बहुदुधी, कमी हंबरणारी, कपिला नावाची पांढरी शुभ्र, गरीब व प्रेमळ ही गाय असते. पण ही जी कपिला गाय असते कुणी कुणाच्याही गोठ्यात कुणीही कुणाच्याही गावात बघितलेली नाहीये, कारण ही अंधश्रद्धा असते. Okay, so there is no such Kapila guy. It is only a myth. Similarly, a professional indemnity which permits out-of-court settlement, foods, air travel bills, includes hotel stay, provides legal help, covers AOI of 1:1, good nose coverage, cheap runoff cover, long tail coverage, all this at low premium. This is like a Kapila guy. This is mythical and fictitious. You need to find out what you want for you in your town, for your practice, for your specialty. If that insurance company gives you at least 80% of those requirements, it is a Kapila guy. It is a wonderful policy, go for it. Don't ask for everything, it is not possible. And the first and foremost, my take-home message today is, don't first dump the words premium kam chahiye. Dump these words. Premium kam chahiye, to policy bhi kam wala hi milega. Be willing to pay bombastic premiums. Now, I need to finish now, am I right? I am already exceeded time. Only a short 7 slides only for how much indemnity insurance is good insurance. Because we need to know determinants, what is your specialty, where is your area of practice, what class of patients you serve, how many patients you handle per annum, and what you feel could be the maximum compensation claim you may face. Okay? Do you know that the court ordered 11 crore rupees compensation in a case called Arundhati Saha case? Go and Google it, Arundhati Saha case. 11 crores. Court ordered 6 crores, उसके ऊपर ब्याज पकड़ के 12 crore रुपया हो गया. In that, the patient had sought 200 crores compensation. So, लोग क्या मांग सकते हैं, आप सोच भी नहीं सकते. तुम्ही कल्पना नाही करू शकत की लोकांची काय मागण्याची ताकद आहे. So, you must know District Consumer Redressals Commission, Consumer Protection Act has been amended in 2019. Before that, the district court had only 20 lakh rupees power. नाशिकमध्ये झालेली केस, पेशंटला माझ्यावर, मी नाशिकमधला आहे, माझ्यावर केस करायची असेल तर त्याला नाशिकमध्ये केस करायची असेल तर त्याला 20 लाखाचीच करता येत होती. त्याला जर 50 लाखाची करायची असेल तर त्याला मुंबईला जावं लागत होतं, बिकॉज ही हॅड टू गो टू द स्टेट कॅपिटल. बट इन 2019 द लिमिट हॅज बीन एक्सटेंडेड टू 1 crore. त्यामुळे नाशिकपासून 30 किलोमीटर लांब राहणारा, गावात राहणारा गरीब माणूस सुद्धा तुमच्या विरुद्ध 1 कोटीची केस नाशिकमध्ये बसून करू शकतो. He does not have to go to Mumbai. So suing you for 1 crore has become very easy now. Besides, that is 1 crore is up to, the district is up to 1 crore. State, 1 crore to 10 crore, limit of state. And National Consumer Court, limit is about 10 crores. So if anybody wants to sue you for more than 10 crores, it cannot file in district court, cannot file in state consumer court, he has to go to the National Commission. And most importantly, the consumer court fees, 10 कोटीच्या वरच्या क्लेमला सुद्धा कोर्टाची फी फक्त 7,500 रुपये आता गेलेली आहे, विच इज व्हेरी चीप. सो टू सू यू फॉर 1 crore ऑल्सो इट इज व्हेरी चीप. टू सू यू फॉर 10 crores ऑल्सो इट इज ओनली 7,500. It is a it is a legislation which is heavily tilted in favor of the patients. So litigant-minded patients are finding it very easy to sue you. So my recommendation is indemnity cover of 1 crore minimum, whatever be your specialty, whatever be the area you practice. Best insurance company for insurance is company X. Sorry, ऐसा कोई जवाब नहीं है. You have to find out, because I know after this I am going to receive phone calls from Nashik. I do receive. कौन से company का लूँ? तो there is no answer Bajaj का लो या ICICI का लो. Find out, call the tie wala, ask him what you are going to give me. Are you going to give me AOI ratio? What is this? What is that? Pucho, and then decide what is the best policy for you and buy that. So I'll end with a couplet. Chintaniya hi vipadam adadeva pratikriya na kup khananam yuktam pradipte vandhina gruhe. The answer is, the meaning is, chintaniya means to think, vipada means calamity. To think of the calamity before. Adadeva pratikriya is the perfect reaction. Pratikriya means reaction. Na kupa khananam yuktam. Na means no, kupa means well, khananam means digging, and yuktam means useful. Na kupa khananam yuktam pradipte vandhina gruhe. Vandhi means fire, gruha means home. So there is no point digging a well when your house is already on fire. Thank you. And don't blame me for rushing, don't blame me for speaking fast. You have to blame the organizers. I have been only 20 minutes, that too at 1 hour and 1.5 hours late. If you feel you want me to enlighten you further on this, ask them to call me for a workshop on indemnity insurance. Thank you very much.
Thank you sir. Thank you for throwing light on this topic and educating us on this important topic. I request speaker and chairpersons to proceed towards felicitation desk. Our next session is quite unique and extremely practical, touching on an aspect that many of us might not have think about it until we are faced with it. As someone says, मराठीमध्ये असं म्हणतात की शहाण्या माणसाने पोलीस स्टेशन आणि कोर्टाची पायरी चढू नये. But what if we have to face it? How to handle ourselves in the police station? It's my honor to invite and introduce Advocate Sachin Bhate, practicing at Nashik District Court, a resource person in POCSO and crime in various schools, to throw a light on this important topic. Please join me in welcoming Advocate Sachin Bhate. I invite chairperson for this session, Dr. Anil Kasliwal sir. Dr. Subhash Kashyap sir, Dr. Manaklal Chopra sir.
A very good evening. Thank you to the organizers for having me here. The scanty of the audience speaks of the seriousness involved with the aspects of doctors getting in trouble. As advocates, we come into play when the doctors unfortunately fail to record their documents properly. Now, doctors have been facing a horrific time. Like contemplated by the earlier speaker with respect to indemnities, we have issues pertaining to the Consumer Protection Act, which came into foray, and the doctors for the first time became responsible on account of negligence caused at the ends of the services which were being rendered by them. Now, necessarily, when we're dealing with aspects of the Consumer Protection Act, we are required to understand that Consumer Protection Act deals with the civil breach with respect to negligence. Now, basically, the word negligence will have to be bifurcated into two separate shelves. The first shelf would be the aspect pertaining to the civil damages, which is negligence per se, wherein you can be dragged into the courts, civil in nature, wherein the compensation would be the ultimate orders which could be passed against you. But then we have a criminal breach. Now, this is where, unfortunately, we as practicing doctors are faced with aspects pertaining to having to walk into a police station. Now, this is where we all are required to be wary of. Doctors are supposed to be the superhumans or the superheroes who do not wear capes but wear gowns. But over a practice of 27 years in criminal law, what I have discovered is doctors need not only know medicine, they need to be good clerks. They have to be very careful about the documentation part. And documentation is one gray area that the doctors have failed time and again. We have seen doctors practicing in isolation individually. We have seen doctors practicing in terms of medical establishments, in partnerships, in association of persons, in companies, or in LLPs. Now, technically, it nowhere lowers the risks involved. What we only do is, when we have a company which is supporting the administration and infrastructure, while the doctor concentrates on the medicine, it is the responsibility of the management to make sure that the documentations are maintained in order. We have one of a very alarming case which came to foray in Pune. It was under PCPNDT, wherein one of the companies, I would not go into naming the company, but we now have a precedent which has been set that the company administrators were held responsible along with the concerned doctors on account of certain breaches committed under the PCPNDT Act. But independently practicing doctors have to be very careful. In course of my practice, what I have come across is that doctors need to understand the importance of the word silence. Your best friend is your worst enemy. We are dealing with Nashicon, and more particularly with respect to the Pediatric Association. Now, Pediatric Association are required to take into consideration the aspect of the document keeping. The second slide, please. Now, the methods of the record keeping are required to be considered. We are required to understand that the initial phase of maintaining records were done manually. But over a period of time, we have grown more prone into the artificial intelligence. We have somehow got friendly with the computer devices, and we have started storing the information required. Now, methods of keeping the record make it even more important. As a practicing advocate, which I keep telling my friends who are into the medical fraternity, is that while maintaining records, kindly understand that we are also allowing footprints to remain into your system. If we are not to maintain our system and feed the information periodically, and one fine day we decide to brush up and feed the information, the details of the encrypted data which is found on the hard disk gives birth to the creation of the document. Now, if you already find yourself vulnerable and you want documents to save you, and if you are to take this exercise of feeding the information in form of encrypted data on your system, one fine day, the creation of the concerned data is going to haunt you in future. because technically the document created would be the document created as per the encrypted data fed into the computer. Now, when we are dealing with pediatric association, now I will not consume time with respect to PCP entity and other aspects, because that would not be our cup of tea as on today. So while dealing with indoor patients and OPDs, the Bombay Nursing Home Act requires that the details or the referral notes are required to be maintained for 3 years. Now, OPD and endo patients both. Now, it is incumbent to understand that while maintaining the concerned data in forms of the referral notes, the discharge notes, the medical notes with respect to the aspects regarding medication provided to the concerned patient, the entire details have to be maintained methodologically and chronologically. Now, there are certain documents which need not be provided to patients as a matter of right unless you are summoned by the court. But then there are certain documents which are required to be handed over pertaining to the discharge summary. Now, discharge summary is something which I have always seen in the last 27 years of my criminal practice, that the doctors unfortunately tend to get lazy in preparation of the discharge summary notes. And these notes unfortunately never tally with the medical reports of the medication being provided. And in case of a contingency, these documents come back to haunt you. Now, this is one area that we as doctors have to be very careful about: maintenance of documents. Documents are your first and last shield of defense. My learned friend who delivered the lecture prior to me talked about aspects of areas not covered under the indemnity procedures. This is the gray area wherein we are talking about gross negligence amounting to criminal negligence, and that is where punitive punishments can lie. Now, the earlier offense under the Indian Penal Code, which stood prior to 1st July 24, was 304A, which talks about death of an individual on account of a rash and negligent act not amounting to murder. Now with BNS, that's the Bharatiya Nyaya Sanhita, we have section 106 which has come into foray. Now, one good thing which has happened with this particular section is we have two bifurcations which have been made under 106. Now, 106 of the BNS now, which came into foray from 1st July 24, states that on account of a death of an individual amounting to rash and negligent act, the punishment prescribed is 5 years. But this first part of 106 does not take into ambit medical practitioners. The second clause of 106 takes into foray the aspects regarding medical practitioners. Now here the government has been human and sensitive, because for the first time we have that any registered medical practitioner, while performing a medical procedure, and if is found to be grossly negligent, which results in a death of an individual, he shall be punished for a term which would be for 2 years. Now this is made bailable, though cognizable. Cognizable म्हणजे मी पोलीस स्टेशनला गेलो तर गुन्हा नोंदवला जाऊ शकतो का? Can an offense be directly registered or not? Now here we are required to understand, for the first time the government has been sensitive. It does not only make this offense bailable for the doctors, but under the provisions of section 185 of the code, now the new Bharatiya Nyaya Sanhita, त्याच्यात त्यांनी असं म्हटलेलं आहे की if an offense is registered by the police authorities, the allegations need to inspire confidence with respect to a cognizable offense, which is been alleged to have been committed. But now this particular Sanhita also says that when we are dealing with an offense against medical fraternity, more particularly pertaining to medical negligence, a preliminary inquiry is required to be conducted before registration of the offense. Because most of the times what happened was, prior to the Jacob Matthews judgment, now Jacob Matthews judgment is a landmark judgment which is now brought into foray, that unless and until the 5 committee members of the medical experts is convened, and this particular committee believes that a doctor has been grossly negligent, which has resulted in the death of a patient whom the medicine was being administered, the offense cannot be registered against him. Now there have been nth number of cases prior to 1st July 24 that the offense have been registered, but the committee reports have not been available. Now that gives rise to various aspects of moving discharge applications, saying that it would be a futile exercise to go ahead with the trial unless and until there is a committee report. But then unfortunately, we stand on either side of the fences. As practicing advocates fighting criminal matters, we stand on either side of the fences and we cry our throat hoarse. Now there is where you become susceptible. Now, the new law requires a preliminary inquiry to be conducted after allegations are made in writing by the victim or the relatives of the victim with the nearest police station. So now the new law requires that no offense can be directly registered against a medical practitioner on account of gross negligence amounting to death of a patient. Now, the other aspect which was touched by the previous speaker was with respect to confidentiality, with respect to maintenance of documents. He gave an elaborate example of Mr. and Mrs. Rao and the concerned doctor. Now that was fascinating because that is the time I was sitting and I realized that confidentiality is one aspect that the doctors, not the doctors alone, most of the professionals, including practicing advocates who tend to flaunt their clients, patients as trophies and talk about their achievements in public at large and get into a lot of trouble later. So like he used the word, the blabbermouth. Blabbermouth is one gray area that one has to be very careful about. The new law which is being promulgated is the Data Act with respect to electronic mode of conversations, the new WhatsApp issues, that the data encrypted available with us cannot be circulated except the author, and the vulnerability of the person circulating the same is questionable. Now, while we are dealing with what is required of a doctor when he is required to go to the police station, the first thing the doctor needs to do is he has to be a good listener. I have always maintained that doctors hit the panic button on the foundation of the term goodwill, and they fear it the most. The first thing that the doctor wants to do is, let's settle the matter outside the court, irrespective of the amounts involved. I do not wish to face litigations. The moment you hit the panic button, you are unfortunately allowing the police authorities and the complainant to win even before you could start. I have always believed that doctors are a part of the noblest profession. We could be held responsible for negligence in documentations which can be used against us, but the laxity in maintenance of documents cannot reflect upon gross negligence. And this is something that the doctors have to be very careful about. They cannot get carried away only on account of a threat of a litigation. Because what the Bolam test is all about, Bolam was one of the persons who had volunteered to be a part of a test carried out against him to justify what negligence is all about. Now, the Bolam test requires that even a doctor is required to be held responsible to his ordinary sense of prudence. He cannot be a master of all trades. He could be a jack of all trades, but he need not be a master of all trades. So basic. Now this case pertaining to the Jacob Matthews judgment, and subsequently while we were dealing with the aspect of negligence, that when there is a conflict in opinion with respect to doctors. Now luckily, what is relevant is we find less of distress amongst doctors. We find less of doctors coming out in open testifying against their own fellow men. We have a committee in place which protects the interests of doctors at large. Now, I use this very cautiously, very carefully, because we are walking the tightrope. The job of the committee is not to pardon doctors, but the job of the committee is to understand the vulnerabilities of the doctor and distinguish in between the degrees of negligence. That in normal prudence case, what can be done? So now when we are dealing with aspects pertaining to police authorities, the first thing is, what is the nature of the allegation made against us? Whether the nature of the allegations create a sense of gross negligence or otherwise, and if it is only a belief without foundation, then this belief without foundation has to be dealt with iron hands and has to pass through the test of the concerned committee, who first has to understand allegations without foundation cannot be a reason for litigation against a doctor. Now, considering the new law, this offense is bailable. So, at no point of time can a doctor be arrested and kept away. So, the anxiety of a doctor walking to the nearest police station is something that he has to now realize. We are not untouchables. If I am summoned to a police station, I need not hit the panic button. You can have an advocate who can accompany you. I can understand the anxiety that goes along when the doctor is called or summoned at the police station. But the allegations made against him pertaining to medical negligence have to be substantiated with proof. Mere allegations cannot give rise to registration of an offense. Now, the most important part is, now with the new law, the doctors can also require that the police authorities necessarily should go through a preliminary inquiry, ask him to provide documents. The documents provided to the police station are required to be placed with them under confidentiality. And the moment the documents are provided, we need to have an acknowledgement from the police authorities that the documents have been submitted. And ideally, if we are dealing with a patient, an indoor patient whom we have handled sometimes back, and if the concerned documents provided to him should not be doctored later. I have found doctors at the receiving end because they do not realize that they have parted with documents to a patient, and later they have rearranged, rephrased, or doctored the medical sheets, the discharge notes, and the other available information. Please consider this. Not only could you be in trouble for negligence under 106 now, you could also be facing issues pertaining to forgery. So the doctors need to understand that these are things which go hand in gloves. So a doctor has to be very, very careful. I could survive a litigation based on documents which might not sound to be completely filled. That could be seen as a clerical error, and that could be used by your advocate while representing that the intentions of the doctor is to provide medicine and not to become a clerk. But if the doctors and the first documents are placed and which are in complete contrast with the documents already provided, we are in for trouble. Being at the police station, kindly realize that while working in an institution, we are dealing with pediatrics, we are dealing with surgeons, we are dealing with anesthets in course of an operation. The statements of all the doctors, whether it is the anesthet, the surgeon, the regular general medical practitioner, the owner of the concerned premise, and the establishment have to complement each other. Let there not be any rat race to save your own skin. What we have seen in the court is that when you hit the panic button, if the unfortunate event occurs on account of an aspect that the surgery was good, but the patient never came out of anesthesia, the first thing that the surgeon wants to do is, he says, the surgery was fine, I am not responsible, let the anesthet answer it. That is where the trouble starts. Because then, finally, we have various players who are involved, and these various players start shedding off responsibilities and holding the other third person responsible. Now, there is one particular law which the professionals need to understand. This was another highlight. This was the Prevention of Violence Against Healthcare Professionals and Clinical Establishments Act. So we have a central act and we have a Maharashtra Act in 4A. So this was to deal with issues pertaining to violence against the medical practitioners, their clinics and their establishments. Now this has been taken and is being dealt with iron hands. This is a non-bailable cognizable offense. If this amounts to violence, hurt, severe hurt, the grievous hurts, we have severe punishments which are involved. Now the doctors have to be very clear that you cannot take it lying down. There is nothing called goodwill. If somebody is to resort to violence and is to be violent against you or the establishment, let it not pass by. Because one wrong message can lead to further chain of events and further violent acts. What I have seen doctors is, I do not wish to get involved and entangled in litigation. I would rather square off the matter outside and not fight it out. My message to the medical fraternity is, when you know that the degree of negligence cannot be equated as a criminal negligence, let it not pass through. This also reflects on the indemnity aspect of the medical insurance that you so obtain from the companies. If you are in a position to successfully fight out a case filed against you, the insurance policy which continues will also carry the benefits regarding the same, because you would have proved not guilty for the civil or the criminal wrong, and you would have saved your skin. So doctors in police station, please do not get perturbed by the mere mention of the word police. Police understand little of medicine. They are playing mind games. Do not fall into the prey of the mind games. Because we have something which is very relevant, which I would want to end with. It is called mens rea. Mens rea talks about criminal intentions. So no doctor, while carrying out the medication, intends to cause loss to his own patient, understanding the vulnerabilities involved. So you can easily walk your way through. Do not get into a trouble by accepting guilt in writing. Time and again, I keep telling doctors, do not sign documents saying, assuming I am wrong, kindly let it pass through. We have seen in PCP-NDT cases wherein doctors immediately after the enactment have said that we wish to apologize for irregularities. If they have been found, kindly condone. This shall not happen again. And these documents have come to haunt the doctors as admission of guilt. So please, doctors, do not admit your guilt in writing unless you know the consequences thereof. Thank you.
Thank you, Advocate Bhate, for such a wonderful talk. I request the speaker and chairpersons to proceed towards felicitation stage. And with this, we conclude our first day of Nashicon 2024. See you all at Love You Zindagi at 7 p.m.